name is Dr. Shada. I'm a scientific and medical manager with Merck Foundation, and I shall be co-moderating this session today, along with my colleagues, Dr. Gilbert Militana from Burundi and Dr. Novia Dennis from Liberia. Merck Foundation continuously strives to improve access to quality and equitable healthcare solutions in underserved communities by strengthening the local capacities and enhancing the clinical management processes through its various scholarship programs offered under the Merck Foundation More Than a Mother movement. Merck Foundation offers hands-on training programs in fertility and embryology at its various partner institutions. Besides, it also offers scholarships in 42 critical and underserved medical specialties, including postgraduate diplomas and master's degree programs in sexual and reproductive medicine, women's health, urology, biotechnology, and clinical psychiatry, including others. You can visit our website, merck-foundation.com, to access the list of all available courses. We are also delighted to inform you about our very own Merck Foundation application, which is also available on the Play Store for Androids and App Store for iOS. You can receive timely updates on our various courses and other initiatives on your mobile devices by simply installing this application. Let us invite our first speaker for the session, Dr. Phineas Ospita from Tanzania. He is an obstetrician gynecologist, head of Safe Motherhood Program under the Division of Reproductive, Maternal and Child Health, Ministry of Health, Tanzania. His topic for the day is fertility care in Tanzania, prevalence, challenges, strategies, solutions, guidelines, and treatment options. Over to you, Dr. Phineas.
Good morning. Thanks, moderator, for the very kind introduction. As you said, my name is Phineas Ospita. I work for the Ministry of Health Tanzania and the Department of Reproductive, Maternal and Child Health as head of program for safe motherhood. And I'll be presenting, I see the technology has been. Can you help please? Yeah, it's working great. So I'll be presenting on fertility care in Tanzania. We shall see on the preference services available, strategies and treatment options. Okay, thanks.
Thank you.
Yeah, this is the outline. We'll see the prevalent challenges, the guidelines, the strategies around, and we see some kind of solutions. So, as in other countries, despite of the association with serious negative health impact and economic outcomes, infertility still is an marginalized issue as compared to other sexual and reproductive health services. The World Health Organization reports that approximately 1 in 6 people face this problem of infertility. And with the lifetime prevalence of around 17.8 in high-income countries and 16.5 in low and middle-income countries. And in Tanzania, the prevalence is around 16%, I think. So in Tanzania, from the Tanzania Demographic Survey, it estimated that the total fertility rate is around 4.8, and this is an increase from the 20 years ago. And the median age for birth interval is around 37.1 months, with the postpartum instability of around 10.2. The median age for the first birth is around 20 years, but we still face the challenge of teenage pregnancy, which is around 22% for those girls aged 15 to 19 years. And the modern contraceptive prevalence rate is around 31%. When we compare the total fertility rate by residents, comparing the rural and urban, generally we can see there is a straight decrease of the total fertility rate. I mean, the average number of children the woman will bear during the reproductive age. And we see it's low in urban areas, and it's high in rural areas, making an average of around 4.8. But generally, the total fertility rate is decreasing. When we deep dive into age specificity, we see the age of around 20 to 29, the peak for high fertility rate, and from the age of 30 to 49, the fertility rate is decreasing. And when we go deeper into regions, some regions has high fertility right? As you can see, other regions has around 5.8, while regions, especially those who are in the cities which are in the southern east, they have the lowest is around 2.8, which is in the city of Dar es Salaam. So this picture correct with what we saw, the low total fertility rate in urban areas. Of course, this is so obvious. The fertility rate decrease with age, and this is a report from the demographic survey. The education level increase, the fertility rate also decrease. As we heard yesterday from Her Excellency, the President of the United Republic of Tanzania, that we are in the struggle reducing the maternal mortality from the, again, which she reported from the demographic survey, from 556 to 104. But we still face the teenage pregnancy. And this is, we are so concerned with this because from the maternal perinatal death review, which we are doing, we still see a significant number of women who die within this age of teenage, as we know that teenage pregnancy is associated with obstetric complications, including difficult deliveries and maternal death. So in some areas, the teenage pregnancy is as high as 45%, and in other areas, it's low as low as 2%. Coming to the contraceptive use, generally, the use of contraception is increasing for the modern and traditional methods, but we still have the unmet need for family planning, which is around 21%. So this means we have married women who are not on contraception, but they still face the problem of getting pregnant. And this we care them through assisted reproductive technology services. Talking of ART services, in Tanzania, they started around 16 years ago in a private clinic. And currently we have the registered, the known 10 facilities, which are mostly in the cities of Dar es Salaam, Kilimanjaro, Mwanza, and Arusha. And these are the services which are provided: IUI, IVF, embryo transfer, and cryopreservation. So we see the need for RT increasing as time goes on, and some clients, of course, are not registered, are not captured in our national data warehouse, and they seek services from abroad, from India, Kenya, and the other neighboring countries. So currently we have developed the national guideline for IRT, but still the bill of law in Tanzania has not been endorsed by the parliament. And of course, the services which are available depends on the cause of infertility, ranging from basic fertility evaluations, medical treatments, and surgical services. As I said, 16% of infertility in Tanzania is a big challenge. But another challenge is the expense for the RT services. They're not covered by national health insurance funds. Most of our clients, they pay out of the pocket, and some services are still unavailable. And as reported from other literature, that cultural stigma is skewed to the women. In our clinics, men, they are still not agreed that infertility can also be a challenge with them. So lack of reliable data for RTs, especially on how we define success rate. We know success rise in the eye of the beholder. We clinicians, the way we define success may be quite different from what the client need, but even the data, they are quite challenging. Services for ART, they are not captured by the DISC Health Information System, which is our national data warehouse. So among the strategies, after formulating the national guideline, which will guide the provision of ART services across the country, but also I've recently constructed an IVF center at the National Hospital Muhimbili, and from the government scholarship and from other stakeholders, including Merck Foundation, we have been able to provide a scholarship for experts in the area of fertility. And of course, in collaboration with other private sector, private hospitals, these services has recently been improved, but we still have a gap to bridge. So as I'm summarizing, let us be reminded that infertility does not discriminate. Anyone can suffer from this dysfunction, and the prevalence we see show the need to widen the fertility services. And the solutions for prevention, diagnosis, and treatment, not only in Tanzania, but also in other countries, they are still underfunded. they are still they are not given that kind of priority as compared with other services. And social stigma and limited availability, of course, remain the challenges. In most countries, including Tanzania, treatment options, they are out of pocket. They're out of pocket, which means for the normal citizens like me, cannot be able to afford the services. So we believe that better policies and public financing can significantly improve the services. Thank you, moderator. This marks the end of my presentation. I submit.
Right. So our next speaker for the session is Professor Satish Kumar Adhika from India. He is the head of Center of Excellence in Clinical Embryology and coordinator at Center for Fertility Preservation, Kasturba Medical College, Manipal Academy of Higher Education, Manipal, India. The topic for his first presentation today is impact of oocyte abnormalities on ART outcome. Welcome, Professor Satish, over to you.
Thank you, Dr. Salaam. Very good morning, everyone, and my sincere thanks to my foundation for the invitation and the opportunity. I will take you through the topic, the impact of oocyte abnormalities on ART outcome. This is my conflict of interest statement, and the next 15-20 minutes, I will take you through the importance of the oocyte morphological variations and how to assess them, and whether these anomalies or abnormalities have any association with the patient pathology, and if we see abnormalities, whether to inseminate or not to inseminate, and finally, the how can improve or how can we manage or improve outcome, fertilization outcome when we have poor quality oocytes. Yeah. As we all know that oocyte is a driving force during the early embryonic development. If you look at the relative contribution made by the oocyte to the successful live birth is much higher. It's about 80% compared to the contribution made by the sperm and oocyte, which are only 10 to 15%. Hence, it is very important to understand, know more about the oocyte in embryology practice. The human oocytes are different. They are usually formed during the fetal life. And during the follicular phase, the first few days of follicular phase, not many changes happen in the oocytes, except a small increase in the size. But the major changes happen at the time of maturation, when there is a trigger or ovulation, the final maturation happens. Until maturation, the oocytes are in GV phase, the germinal vesicle stage, which is the prolonged resting stage of the oocyte. And then what happens when there is a trigger, the maturation process starts, the GV becomes GVBD, the germinal vesicle breakdown happens, it becomes metaphase 1, and then becomes metaphase 2. The reason I'm explaining here, because the oocytes in the follicular environment, they have a limited ability to sense any kind of stress. If the follicular environment is not conducive, because patient receives supraphysiological level of gonadotropin, there are changes in the follicular environment, but still oocytes keep progressing from GV to GVBD and becomes M1. When it becomes M1, it realizes there is some problem in it. So it stops progression or delays the progression. So this could be one of the reasons for seeing the heterogeneity in the maturation during oocyte becoming. Oocytes are normally seen first time with the cumulus cells in IVF lab, COC or the cumulus oocyte complex. These cumulus cells are very important because they are the nourishing cells. They are derived from the granulosa cells, and they are responsible for the nutrition of the oocyte. They provide nutrition to the oocyte through the gap junction, and they control the metabolism. They control the maturation. They're very important. Hence, it is important to assess the oocyte, or I can say the oocyte, the cumulus assessment is an indirect indication of the health of the oocyte. Why oocyte assessment is important in ART? As we all know that the quality of the oocyte varies. There are variations in the quality of the oocyte. There are several factors influence the quality of the oocyte. It could be the pathology, ovarian pathology, or it could be the superovulation, or the progression of the follicle, if it is not synchronous, or even the trigger can have impact on the quality of the oocyte. So the assessment of oocyte is very important for embryologists to decide the time to inseminate. Can we wait for some time or can we inseminate immediately? And allow the time for maturation process. If they are not mature, we can allow them for maturation for some more time and then process for fertilization. The assessment also helps in identifying the anomalies in the oocytes so that we can select or deselect such oocytes for fertilization. The human oocytes, they show huge morphological variation. It's not that always we get beautiful oocyte like this. They're very heterogeneous. Ideally, it should be around 100 to 120 micrometer. They should have a very spherical structure, inclusive, they're very uniform, clear, colorless zona pellucida, the uniform translucent cytoplasm pre-inclusions, and an appropriate size polar body. And when to assess oocytes? Normally, oocytes are assessed at two different time points. As soon as we receive them, the follicular fluid, we assess them along with the cumulus mass. And subsequently, at the time of fertilization, we assess their nuclear maturity during ICSI. So conventional assessment depends on how they look. We look at the polar body, the perivital space, zona pellucida, cytoplasm, and also the shape and size. But there is also a possibility to assess some of the subtle or molecular aspects such as the proteomic analysis. We can also look at the calcium levels. We can look at the apoptosis, but these are quite invasive and they cannot be done in a routine embryology practice. So normally, the oocytes maturity is not 100%. So any stimulation cannot give 100% maturity consistently. You may get in few patients, but it is almost impossible to get them in continuously in your program. Ideally, about 15 to 25% of the retrieved oocytes are immature, and embryologists normally they are competent enough to identify the most immature and the post-mature, which is in the extreme side, which you can easily appreciate under stereo microscope. But the critical situation sometimes happens in between two images. You look at the cumulus mass, they are very nice, sunlight, sunburst appearance. They look normal, they look mature. But if you denude them, you don't see polar body here. That means it is metaphase 1 oocyte. What I mean to say is that the cumulus assessment cannot always predict the nuclear maturity. So this is the most immature stage of human oocyte. We call it a GV oocyte. You can see a clear bond with the germinal vesicle. And when the process of GVP, the maturation happens, there's a breakdown of the germinal vesicle. The membrane is not as clear as we see here. And then finally, within few hours, the oocyte progress to mature state, that is the metaphase 1. It's still in its immature phase. All right, here, this is the metaphase 2 oocyte, the most mature form. And normally what happens, seeing polar body in perivital space doesn't mean that it is in metaphase 2. If you look at the second picture, you can see polar body and the meiotic spindle when you look under polarized light. Whereas the third picture tells you there is a connection between the polar body and the meiotic spindle. That means it is not metaphase 2. It is still in the metaphase, the telophase of the first meiosis. It is not mature oocyte. And if you inject such oocyte, there's always the risk of getting the abnormal, genetically abnormal embryo. So the oocyte morphological variations normally categorized as the extracytoplasmic and cytoplasmic. The extracytoplasmic in the top panel, the abnormality seen outside the cytoplasm, whereas intracytoplasmic or cytoplasmic abnormalities are seen within the cytoplasm. The giant oocyte, the size of the oocyte is also very important. If the size is abnormally large, if it is more than 200 micrometer, such oocytes are usually diploid oocytes, and they should not be inseminated. As you see here, you can see two polar bodies in the giant oocyte. So such oocytes should be deselected from fertilization. The other important dysmorphism not very important. The common dysmorphism I can say is the ovoid oocyte. As I told earlier, the normal oocyte should be spherical in shape. The size becomes ovoid, the oval, and it is not good. It is normally referred in terms of roundness index. A circular one roundness index is 1, as and when it changes dysmorphic or elongated, the roundness index increases. And ideally, it is believed that if the roundness index is more than 1.5, it is not good. But good thing is that such oocytes do not compromise the progression and the quality of the blastocyst. Still, we can get good quality at the embryos and blastocyst from such oocytes. So these are some of the extracytoplasmic dysmorphism. I'll quickly take you through the zona pellucid abnormalities. So zona pellucid abnormalities may include the septum, duplication, and the discoloration. So normally we don't worry much unless the zona pellucida is really abnormal. Okay. So if, for example, the second image, you can see exceptionally thick discoloration. If you see such changes, it should be noted. And if you have the opportunity to go for assisted hatching in your facility, you can go with assisted hatching. The periovital space is also very important. This again reflects the genetic status of the oocyte. The periovital space should be appropriate. As you see here in the first image, the second one, you can see a large periovital space. It's a sign of over maturation, because if you see over maturation, if there is over maturation, the size of the periovital space increases. But also, if the culture medium in the lab is not appropriate, if the osmolality of the medium changes, then the oocyte shrinks, and then the size of the periovital space increases. So this also could be iatrogeny. And many times, the large periovital space is associated with a large polar body. So this is definitely not a good sign, and such oocytes should be deselected for fertilization. The inclusions, they are very, as you see, there are multiple, they look like the small bodies in the periovital space. Normally, we don't know what exactly is the reason for seeing the inclusion, and there is no need of counting them, but whether they impact on the fertilization, embryo development is not very clear. The polar bodies again reflect the quality. Believe that, as I told you earlier, the large polar body is suggestive of the genetically abnormal oocyte. Sometimes we do see fragmented polar body, as you see in the second picture. Again, it is not good for the oocyte. And the fragile oocyte means the membrane or the cytoplasmic membrane of the oocyte is very fragile. The embryologists don't feel any resistance during injection. The needle just goes in, and there is a risk of leakage. As soon as the needle is withdrawn, there is a leakage. It is because of the membrane fragility. And such oocytes should be handled very carefully in IVF lab. If you have the facility for piezo-ICSI, then you can minimize the regeneration in such oocytes. The cytoplasmic granulation is another most common abnormality we see. Ideally, the cytoplasm should be very homogeneous. The mild granulation, as you see in the second picture, is also fine, because if you see mild granulation, that means it's a transcriptionally very active. But if we see severe granulation, highly granular cytoplasm, it is not good. That means the oocyte is experiencing severe stress. It is trying to come out of it, and eventually it may lose its viability. But we are more concerned about the central granulation. If the granulation is localized in certain areas, it is not good. We call it as clustering of the organelle. And such oocytes, normally when you do ICSI on such oocytes, we may not get fertilization, or there could be poor fertilization, the poor implantation rate, and also there is an increased risk of aneuploidy in such oocytes. Another important abnormality is SCR disc, or smooth endoplasmic reticular disc. We are concerned about that because there are reports saying that the oocyte with the smooth endoplasmic reticular structure have increased incidence of fetal anomalies and the imprinting errors. But there are studies that have shown that there is no conclusive evidence of SCR on fetal anomalies and imprinting errors. But normally in IVF lab, if you see SCR cluster in the oocyte, the sibling oocytes also should be looked for SCR cluster. You can still inject, you can still fertilize them, But those embryos derived from SCR cluster should last one to go. Don't select such oocytes in the initial attempt for transfer. The vacuoles, the small vacuoles in the oocyte are fine. If the vacuole size is more than 18 micrometer, it is not good for the oocyte because they can lead to displacement of the cellular organelles and which can lead to a risk of abnormalities and poor prognosis, the blastocyst development. So let's look at the morphological variations and the impact on the embryos. The one in the green, if you see dark color in the cytoplasm or homogeneous granularity, the shape is oval, they're fine. They have a minimum impact on the embryological. The refracted bodies, the fragmented first polar body, the dark zona pellucida, large PVS, debris in PVS, they have a moderate impact. Whereas if you see large multiple cytoplasmic vacuoles, a large polar body, the giant oocyte, severe central granulation, cluster of smooth as endoplasmic reticulum may have a significant impact on the embryonic outcome. So apart from these, I mean, why do we see the abnormality? There are multiple factors. Aging, as we know, the aging can lead to the depletion of the ovarian reserve and the oocytes. In the age in the aged patient, the quality of the oocyte also decreases significantly. There's the increased incidence of vacuoles, altered mitochondrial matrix, increased incidence of the SCR, increased incidence of dilated Golgi complex, which may compromise their fertilizing ability. Apart from patient's age, the in vitro aging of the oocyte can also significantly affect. What is in vitro aging? In vitro aging is when you do oocyte pickup in the morning and you wait for a long time for various reasons and you do insemination or ICSI very late. So in vitro aging can significantly compromise again the quality of the oocytes. The association between the metabolic conditions, PCOS and oocyte quality is not very clear. There's very contradicting report, but there are reports saying that endometriosis can have significant impact on the oocyte quality because oocyte experiences oxidative stress in the follicular environment. Again, these days we are concerned about the impact of the cancer. The studies have shown that the patient with cancer, the breast cancer, there's an increased incidence of atretic oocytes compared to normal population, and also the maturation of the oocyte also compromised the post-stimulation in cancer patient. The human oocytes are very unique because unlike somatic cells, they lack one important protein known as microtubule organizing center or mTOR. The mTOR is very important to maintain the genomic integrity of the oocyte. It is a spindle, and this protein will maintain the integrity of the meiotic spindle. Unfortunately, human oocytes do not have this protein, so there is always a risk of higher genomic instability. For various reasons, it could be because of the exogenous hormones during stimulation, or it could be which eventually lead to oxidative stress and can lead to aneuploidy or various abnormalities. The question is whether the stimulation, the controlled ovarian stimulation, has any impact on the follicular environment and the oocyte quality. Again, there are several reports, but most of the studies done in human model have shown that the stimulation has some adverse effect on the oocyte quality and outcome, but the studies in the human have failed to conclude that the stimulation has an impact on the oocyte quality. Now the question is from the embryological aspect, to inseminate or not to inseminate when you have such oocyte. For example, if you see giant oocyte, extremely large PVS, the fragmented oocyte, extremely large polar body, avoid injecting them, don't fertilize them. And if you see SCR disc, the vacuolated oocyte, the severe central granulation, you can inject, but those embryos should last to go. Don't prefer such embryos for initial attempts. And if you see thick zona, the mild granulation, refracted bodies, the PVS inclusion, fragmented polar body, they have a minimum impact and they can be used for fertilization and for embryo transfer. The question is, do we need to optimize the lab protocol if you see abnormalities in the... One thing we should always remember in IVF lab is that the poor quality oocytes have increased susceptibility to iatrogenic damage. So we have to handle them carefully with the minimum manipulation, see that they are not exposed to adverse pipetting or condition, pH or osmolality changes. And if you see heterogeneity in oocyte maturation, you can go for extended IVF. Let's see, you think that, okay, they are metaphase 1, give them more time for in vitro maturation, and then do ICSI. And if they are post-mature, don't wait. You have to inseminate immediately, because if you don't inseminate, there is a risk of the polyspermic fertilization or other kind of fertilization abnormalities. And if you see all immature, the pickup is done, the 10 oocytes out of 10, 9 are immature or GV. So there is an option of going for rescue IVF. This is not a conventional in vitro maturation. It's a rescue in vitro maturation, but the results are not very promising. But still, one can, instead of discarding such oocyte, you can subject them to in vitro maturation. Within 24 hours, if they progress to metaphase 2, then prepare a fresh sperm, and then you can continue with ICSI. Or there is also a possibility, instead of throwing the GV, you can freeze them. And if you are not successful with the initial attempt, then you can still use this GV for maturation. And if you get such embryos, you can transfer to the patient, which can, instead of going for a fresh stimulation. Insemination technique, IVF or ICSI. If everything is fine, why not IVF? Give some natural selection by IVF. But if we see asynchronous maturation, it's not that, as I said, we don't always get mature oocyte. If you have asynchronous maturation, use mature oocytes for ICSI, and immature oocytes can be subjected to in vitro maturation, in vitro fertilization, conventional IVF. Because by the time they mature in few hours, they get fertilized if the semen parameters are fine. We can also think about the adjuvants, the assisted oocyte activation. If we think the oocytes are very abnormal, heterogeneous, we can expose them to the calcium ionophore activation, we call it as AOA. So after ICSI, keep them in calcium ionophore for about 10 to 15 minutes, so that increases the process of fertilization and can increase the fertilization and embryo quality. And of course, embryo selection, transfer, freezing, it is not that if you think that the embryos are not good, then probably you can transfer them on day 3 instead of going for day 5, because we believe that we have excellent embryology lab and culture condition, they cannot completely mimic in vivo system. Transfer them on day 3, probably they may progress better in vivo rather than in IVF lab. So in summary, the assessment of oocyte is a crucial step in identifying quality of oocyte, and subsequently it can help in embryo selection process. There are several factors can influence the oocyte quality. The poor quality oocytes have very high or increased susceptibility to iatrogenic damage, so they have to be handled carefully. You can also think about the adjuvants like assisted oocyte activation, piezo-ICSI, that can help in overcoming fertilization failure and can give better outcome in our IVF program. Thank you very much for your attention.
I'd now like to invite my friend, Dr. Gilbert Nibitanga, to kindly moderate the session further.
Thank you for the introduction and the opportunity, dear Dr. Salaam. We now have with us Professor Jolie Simpson from the United States of America. He is a professor of obstetrics and gynecology at Harvard West College of Medicine, Florida International University, USA, and past president of the International Federation for Fertility Societies. Dr. Simpson has actively contributed to many aspects of reproductive medicine and genetics, and the prenatal medicine, prenatal genetics diagnosis. He is certified professional in medical genetics and has over 800 articles and chapter credited to his name. Professor Simpson has also been a long-term partner in various initiatives with Merck Foundation. The first topic for the day is detection of relative with autosomal dominant cancers sensitivity gene may identify relatives at risk who choose PGTM for embryo selection. Over to you, Professor Simpson.
The number of people that are demanding the slides outnumber the speakers considerably, but I think we have an excellent project. So Dr. Shadab, thank you very much for including me in the program. It's his responsibility to have chosen the exact topic here. it's actually more of a description, but I'd like to read it to you. Detection of a relative with an autosomal dominant they identify individuals at risk who use pre-implantation genetic testing for monogenic disorders or embryo selection. If you think about that, what that means is that instead of identifying individuals at increased risk or embryos at increased risk, we're going to prevent them from resulting in an abnormal outcome because we've got the susceptibility to do that, as mentioned. So here's the title right there. Once again, I'd like to thank the Merck Foundation. The individuals involved are myself and Svetlana Reshitsky, who is in charge of the Reproductive Genetic Innovation Program in Chicago. We are both identified there. Disclosures are each of the two, and in addition, I have one additional potential conflict on the Scientific Advisory Board as listed. So the objectives that we have right here are number one, we'd like to state the role played by expanded carrier screening and gene panels for increasing the number of pre-genetic testing for monogenic disorders. We'd like to discuss also the management, once we get this situation, of patients who are effectively learning that they are at genetic risk because of first-degree relatives that have been identified as having an autosomal dominant disorder. So we've been traditionally in obstetrics and gynecology and even reproductive medicine, we've been looking for childhood onset conditions. We're going to switch it now. The dynamics are totally different and they affect each of us in the room. And in addition, after we have identified someone at increased risk, as I've just mentioned, we can prevent the transmission of the affected offspring, and we can do that by selecting the embryo that does not have the given infection. So, Dr. Reshitsky and I are involved in reproductive genetic innovation. Has a number of global customers, so to speak, around the world. And look at the numbers here. They've done 11,400 single gene disorders. That's probably more than anyone else in the world, in particular for 796 different genes. So many of these, RGI has been the first in the globe to come up with these diagnoses. So you can look at those numbers and come back and think about it a little bit. Now, what we really need to do today is to talk about the dynamics of pre-implantation testing, PGT, and why that has changed. And at one time, for the career of most of the individuals in this room, who are younger than me, but none of you haven't graduated from medical school in the last week or so. So the approach here was to avoid disorders of childhood onset. So adults were interested in minimizing the likelihood that their offspring would be affected with the given disorder. Now we're switching around to that. Instead of waiting for an individual to be affected, we have the opportunity to identify parents at risk for an autosomal recessive or now autosomal dominant disorder. And that's going to bring us into fields that we have not historically done. We're going to talk about cancer, cardiac arrhythmias, which are usually autosomal dominant in nature, and neurodegenerative disorders like Huntington's disease. So although our background for many of those in the room tends to be adult onset, we haven't been able to identify the genetic disorders, and now we've unquestionably have been able to do that. So let's talk about what that's meant for carrier screening. Carrier screening is to identify couples at increased risk. So historically, we had only these three disorders that are listed: sickle cell anemia, Tay-Sachs, and beta thalassemia. The reason we couldn't do that is that we couldn't extend beyond those three. It's that we could not distinguish a homozygosally normal individual from a carrier individual. And the reason for that is that we did not have the ability to look at DNA for most of the last century, and Instead, what we had to do was to look at a protein gene product. In other words, the endpoint, and that's different. Now we've switched away from that. We don't do that anymore, and we can sequence the DNA, and we can talk about that in length or so. So the various vendors, for example, Thermo Fisher, but lots of others I could name, none in specific. Get this file. Here we go. So there are several versions. The most commercial entities look at as many genes as they can, and that's generally about 400 to 500, large numbers of these. The American College of Medical Genetics, of which I am the past president. Let's stick with this slide. Can we just leave that one on for a minute? Did a different approach. It said you don't necessarily need 450 different disorders because we don't have enough people to counsel the consequences of that. But instead, what we could do is identify these specifically in certain ancestrally or genetic groups. That's listed in the second bullet that you can see. And we only want to look at those disorders that have a severe or a moderately severe genotype. And we want those disorders that have an incidence in the carrier population, that is the heterozygotes, of about 1 in 200. Once we do that, that's called tier 3 genes. You can look at the numbers right there. And the conclusion was that we had 87 individuals who were at increased risk. We had another 10 that had supplemental mutations, and we had 16 X-linked receptive genes. Bottom line is that not 450, but 113 genes were identified as worth screening for. There's been an update there, and I call your attention in particular to the 2 slide, in which there were 3 individual ancestors that looked at. One was in the Middle East, and the consequences of that in particular is that if you have consequentious populations, which certainly we all know does occur in the Middle East, you're going to have increased frequencies of consanguinity, and you're going to go to a tier 4 gene. So we're able to do that if that's appropriate for the population in which you are working. So that's where we stand there. Now, once we've done that, we're screening adults in the population like us. People in the room right now, we have our offspring, and they're younger than us, and they're still reproducing. And we have to ask the question, what's the consequence to us? So one of the consequences is that if we screen individuals at risk simply for autosomal recessive offspring, sometimes we find that the person being screened is the person at risk, because ataxia telangiectasia and several other autosomal dominant disorders are picked up inadvertently. We didn't expect to pick them up, but we did have that. So look at bullet number 3, for example, heterozygous autosomal recessive ataxia telangiectasia or Fanconius can be identified in a woman who's worried about her offspring, but now we see we're worried about her because she is the individual that is at risk for certain types of cancer. Now, this has resulted in a huge increase in the number of adult individuals who are coming for autosomal recessive disorders and for autosomal dominant disorders. And we've always done that for reproductive genetic innovation. Look, you can see the graph, but look what's happening in the last 4 to 5 years in terms of an increase in people who are coming for carrier screening and for pre-implantation genetic testing. So how did we got that? And what does it mean? So if we go back to as recently as 10 years ago, we can see what's happening in individuals who present for pan-ethnic carrier screening and through that PGM. So the green bar represents the total number of cases in a given year, and the blue represents those that were ascertained by carrier screening. It used to be that was fairly uncommon. You do cystic fibrosis, not a lot else. It rapidly moved forward with DNA testing by 2021, now we had 68% of cases for PGT, monogenic disorders, were in fact due to carrier screening. Identified couples at risk did not have an effective offspring, and in 2022, it's 86%. We haven't finished the calculation for 2023, but it's even higher. So the change is different in a huge fashion. So just to give you a couple of quick slides, in 2024, in our unit, there have been 60 different cancer susceptibility genes that we looked at over the years. That's 829 patients. We looked at the number of embryos transferred after the last assist genetic analysis, 1852, and that resulted in 671 deliveries, very few gestation, so 733 babies at the time. So the most common cancers that were patients seek information on in terms of determining whether they're going to transfer an embryo or not is BRCA1 and 2. That's no surprise. The 360 of the 829 patients had that condition. Lynch syndrome is the second most common, and the old ones are neurofibromatosis and tuberous sclerosis. We've been looking at those for a long time. They used to be the main things we looked at, but that's not true anymore. So 56 different genes in addition to the 4. So it's extremely heterogeneous in the population. So let's stop for a minute and go back and look at what happens in terms of cancer susceptibility. What does it mean if any of us have cancer susceptibility? There are really 3 different types of conditions that we could look at. These are autosomal dominant disorders, 50% risk, and they are adult onset. So that includes everybody in the room, including me and my own offspring who are of reproductive age and sometimes have passed reproductive age. So we're going to talk about cancer susceptibility, what that means. We're going to talk about cardiac genes and neurodegenerative. I'm going to emphasize cancer, but I could give the same talk if I were asked in front of a bunch of cardiologists to tell what the risk is there. So let's look at that. So cancer susceptibility genes is going to be the main focus. Now, cancer susceptibility is different than what a lot of us thought we knew about cancer and when it occurred. It turns out it's a two-hit hypothesis. You don't usually get cancer, especially autosomal dominant disorder, simply on one hit, and you get the tumor that occurs from there. So instead, it's 2 hits. The first hit we're born with, we didn't ask for it. We just got it. You came from one of our parents. That's the first hit. It's only when we get the second hit that we develop multiple manifestations of the cancer. So this is what happens. Some of us in the population are unfortunate enough to have a germline mutation at the top. You know, the sort of Damocles is over us, and it may or may not hit to us. And it'd be a lot better if we had the situation in which we didn't inherit that, and we had to have 2 successive hits in order to manifest this disorder. Now, what does that mean in terms of what we tend to identify in the population? So let's look, for example, at BRCA1 and BRCA2. This is the most common cause of breast cancer. It's autosomal dominant. So if you look at any portion of the slide, the gray height represents the breast cancer, for example, or any of these cancers in the general population. 7% for breast cancer
in progress
in the population. But you may or may not develop cancer because you got the second hit that can come in. However, if you live to age 70, the likelihood is 87%, not 100%, but 87%. If you look at ovarian cancer in BRCA1, BRCA2, it's 63%. And then to the right, the reason that is significant is that this represents the same gene, but in different organ systems and therefore different clinical manifestations. So prostate cancer, so that means if your mother had BRCA1 and BRCA2 and you were male, you were at risk for prostate cancer. It's not just all female oriented, totally different situation here. Same thing for pancreatic cancer as well. So why is that? So because of these two hypotheses, you can look at a graph like this. So breast cancer is associated not simply with BRCA1 and BRCA2, but all of these other genes. You can go around TP53, for example, JAK2, or any cancer people in the room, these would be very familiar situations. And flipping around the other way, we can get TP53 and the graph to the right side of the screen there represents the clinical manifestations that can occur. So it's flipped around in the same situation right here. So we have a totally different ballpark that needs to be considered here, and we can address it or so. So the next situation is, where's the genetics come in? This is a nice story, impressive story, but what happens then? So it's now possible because of sequencing that's remarkably inexpensive, that we can look at the different genes that cause these adult onset cancer, autosomal dominant. Their cancer susceptibility, cardiac genes. So let's just look at a few what happens if you were concerned that the cancer you had was autosomal dominant and it was a gene mutation. What you do is order that. You don't have to start here. This is a gene panel for one particular condition. Doesn't really matter. And you look at this, and there's about 100 different genes in which there's a mutation that can cause breast cancer. 100, large number. And in fact, it's a very sophisticated methodology. I won't go into what's to the left portion of the screen, but it's looking not just at the coding sequences, but those that are before and after that. We can do the same thing for arrhythmia genes. So here's another 100 genes in which there's mutations that can cause cardiac problems that none of us would like to have. Now, how do you manage that? That's the final portion of what we're going to talk about in just a few minutes here. So the index case is treated as always by oncologists, urologists, and the likes of that. Most of us are not going to have anything to do with that. And that used to be all that a family cared about. But in fact, it's different than that. Because of these are genetic conditions, autosomal dominant, adult onset, we're going to have to involve the geneticists, genetic counselors as well. Because they're offering a different set of consultation that be necessary. And look at the last bullet, autosomal dominant inheritance. If your mother has it, breast cancer for that, that means that all of her offspring, including some of us in that scenario, have got a 50% risk of having that autosomal dominant. Not 1% in the association, but 50%. And the risk for the second degree relatives, those would be the grandchildren, would be half of 50% or 25% in that population. So what would you do now? What would be the counseling situation? Well, first bullet, typically these are women, say age 55, 60, 65, in that ballpark. The first degree relative may or may not have had children. They may or may not. If you develop cancer at age 42, you will have your offspring probably are still developing their own family or so. So it is not completed by offspring of the index of the first patient. I would screen that individual and then offer her the ability to detect which embryo could be transferred and which one could not be transferred. If they've already completed their family, for example, then that's not an issue, but the offspring of the daughters and males of the woman that had breast cancer is an issue. And finally, again, as I pointed out, for BRCA1 and BRCA2, both male and female offspring are at risk. It's no longer just mother's problem and her daughter's problem. It's all of us in these problems. So final main portion that I want to talk about right here is that what's changed and why are we talking about this in this particular room? Well, it's changed because we used to have individuals at risk for various conditions and they had had it affected offspring. And even if they could be screened like cystic fibrosis is a very good example. We could still do amniocentesis. The problem with amniocentesis for autosomal dominant disorder, you've got a 50% risk that you're going to be affected. And that means a huge number of pregnancy terminations that exist in that situation or so. A much better mousetrap exists with the embryo selection by IVF. Even if you're fertile, if, for example, already didn't affect the child, in that situation, we can avoid that. We can prevent the birth of a child with a cancer susceptibility gene or cardiac gene or Huntington's disease, each of these things. So what you do is you develop a cohort of embryo, and certainly don't need to say that to everyone in the room or at this meeting, the selection of an unaffected embryo, that is, does not have the mutation, is relatively simple. I'm not going to go into it in detail, but it is, and therefore we can select the embryo to transfer that does not have the mutation, and there will be no risk of an affected pregnancy in that particular situation. I think that's a huge advance, you know, and it's really going to change the field completely. So remember, amniocentesis or chorionic villus sampling, you've got a 50% likelihood of the pregnancy termination, which nobody thinks is a good idea, except to prevent something that's even worse. Now, just a few slides here on the diagnostic pitfalls. This requires sophisticated pre-implantation genetic testing. No argument about that. We especially are concerned about making sure that the mutation that we're searching for is in fact there or not there. It's more simple than what you think. And so this is called allele dropout. It's simply a limitation of the amplification that occurs. You know, it's simply not 100%, it's about 95%. But with screening like this, like in high state, you need to take that into account. So this is a slightly sophisticated slide, but just show you. Looking at all the embryos here, the red ones have the mutation for cancer susceptibility gene right there, you know, and sometimes you're pretty sure that you have a mutation there because all of the other genes to the left, to the right, show the mutation. But if you don't see it, we call that allele dropout, and you look through, and if we don't see it in the middle, we go back. Diagnostic pitfalls, the only other one that I'll mention here is molecular heterogeneity. If you look at BRCA1 and BRCA2, these are the different numbers of genes in the same BRCA1 and BRCA2, different portion of the gene. So at the top, you have deletion of adenine and guanine in 94 of 193 cases or so. And then in the others, however, these are often found only in a single family. So this is not the stuff for amateurs. You're going to need to sequence every aspect of that gene for mutations. So they're going to be under different sites that could have occurred. Same thing for BRCA2 and 3. So just to finish here, what I've tried to tell you, preach to you, expanded carrier screening identifies many couples at risk for autosomal X-linked recessive disorder. Cancer susceptibility can be transmitted to offspring who are now adults. The robust methodology takes into account de novo mutation and allele dropout. You don't need to know about that in general, but you need to know that it exists. And finally, number 4, adult offspring at risk for cancer susceptibility or cardiac genes can choose IVF even if they're fertile. New customers, so to speak, followed by embryo selection and transfer of the unaffected embryo. I'd like to thank you for your attention, and I hope that you.
Our next speaker for the day is not other than our Professor Oladapo Ashiru from Nigeria. He is the president of African Reproductive Care Society, president of Academy of Medicine Specialties of Nigeria, Secretary General of International Federation of Fertility Societies, Nigeria. His area of research interest is mainly in the field of reproductive and endocrinology, infertility and assisted reproductive technology. He is constituted as the pioneer of in vitro fertilization and embryo transfer in West Africa. He has been a long-term partner of Merck Foundation in its various programs. His topic for the session is infertility and assisted reproductive techniques. Over to you, Professor.
Good morning. I think I'm going to talk about the topic given to me, and it's giving you a broad exposure of what we can do in our environment in Africa. Because I see in the audience people who are having ambition to set up assisted reproductive technology centers in their area, and also people who have already reached a level that they're able to do some, and I am given a wide span of what you can do up to the advanced level. So it's a pleasure to give this talk, and I have no disclosure other than what has been said. This is the scope that we'll talk about. I will talk about infertility, then assisted reproductive technology as a medical assisted reproduction, the process of IVF and PGT, other ART procedures, modern male medicine, the future of ART, and the summary. Well, we all know that what infertility is all about. There's a difficulty, inability to achieve conception after 12 months of regular and unprotected intercourse. And these are the causes that can be involved in this, from tubal up to abnormal sperm parameters. Now, there are two types: primary, which has no previous history of conception, and then you have the secondary, where they've not been able to have conception or any pregnancy at all in the past or in the last 12 months. So even if you had one, and then if you tried again 12 months, no conception, is regarded as primary. Now, what are the options if you have an infertile couple? You can either adopt, you can have time legal intercourse and continue, then you can opt for medically assisted reproduction. And this is clearly in stages. The ART, which is assisted reproduction, insemination, surgery, ovarian stimulation, and ovarian regeneration, which is one of the new techniques for people who have reached menopause. You can get stem cell into the ovary and then living child-free. Now, what is ART? It involves removing egg from a woman's ovary, and the eggs are fertilized in the lab, and the embryos are transferred back into the mother or donated to another group. Now, ART excludes procedures handling sperm alone. So, because what we found out in Africa, I mean, at least in Nigeria, you have some doctors who have a clinic, and all they're doing is IUI, that is medically assisted reproduction. ART, if you're handling sperm alone, you're not doing ART. If you are doing treatment that you are just stimulating eggs, no. For ART, you must manipulate the sperm and the egg in the laboratory. Thank you. Now, let me just go through historical. I will skip the. It started as far back as 1677 when mammalian spermatozoa was discovered. Then you can go down, you see that by 1969, Edward Bavista and Steptoe have been able to demonstrate human oocyte in vitro and fertilized it. and then successful freezing. Then you could see here, birth of the first child from IVF was 1978. At the same time, Ashura and Blake, we reported stimulation of endogenous FSH release by giving FSH, which is now used in technology. And then you could see that first IVF was in Nigeria in 1984. Then South Africa had the first baby in 88, Egypt 86, Nigeria had the first in 89, and then Ghana had 1995 first IVF, and then we in Nigeria reported PQT live baby in 2012, and Ghana had the first baby born using low-cost IVF. So you can do low-cost IVF even in your centers. Now I show this picture to show you that the first baby born, Liz Brown, celebrated her 40 years birthday in 2018. And this was in Baltimore. She wrote a book, and you could see here, that is the test tube that she was conceived in, which Robert Edward gave her as a souvenir. And you could see that today's test tube, if you ever go in the lab, is different from this. We now have, the industry has come to our help, and we now have big incubators and different types. Good. So you can see that at this point, let me just go back again. At this point, the pregnancy rate was about 10%, but today's pregnancy rate has moved as high as 75% in centers, if you can. And we are hoping that very soon, maybe in the next 5-10 years, IVF should reach 95% with all the technologies coming to it. Now, this is the feedback work that we reported in 1978, 79. And this is very important because that is the basis that we now use gonadotropin to cause multiple ovulation. It was based on this science work we reported. And then these are the steps that are involved in IVF. You stimulate the patient, you retrieve the egg, you inseminate, you culture, and you transfer. Now, if you're trying to set up IVF system, you may start from a low level, you can improve to your level. You could see there how it is retrieved, ovarian follicular aspiration. Then you need one blocks to receive the follicles. And then you need good microscope to do sperm preparation, washing and preparation. And then what is critical for an IVF is a stereo microscope, which you need to be able to identify the oocytes after from the follicular fluid. Once you do that, then you can just culture it in the lab, and you can then get the embryo and transfer. If you have the resources, you can upgrade and start doing intracytoplasmic manipulation. This was as far back as I was in it at the University of Illinois, Chicago in 1995. Then you can then upgrade to this type of XC machine, which now has a lot of accessories for you to do more. And of course, in future, we're thinking that sperm injection can become automated, in which case all you need to do is use a probe to do your sperm egg injection. And you could see how this is being immobilized, the sperm is being taken, and then he's now going to take this and get it injected. You can see that is all being done by the machine, by the AI, and then it's going to sense where the align the polar body, and then you're going to see detect the zonal pellucidar and perivascular space, and then the injection, you could see it coming in. It's going to inject you can see the sperm coming out, and then it goes in, takes the tip of the injection, and it penetrates. You can see that is all being programmed by the AI. This is the EC process that is done manually, being now done by the artificial intelligence programmed to that machine. Then it's going to go in, you see, and then absorb some of the, you can see taking some of the ovarian tissue and now injecting. So that is what happens there. Then you can now monitor embryo development. Things that we did study in embryology before that we could not recognize, some time-lapse imaging has now enabled us to see what really happens in the embryo during that period that we are keeping it in the lab, and it can help you to select the best embryos up to blastocyst. But these are techniques that will require a lot more funding, and you can see that. Now, once your embryo is ready, then you're going to pick them and you can transfer on day 2, day 3, or day 5 of the process. And sometimes if you don't have the good ultrasound scanner in which you can do ultrasound guided transfer, before you transfer, you will do a mock transfer so you know the length of your catheter and you know where you're going to transfer to. Now, you've heard this morning what Professor Simpson talked about pre-implantation genetic testing. These are one of the novelties in ART. I will quickly run through them. A male treatment, because when you emphasize that male should join in fertility, then you should be able to offer them treatment. Otherwise, they'll be discouraged. Then we talk about donor, and then I'll quickly go through all these steps quickly. So you can do, I don't know where the pointer is, but you could see there, you can extract sperm from the epididymis or from the testes. And this requires you to be able to locate the anatomical positions. You do local anesthesia, and you can just aspirate the sperm in that position. That's percutaneous epididymal sperm aspiration for people who have maybe ejaculatory problem, and then those who have low sperm, and then the embryologist can go in and select the sperm from there. Then we can do pre-implantation genetics testing, because in Nigeria, sickle cell is very high, and you have couples who are carriers, AS couple, lady married to an AS man. And as you had in the previous lecture, what was the option available before? They either risk it and have a sickle cell baby, or they will go through amniocentesis, and then they end up that they have an AA baby or AS, they're happy they continue with the pregnancy, or they have an SS and they have to make a decision, do we terminate this pregnancy or not? So we now use this help to identify embryos that are normal, AA embryos from SS embryos. So these are some of the things that have been done. So I will not walk through that, but it started with, this is the history and the landmarks of those people who have worked there. From 1960, it started with Alan Hardesel in 1989, and then going all the way with Valinsky and Richard Lana. They worked in Chicago doing polar body. Yuri Valensky died some years ago, and Richard Lana is the one that continues the work with Professor Simpson doing this early PGT different levels in Chicago, and they've moved now to do even cancer screening, which is very novel. Now, we used this, and we had the first successful pregnancy in 2013. It was a known sickle cell couple, and they were able to achieve pregnancy by 2012 from FET. They had an affected boy, and you can now use this for HLA typing to correct the affected boy. They were able to have a sickle cell-free baby, and we published this in Nigerian Medical Journal in 2014. Now, what are the indications? It's been said before, but like autosomal dominant, like Huntington disease, dwarfism, sickle cell disease, which are autosomal recessive. then sex-linked diseases like hemophilia, and then HLA matching and structural and chromosomal abnormalities. Just to show you what is evolved, it has evolved from the original method of fluorescent in situ hybridization to look at it. And then you can now do polar biopsy just for your education, and then you can do blastocyst biopsy, you can do tophaceous biopsy, and then the next level was the comparative genome hybridization, where you take the biopsy, you amplify it, and then you take a control DNA and a biopsy DNA, and then you get them and you are able to analyze for them. But this array CGA, formerly referred to as gold standard, became redundant, and you now have what you call the next generation gene sequencing, where DNA is extracted and goes through these various processes for analysis. Then you have for PGTM, where you do whole genome amplification, you detect the specific mutation, and then you also look at inheritance of normal copy of the gene allele. Now, this is a result of some of the, this is a collaboration we do from our center in Lagos, collaborating with Reproductive Genetics Institute in Chicago. We do the aspiration in Lagos, oocyte aspiration, we fertilize, we get the embryos on the farm, we biopsy it, and then we send the samples which I showed through Delta Airline to Chicago. It's a very straightforward process. They get the the biopsies in within 24 to 48 hours maximum, because they are frozen, and they send a pack. And what we are now doing in Nigeria is to collaborate, so you can send those things to us and send it to them, or we can teach you how to biopsy the embryos in your center. And once you have the tube, you freeze your embryo in your house, in your clinic, and then you await the result. The result will come out like this after the analysis. You could see some may not be biopsy, but you can see carrier, you can see affected. You can see that number 4 is good, it's a male, and you can transfer. Then you have these are carriers, and then number 8 and number 9. But if you see number 8 being a carrier, but it's abnormal with a lot of deletions and chromosomal abnormalities, so you don't transfer. So the value of this is that you're able to know the morphology, the genetic composition of these embryos, and you know the ones you can transfer. And one of the reasons we have not been able to, we prefer to do this collaboration, as I was explaining, is that we were trying to set up a PGT program, but PGT program has to be independent of your IVF program, because you can't combine the two. It is labor intensive and it is capital intensive. And unfortunately, by the time you try to establish a lab, and before you can make your return, because it's not for free if it's in private setup, before you can make your overhead, the equipment have expired and you need to change it. So those are some of the problems we have with PGT. Then the next thing we do is surrogacy, and then I'll quickly go through this. We have used this to help people who have a history of complications in pregnancy, people with recurrent pregnancy loss, people with medical conditions and cancer and things they don't want to carry pregnancy. You can get the egg fertilized and transferred to a surrogate. And we've done this in Lagos, and we've had several babies born from there. This is the data. At the point, we've got about 45 babies at this point, but probably more than that now. And the last thing I want to talk about is what I talked about, clear and present danger to infertility. And this is now being emphasized by WHO and by fertility organization. What you talk about, things in the environment, environmental toxins that affect infertility, bad eating habits, and stress. And we in Lagos, after transferring to patients who had problems with recurrent pregnancy loss, then, oh, maybe it's the abnormal embryos. Then we did PGT for these people, And then we transferred euploid embryos to them, and they were not getting pregnant. Why? We found out that these people were living in the oil-producing areas of the country, or they were having a lot of heavy metals in them. So by the time we take them through this mother mere detoxification, then we transfer back some of the remaining embryos, and they end up having their babies after that. So we use this method to eliminate toxins from the body and thorough intestinal cleansing. And we know there's a lot of publication. This was in Fertility and Sterility, which talks about the gut microbiomes and the relation with a number of problems like obesity, insulin resistance, and age. And we realize that Meyer therapy can help mitigate the influence of gut microbiome by helping providing alternative management of PCO. This is some of the methodology, mechanism by which Wang and his group showed to relate the microbiome of the gut with PCO and other disorders. And what we did in Meyer is that once we clean the intestine and the rest of the bodies, we remove these organs, these toxins, and we're able to achieve a better pregnancy. That is why today we are recommending preconception cleansing of any type. It just maybe even just doing your lifestyle management or dietary or exercise. These are part of preconception cleansing. And we've managed this and we've published this in Global Reproductive Health, where we show that in two groups of people, we're able to have increased pregnancy rate, 30 and 20% between two groups. And also, we have shown that we can remove these heavy metals from the body by our technology. This patient was seen in September. This is you can see that red line in there. That's showing this was done by Genova Diagnosis and Toxicology in the US. This is heavy load of metal in that patient. And then you can see 3 months after, all the heavy load of metal have reduced and the patient is less congested with heavy metal, and there was success. And then we showed that there is a potential for IVF. We've shown this. And also, it shows that people who have failed IVF or who have been through detoxification, before detox, the failed IVF ranges from 1 to 5 with a statistical analysis. But after detox, the average was now 0.29 compared to 2. And this was a show published to show that detoxification can be a potential method to improve your fertility rate. What is done? What do you mean by detoxification? You give oxygen therapy, you chelate heavy metal from the body by using you do lymphatic drainage to improve the process, and you also apply two-rack technology. These are some of the things that we use in that process: oxygen, electrolysis detox, lymphatic drainage, phytotherm, infrared cabin, aqua lymphatic, and we realize that Meyer therapy, removal of nutritional toxins, removal of heavy metals, improvement of chromatographic quality, total body detoxification, antioxidant therapy, and automolecular supplements like selenium. Even if you are not able to do this, given things like selenium and D3 and CoQ10 can help you to improve the process outcome for your patient. Now, the future, what we realize is that we know everything now about IVF, but the problem is the implantation. And it shows that the uterine receptivity is a problem. And there are a lot of changes that occur in that area. And in terms of that, we believe that new technology will allow us to be able to have more diagnosis, more disorders, to be able to do PGT from the culture media, metabolomics, and then improving implantation success. This has been shown by some review as the hormonal interplay that is involved in embryo receptivity. And the window of implantation was looked at, but we still don't know what exactly is involved we know that we give progesterone as potential support. Some people will need E2V, but there are so many things that are necessary. We were thinking about this method, but it appears that the studies that were done is now being shown as not so relevant because they did not compare the same apple. They were comparing apple with oranges. It's not eukaryotic embryos that were transferred. Some were just embryos, so we didn't know. So let me summarize that increased understanding of physiology, microscopy, and molecular mechanism of reproduction has enabled us to improve reproductive capacity in the human. To date, in fact, it's 10 million babies have been born with this knowledge, driven technology, which occurs in Nigeria. I can now add Tanzania, I can add Ghana, and I need you to give me, if you've done it, so I can add your country as those countries in Africa that have been able to join this world map of reproductive fertility. And these are the references. I end off by saying that in the words of Beethoven, the 17th century composer, I recognize no superiority in mankind other than goodness. I said this at the end of this lecture. And I said that if you all extrude goodness, we make good process for our patients and for our country. Thank you for listening.
He is the president of Inter-African Group for Study, Research and Application on a Fertility Giraffe, a university lecturer of San Pedro in Cote d'Ivoire, a biologist, and the head of laboratory at Clinique Médicale Janique in Abidjan, and a successful Merck Foundation alumni. He would be speaking on the topic, bridging the gap, improving access to assisted reproductive technology in underserved communities. Over to you, Professor.
Ladies and gentlemen, morning. I try to speak English, but my English is not high. I usually speak French. For situation, I try to speak English. Are you okay? Now, my presentation is the title is bridging the gap to improve access to assisted reproductive technologies in underserved communities. The topic of the presentation is, let me see that, yeah, a global problem of infertility, assisted reproductive technologies in Africa, in raising awareness among communities is lacking. Situation of current infertility practice and strategize to consider to fill the gap. Before to start it, you know, we have not experiences in the English country. We have not the same experiences, and we started with what do you say, technology, obvious technology is too late between the English country. But for what do you see? Yeah, for global problem of infertility, we can see infertility is still a major concept for couple today, especially in Africa, where the children occupies in a irreplaceable place in the development and harmony of the family. Indeed, infertile couples suffer especially is psychological and economic suffering and trauma. What do you say? Yeah, indeed, infertile couples, despite now assistant reproductive technologies in Africa and raising awareness among communities is still lacking. Despite this destructive situation experiences by several couples in our country, the treatment of infertility through assistant reproduction technologies is still lagging behind, or is still in emphasis in several communities in the private sector, especially non-assistant in the public sector. What a contribution to improving the management of couple infertility in remote regions. Current situation current situation of assisted reproductive technologies, IRT. The prevalence of infertility is high in Africa, French region, around 30%. Opposed to several factors and insufficiencies of IRT center, a population with limited means, medical tourists is seen as a luxury. Only a few couples who can offer these opportunities outside the country and offer. Introduction in the 1918 in a few African countries, assisted reproductive technologies only became widespread during the 2000s. Today, only 73 assisted reproductive centers in 18 countries out of total 54 and registered with the African Network and registry for medical assistant reproduction. You can see an array 23. Oh, please, sir, I'm confused. At the giraffe level, around 40 centers have been identified in the French-speaking zone of West and Central Africa. Several countries on the continent do not yet have a center for assisted reproductive technologies and health professional training in reproductive medicine due to the following factor. We have the high cost of technologies. Luck has specialized training, the absence of national and international policies aimed at supporting infertile couples in Africa. All things limit the implementation of these technologies in the country to low income. Thank you. Oh, yeah, thank you. And for training, insert assistant reproduction technologies into the training curricula of biologists and biologist technicians, initiated at above all supervise the training of human resource technician and biologists through workshop, online, or face-to-face training, such as the example of Merck Foundation. We have example of the webinar organized with a giraffe. We have again a giraffe and organize something and with another association. For training, another strategy of training is the mass of the well-trained professional can lead to the creation of center, since the sector is dominated by the private sector. Another strategy to fill the gap is a contribution of research in the context of low-income countries. Socio-anthropologist approach use research on a medical plane in the management of infertility with community research program. Periodical maintain data collection. Another, oh, it's not easy. What can it? What did you say? Oh, technical thing. Technology is not good now. And I don't speak French very well. I don't speak English very well. I continue to speak French if you want it. In English. Are you sure? Okay. Change the battery.
In the slide from here.
Okay. Yeah, you can read. Okay, continue, please.
This one?
Yeah,
Which
okay,
slide?
thank you. No. After, please, next. Yeah. Okay, thank you. Next strategy is to promote the professional framework is by creating and improving the legal framework for this of IT in the public African center on the country. Promote the adoption at the IT by communities on the cultural. Yet, again, we have promote of professional, yes, professionally framework, you can see promote partnership with institutions and advances IRT country. Activate partnership between biologists and organization and association fighting infertility. Encourage the private public partnership with for the creation of IRT center and public university health center. Promote the mobility of biology and particular. Example of the partnership. Following proposition is by the implementing state support strategy, subsiding construction of center, training of human resource, diplomatic relation with advanced country in order to promote technologies transfer. And next, please, next proposition with creation health and care framework and is to insert IIT into state health program, mother, child, and production health. More than 2.5% of children born via IVF worldwide, more than 400 births in Cameroon. Next proposition is to promote the institutional and state framework favorable to the IIT in Africa. The law on the exercise of IIT is low-income country. The involvement of insurance company in the coverage at IIT in low-income country. Improve state health program, more children reproductive health, and finally, in the conclusion, political is more than necessary to support the implementation of the IIT in our country. And important advance in the care of infertile couples with especially ethical, technical, and professional requirement which cannot be neglected. Thank you for the question.
Thank you very much, Professor Koibad, for sharing your insights. Our next speaker, we will please welcome our next speaker for the session, Dr. Vipin Chandra from India. He is the Chief of Clinical and Lab Operation at India IVF, India's largest chain of IVF clinics. His first presentation topic for the day is European implantation failure. Over to you, Dr. Vipin.
Good afternoon, everyone, and a lot of love to my students. And just because of this love, I come over here. Before we start with the session, a lighter note on the Merck Foundation. A lot of French speaking, and Merck has placed up all infrastructure possible for those who are having a preferred language as French. So here in this in this land, where a lot of the French people are there, Merck, which is a German company, collaborating with lots of Asian speakers, European and American speakers, and giving awareness about ART in a land where French is a dominant language. So this Merck Foundation, More Than a Mother's logo, seems very genuine and very precise. Thank you, Merck. So I'll begin with my topic. This topic, to the Merck, I'll say this is a very difficult topic and very long topic. It will be, if you allow me, I can speak on this topic for a whole day, or maybe continue for 2 days continuously. So just to put up a key notes and to be very specific about what's the new developments are there in ART, where patients are having multiple failures. Now, just to begin with, since ART is still in the evolving phase in Africa, and many of you must be practicing ART, how many, which a patient you have treated had a maximum number of IVF failure and made them a successful IVF outcome, given them a successful outcome? 4, 5. Can you raise hand? How many of you given a live birth to a patient who had a 4 or 5 IVF failures? Anything and who had done it beyond 10 number, 10 failures? Anything beyond 15? Yes, that's the reality. Anything, infertility is a taboo in most of the country, and recurrent implantation failure will always add that psychological stress to the couple because they are infusing money, they're wasting their time, they're wasting their resources, and we have to be mindful about their time, their resources, so that we can individualize the treatment, so that they can get the outcomes, good outcomes, in as minimum possible. So that's a concept which has come up to decrease the lifetime to live birth. And all those initiatives can be taken up for these recurrent implantation failure cases so that we can reduce the time to live birth for such patients. I have a privilege to give live birth to such patients. The maximum one have gone up to 23 IVF failure, for which I have given a back live birth. So to begin with, there is no discrete definition. Ashley has come up with certain numerological numbers and wanted to make it more specific. But yeah, for a layman person, in anything, any person who has undergone 2 IVF failure with and still failed, then we can term it as as a recurrent implantation failure. Implantation, as in previous talks, has also been described by professor. Also, he also described that it's in a difficult physiological process and lot to be understood about it. But and it's in a seed and soil relationship where we want to implant a seed produced in outside the lab in utero. So to understand that, we know there are many factors are there. There are embryonal factor, can I control the slides myself, or it's possible?
Yes, but the
Okay.
controller
Uh,
will discharge.
Yeah, next. So there are embryonal factors where embryos are not so good. There are many reasons are there. Dr. Satish Adiga has already informed us that because of the oocyte which contribute maximum to the embryo formation, and they can be a reason. Those may be the maximum time the reason for the poor embryo being formed, and also the poor culture conditions. So lab quality is also very important. Next, decreased endometrial receptivity. Again, this receptivity can be abnormal. It may be thin endometrium, endometriosis, endometritis, immunological factor, and hypercoagulatinomyces and local dysregulation. We'll understand these things. And lastly, there can be a multiple factor. A patient can be having many factors all put together. They can be have PCOS, hydrosalpinx, endometriosis, and they may be undergoing unconventional hyperstimulations where gonadotropin doses are very high, as in the morning, professor as well as Satish Adiga, Dr. Satish Adiga have said, strong, hard stimulation can impact the aneuploidies of the embryos. Next. So what investigation do you feel in these cases, which should be the line of management? So I'll brief you certain investigations. Next, please. Which should be done for a patient who had to come up to you with an implantation failure. So parental karyotype must be done, as professor has said. There are many people out there who may be having a recurrent implantation because of the genetic reasons. The karyotype is just the initial beginning of the such testing. But if you want comparative genomic hybridization or exome sequencing and all should be done, but minimum karyotype should be done. Then look out for the thrombophilia, sperm DNA fragmentation to rule out any abnormalities in the sperm. DNA fragmentation is very important because we should not overlook the male partner. Pelvic ultrasonography, 3D and all to look into the peritoneal adhesions and peritoneal reasons for the endometrial reasons for failure, hysteroscopy. So these are the recommended investigation. Along with that, certain more investigations will be there, which we'll do in the case-by scenario when we take up each case. Now, next. So when we see that there is patients are there which are having a multiple implantation failure, they should be, as I said, there should be a minimum certain technologies are there, should be there in the lab to address out such difficult cases. So what should we do? So there we should have at least microfluidic sperm sorter to select out those sperms, differentiate the trip sperm from a high DFR, the DNA fragmentation from a low, and so that the better sperms can be utilized. Surgical sperm retrieval technique should be there available in those clinics. IMSI and all should be, and PIXI should be there. But again, IMSI and PIXI should be just just add up little value. But even if you have ICSI, such cases can have been dealt very precisely over the time. Next, extended culture, going from the day 3 to day 5, so that we can have a more precise and biologically at being proven to be a more given out trying, which we can give better outcomes. So studies have really shown that instead of day 3, day 5 transfer, it always ends up in a better pregnancy outcomes up to the live birth. Next, developmental rate, and looking for that abnormal kinetics of the blastocyst. So again, within the blast also, if somebody, those embryos which are grown and become a full-grown blastocyst on the day 5 itself instead of day 6 or day 7, they will be the one who should be preferred over the day 6 and day 7 blastocyst. Time lapse, again, there is a question mark, because though it's certain literature has come up which time to live birth, but again, on cost proposition, should we add time lapse to each and every as a technology for the treatment of these implantation failure patients? I have a doubt on it. Next, freeze-all. Again, freeze-all is very important for such cases, because doing a fresh transfer in cases of a recurrent implantation failure where we have done a stimulation, it go skyrockets, and that these are the cases where the hormonal millennium and the embryonal age and the endometrial age may not match up properly. And that's why for recurrent implantation failure, freeze-all should be a better, because there we can, because now we have a technologies where cryo survival rate is almost 99.9%, and we can reduce the impact of excessive hormones, because the control have ovarian stimulation and decrease the contractility and increase the endometrial receptivity. Next, assisted laser hitching physically is the one which is a proven technology now and should be used, and it shows that there is an increase in outcome if used properly. Next. So now let's, what we have discussed about the test to be done, we have discussed about the minimum technologies should be there in the ART to deal with such a cases. Now let's discuss two scenarios which are which are the real one which we have treated, and where a lot of aspects of the recurrent implantation failure have been taken. So this is the case one where 33-year-old female who was married since 5 years, having a dysmenorrhea and all, who attempted previous 3 IUI, all ended up in a failure, had a hysterolaparoscopy with a suggestive of bilateral ovarian adhesions, and the endometrium were resected. Hysteroscopy was normal. No active treatment was taken for the next 1 year. Investigation done, AMH was 3.5, USG was, uterus was normal. There were recurrent bilateral endometrioma, posterior adenomyosis there, AFCs of, and in each ovary, semen analysis normal, endometrium on the day 18 is 7.9. She has undergone 3 IVF cycles. In all the 3 cycles, grade 3 embryos or good grade of 5-day blasts have been transferred in IVF cycle, but all ended up in a failure. So I think doctors have done best of them. They have achieved good blasts, and they have transferred in a uterus with a good endometrium. Still, the patient has failed. So what should be done? Next, what could be the possible and how to proceed in this case? Next. So first of all, the factor which we have to consider, since everything seems normal over here, few things which we have to consider in our mind, that there is an adenomyosis, and there are again certain more factors there which I'll discuss as on. So let's discuss adenomyosis over here, endometrioma. Next. So there is an endometrioma, and endometrioma always have a certain bad outcome, and a systematic review has shown that if there is a presence of severe endometriosis associated with a poor implantation history in a woman undergoing implant IVF. Because endometriosis and adenomyosis, but once per se, does not decreases, it impacts every aspect of a reproductive process, starting from fertilization to the implantation. Next. So what is the role, what should be give, what should be done for this? Should we do surgical? Next. Role of surgery in a present era, role of surgery is not so much, especially specifically coming for infertility is the main concern for them. Then doing adenomyotomy, removing endometrioma is not the choice of treatment, because anyway you would giving more harm to those patients rather than you getting any benefits. Yes, if the family is complete and the patient is having a systemic sign and symptoms very severe dysmenorrhea and all, definitely surgery can be an option, but not for the infertility. Next. So how to deal with this? GnRH agonist is a tool, and we should do whatever way you produce embryo. Once embryo is produced, once embryo is there, you can downregulate with an agonist, and then do the frozen embryo transfer. Next. So that should be the treatment, and many retrospective studies as well as the review articles have been published now, which supports that adenomyosis and endometriosis in a cases where multiple failure has happened up. We should not let them to go for up to multiple failure. Any case where endometriosis or adenomyosis, frozen embryo transfer after proper medical separation should be the line of treatment. Next. Now in this case, good embryos were there, good endometrium was there, and we have now seen that adenomyosis can be a reason. But can receptivity also be a problem in this case? Yes. Next. So endometrial receptivity is also being hampered in cases of adenomyosis. Window of implantation shifts from the receptive age to pre and post. And this is where 25% of cases will have in cases where the recurrent implantation failure will have a displaced window of implantation. And you can do the receptivity by using MIRA. But again, this has to be done, is not for routine purpose patients, but because it's a cost wise, it's costly affair. But especially the patient is having endometriosis and adenomyosis, because it's proven beyond doubt that endometriosis and adenomyosis impacts the window of implantation. For such cases, ERA still be helpful. Next. Let's understand the case number second. She's 39-year-old, married since 8 years. Investigation wise, AMH is 1.1, ultrasound is normal, bilateral ovaries are having an AFC of 3.4 in each. Endometrium on the day 18 is 8.5, semen analysis normal, DFI is 18. Now, she's already undergone diagnostic hysterolaparoscopy, which is 3 IVF cycle has been done. In all of them, good grade embryos been transferred, but still fetus is. So what is wrong over here? Is wrong is that though the embryos are good looking, they are morphologically very good. 4A, you cannot expect a morphologically better embryos than these, but because since she is 39, they may be genetically not so good, and they may be the reason of implantation failure. What else? Because there's still a DFI is very high. Anything above 15% is an abnormal DFI. So these may be the reason of having maybe the embryo are good, but still those embryos may not be having. What else? So how to tackle a situation of these where age is high and failures are happening, and patient wants to go with a self cycle, because you cannot you cannot ask anybody to go for the donor programs until they are not willing. Everybody wants to go for their own, to have their own biological child. They have their birthrights. So what can be done? Next. So since this patient wants pregnancy out of the self gametes only, and though good embryos have been formed, they may not be euploid. So what could be done to make them euploid? So there are 3 strategies there that we can involve in a pre-treatment, certain more androgens, so that we can increase the number of increase the number of oocyte which can be harvested, and the pooling of oocyte without pooling of embryos can be done. Coenzyme Q could have been added in the pre-treatment, which because we know it's now that a lot of literature has come up. Coenzyme Q decreases the aneuploidy rate in the embryos being formed. Then change of the stimulation protocol. We are till now being taught in our to stimulate as hard as possible so that we will get a maximum, try to achieve a maximum number of oocytes, and then out of the maximum number of oocytes, we will get a good number of embryos. But for these kind of a patient, this is not the way to stimulate. These are already have a depleted ovaries, not much ovarian reserve is left over there. If you still stimulate hard on them, you still be hard on them, the oocyte will give away, and the quality of oocyte will not be as great. Studies have shown that higher the gonadotropin dose, the risk of aneuploidy in such oocytes will be always be high. So milder stimulation is the way to go forward for all the posodian classification group 1, 3, 4, but especially for 3 and 4, which have a low reserve. For such low milder stimulation, and concept should be on focus should be there on pooling the embryo rather than trying to get all the oocyte possible in one go. Use of PGT, definitely yes, because advanced maternal age is associated with the genetic abnormality and aneuploidies. Next. So for pre-treatment, as we discussed, androgens, DHA, coenzyme Q should be there. Next. For milder stimulation, in our scenario, in our units, we use milder stimulation in the form of clomiphene citrate, starting from with the clomiphene citrate 100 milligram with a recombinant FSH or HMG 150. Dose should not be more than high. Clomiphene citrate will also add up to these, give an advantage to these patients because the initial endogenous FSH will come because of the clomiphene citrate will help in recruiting the better recruitment of the follicles. So, and this stimulation will not be hard, and studies have shown that the aneuploidy rate is only 51% against the 66% in cases where milder stimulation has been done. Next. Pre-implantation genetics, it's beyond doubt now. For such patient, pre-implantation genetics should be done, should be given for. Next. Along with the invasive biopsy, now there is another new kid in town has come up, which is a non-invasive. It's evolving technology, but still this can be used, especially in those cases. Dr. Shati Chadika will and the professor will really will acknowledge me also that this technology can still be used, especially for those embryos which are morphologically not so great, so that they cannot sustain the injury of micromanipulation. Those embryos which are fair enough, but still you want to do the aneuploidy testing for them, this spent media technology with the NICS could have been done, but the sensitivity of NICS is still not as up to the standard of PGTA. If you have good embryos which can be tested by invasive biopsy, nothing better than that. But if you don't have embryos which can be put into the strain of an invasive biopsy, NICS can be offered. Next. What about sperm? So, as we know, this patient has a high DFI. Now, the high DFI has to be treated. Next. So, high DFI for sperm, we need to know because there can be a chromosomal abnormality which can already be parental karyotype or exome sequencing. High DFI can also be the reason. In a high DFI cases, you always look for the modifiable causes, rule out the thyroid abnormality, rule out diabetes, rule out infections, treat them. If still the DFI is high, put them on antioxidants. If still the DFI is high, then do the use the testicular sperms rather than the jugular one. Next. Because why? Because DFI impacts all the stages until the live birth. It decreases the embryonic development, decreases the implantation, increases the miscarriages, and even impacts the childhood disease. Next. So these are the causes as we discussed. Who all the patients where DFI should be done. Any patient who is having an unexplained infertility more than 3 years, having a parental age more than 40, 45, and having bad habits, smoking, alcoholism, and exposure to the environmental pollutions, infection, systemic varicocele. All these are patients which should be. Along with this, anybody who's got undergone IVF failure, DFI should be done. Next. As we said, as we discussed already, what should be the management? Management should be lifestyle modification should be there, correction of any modifiable diseases, antioxidant should be added, varicose, if varicocele is there, varicose cells should be repaired by microsurgical technique. And if still after these interventions, the DFI is still high, you can use surgically aspirated sperms for the use of EC. Next. Now in this case, endometrium was good, embryo were good. So there can be another way, another reason for implantation failure, which is immunological reasons. Now immunological reasons were not being tested, not been evaluated since long, and people were overlooking these important aspect of implantation, which was still not being understood very well. So we all know immunologically the embryo, which has a 50% genes from the parent, so it's not identical to the mother. Now, if somebody is not identical to the mother, why are they going to receive that one? But still, nature has given a very good tool that the immunological mechanism at the level of endomyometrial junction is such that they produces an environment which is more receptive to them rather than being a hostile environment. Now, in such scenarios where where fetus is semi-allograph because half of the genes are from the father, not the mother, but still the pregnancy is being taken care of precisely. But what if this has gone wrong? If immunologically the mother is not receiving the embryos and maybe then in such cases the implantation required early implantation failure may be the reasons for such case. Maybe the cause, immunological causes, may be the cause of early implantation failure. Next. So what happens? I'll give you a little bit of idea around it. We know that immunologically we have T lymphocytes, and out of them there are cytotoxic T cells and there are helper T cells, CD8 and CD4. So CD8 are cytotoxics which are high. They are not good for the implantation. CD4, which are helper T cells, they are the one which will be required more. Among the T4 also, there is TH1, TH2, TH17. TH1 and TH2 ratio, TH1 produce inflammatory kind and TH2 are anti-inflammatory. So higher the TH2 in comparison to TH1 will be more beneficial for the implantation failure. But these are not reversible. Once their concentration, their levels have been there, once differentiation has happened up, we cannot do any changes. But in TH17 Treg cells, they go into changes, and especially the Treg cells can go into T17 and Treg cells. The higher the Treg cells are anti-inflammatory, they cause the immunosuppressive environment at the endomyometrial junction for the embryos to be planted. So we need someone environment where Treg cells can be in higher or TH2 cell can be higher in concentration rather than H1 and TH7. Next. So this is how the immunological rejections happen. So if there is allo recognition is there, not there, then what happened at the residual level? Then there will be higher TH17, TH1 response will be induced, TNF alpha, interleukin 2 will lead to the rejection reaction. Since there will no blocking antibody, they will cause the destruction of the pregnancy. On the trophoblast level, there will be low HCG, low progesterone, low pregnancy binding factor, and then low local immunomodulation leading to the pregnancy. This can be modified by doing some kind of an immunotherapies. Next. So how to check for the alloimmunity? We can do serum NK cell levels, we can do serum TNF alpha, we can do, if all these are high, then there is a high chance that they may, or we can do the lymphocyte cross match for the couple. If it is negative for both HLA class 1 and HLA class 2, then again this couple will have a very high chance that the even good embryos will be rejected by mother. So these patients will require immunomodulation. Immunomodulation can be done actively, passively. Next, please. So active can be done by immunotherapy. Passively, we know certain progesterone and LMW, low molecular weight heparin, IVIGs, intralipids, and some steroids can bring impassive immunomodulations. So what if the use of these, what will happen? What they do, they will bring recognitions, and they will increase the Treg cells concentration at the level which induces the Th2 response. So instead of those TNF alphas, interleukin 4, 10, and 13, which will facilitate produce the blocking antibodies and protect the embryos. On the trophoblast level, HCG will be high, progesterone high, and pregnancy binding factors will be there, and which will cause local modulation, and pregnancy will be protected. So this is still being a lot many studies has to be done to really prove these theories on immunological rejections of for implantation. Next. We at Indra, we also do we go with a lot of intervention in immunology. So in our centers, we have till now we've done immunotherapy for all patients. Out of them, 1,200 plus patients have undergone ET. Out of them, 846 have already had a beta C positive, out which is 67% biochemical pregnancy rate, which is for those couple of patients who are having multiple failures, and achieving them in a 67% success rate is a very good, means there is a role of immunotherapy. And out of these 6-week pregnancy with a heart rate was positive in 792, which is 63, and only 6% patient had a biochemical loss, means early pregnancy losses. So it seems that it's working. Next, role of PBMC in stem cells. Yes, PRP, as professor has said, and stem cells, if in case of a recurrent implantation failure, even though the endometrium is good, if can be done on a day 12 or day 14, will give a good receptivity. What should be done post embryo transfer? Once embryo transfer is done, what should be done? Now again, this is something very critical. So this is very important. Post embryo transfer, we need to manage initially until and unless the embryo is being first wave of placentation happens. The immunologically surprise state, it should be there, and good progesterone support should be there. And if there is thrombophilia, low molecular weight heparin is role, steroid, intralipid, IVIGs should be given for such patients, and good amount of progesterone support. Now, progesterone support, I want to say that it's up to the patient compliance. You can give vaginal, you can give oral, but out of these, vaginal or intramuscular should be the way to go. And among them also keep because intravaginal will not give you accurate, because there is no mechanism to monitor the serum progesterone level. So that's why for such cases, up to the 6-7 week of pregnancy, if intramuscular could have been given, then this is a better choice, because we can monitor at least what's the progesterone level. If needed, we can augment the support. Next. So this is the summary of how to go forward in such cases. Do a proper investigation, rule out the abnormal causes, endometrial, any multifactorial reason is there. Do update your labs for at least for blast, assisted leaching, and PGTA. Do a surgical corrections in cases of hydrosalpinx and fibroids, and do give proper treatment, individualized treatment as when needed. Thank you, sir. Thank you, everyone.
I would once again like to invite our very dear Professor Satish Kumar Adiga from India to take the stage for the second presentation on the topic, optimizing a successful cryopreservation program. Over to you, Professor.
This is a topic, optimizing a successful cryopreservation program. This is a conflict, please. This outline, I'll start with the fundamentals of cryopreservation, and then talk about the different types of cryopreservation and some of the technical aspects of freezing sperm, oocytes, and embryos, and then factors affecting the outcome. So in the field of ART, we have been seeing many techniques there, but most of them, they came and they went off. There are two techniques which made a revolution in the field of ART. One is ICSI, the second is vitrification. I'm going to talk about the cryopreservation in general and vitrification in specific. So before I take you through, I would like to give an overview of what is the cryobiology of a cell. The cryopreservation is nothing but the freezing a cell at sub-zero temperature. When you bring a cell to sub-zero temperature, what happens? Because cells are hydrated, cells have a lot of water. When you bring them to low temperature, the water becomes ice. When the water becomes ice, the ice crystals can negatively affect the cell, please. So when there is an ice crystal, it can lead to dehydration, can lead to increase in the intracellular salt level, the enzyme activities are affected, proteins are degenerated, and eventually the cell is going to die. So this happens. So the primary concern in the cryobiology is how can we prevent the ice crystal formation? So this is done by using certain molecules, the chemical molecules known as cryoprotectants. So what happens during cryopreservation? These molecules try to prevent the ice crystal formation inside the cell. So there are different types of these molecules. Some of them are penetrating. They will get inside the cell and remove the water. And some molecules, the sugar molecules, the large molecules, they don't get inside the cell, but they protect from the outside. So what happens? Now you have a cell or a oocyte or embryo. You mix with the cryoprotectant and then bring it to during the process of when you add, what happens? So the cryoprotectant will get inside, the water goes outside. The water is outside, so no crystal formation. When you bring at low temperature, the cells are safe. So this can be attained by two techniques. The one is slow freezing, the other one is vitrification. As the name explains, the slow freezing is you bring down the temperature very slowly from room temperature to -40. Whereas the vitrification, you bring down rapidly. It's a ballistic freezing. You have to maintain a very high cooling rate. Let's see what actually happens. So when you bring them at very high cooling rate, then there is a state known as glass. Vitri means glass. As you see in those two pictures, the one when there's a cryoprotection, it looks like a glass. The other one is a PBS or the medium, it forms the ice. So no ice formation, the vitrification, it attains a state known as vitri or the glass, and the cells are safe. This is the biology of cryopreservation. I always compare the cryobiology similar to our phone technology, mobile phone technology. When I started my profession in late 90s, the cryopreservation machines are something like washing machines there, as you see. Like my grandfather was using the old phone, right? Now it's a transformation and we have smartphones. The same way, the technology has brought down the cryopreservation machine so small, and now we don't require any machine for cryopreservation. You need just a device to hold the cells, oocytes, or the embryos. So once you protect the cells with the cryoprotectant, the next you have to hold them at sub-zero temperature until you use them. So this can be attained at a different temperature. We use liquid nitrogen. The liquid nitrogen helps in maintaining at -196. You pour the liquid nitrogen in a container. The temperature of the liquid phase is -196. Normally, we keep the embryos or oocytes -196. But there is also a possibility to keep them at vapor phase. That means cells and embryos don't come in contact with the liquid nitrogen, where the temperature differential is only about 15 to 20 degrees. Still, at the temperature of -150, the embryos and oocytes are safe. So now you have stored them at low temperature. Now you wanted to use them. Now you have to bring those cryoprotectants outside, because the cryoprotectants at higher temperature are toxic to the cells. So the same process is reversed. When you keep them in the cryo thawing medium or the warming medium, there is the rehydration. The water will get inside the cell and the cryoprotectant gets outside. So the rehydration, there is a cell rehydration, so everything will come back to normal, and eventually the cells or the embryos attain normal physiological process. So now in ART, why do we do cryopreservation? The cryopreservation of spermatozoa can be done either by vitrification or by slow freezing. And primary indications for the sperm cryopreservation, they're for fertility preservation, the donor sperm program, convenience banking, or any patients who are undergoing the gonadotoxic therapy who wanted to store their sperm before undergoing chemotherapy. Whereas in case of oocytes, the most recommended way is by vitrification. And it is normally done when the partner sperm is not available. You have retrieved the oocyte, but no sperm is available for some reason. You have to freeze them. Oocyte pooling, normally it is done in case of poor ovarian response. You get only one oocyte or two oocytes and you freeze them. Later, when you want to use, you thaw them and then fertilize and create the embryo. The social freezing, you want to delay the pregnancy, and it is gaining popular, or in case of donor programs. And the embryo cryopreservation is normally done either by slow freezing or vitrification. The primary indication, surplus embryos, or if there is any contraindication for embryo transfer for various reasons, or in case of embryo biopsy. The ovarian tissue cryopreservation can be done either by vitrification or by slow freezing, and primary indication is oncofertility or fertility preservation. And then testicular tissue cryopreservation, it can be done either by vitrification or by slow freezing. And again, for fertility treatment or the situation like the erectile dysfunction, person undergoing chemotherapy, radiotherapy, then the tissue can be frozen. So these are the techniques. But if you look at how this can be applied clinically, most of the techniques are well established. Like the sperm, adult testicular tissue, oocyte, ovarian tissue, embryo, these techniques are well established now. They can be used. The only technique which is still under experimental is immature testicular tissue. That means the testicular tissue taken from a prepubertal boy where there are no sperm, then the freezing technique is a little bit complicated. So semen cryo, I'll quickly take you through these individual cell types. The semen cryopreservation is the most easiest because sperm cells are quite resistant because of their chromatin architecture. They have a very tight chromatin and very difficult to damage them. But the only problem is that they have large surface area. You see in the membranes sperm cells. So they tend to experience some kind of damage, but still it can be easily handled. But there are certain difficult situations in sperm cryopreservation. Like you have the poor quality ejaculate, can say cryptozoospermia, very few sperm in the ejaculate. Bit complicated because, as I told you earlier, the poor quality ejaculate or poor quality sperm or oocyte are more vulnerable or susceptible to experience damage during cryopreservation. So you have to handle very carefully. And previous slide. And the cryopreservation of single sperm. And again, this is now becoming very popular. So there are devices like the vitrification devices where you pick one sperm from the testicular tissue and put it directly in a medium, and whole thing will go inside the device so that you will not miss any sperm during the fertility restoration. You can easily pick it and use it for ICSI. So this is, I don't want to take it, make it complicated because it's a testicular tissue cryopreservation for the prepubertal boys. This is a little bit difficult because we have a different medium for this DMSO-based medium. And the technique is still experimental, but this is the only option available for prepubertal boys who are undergoing chemotherapy or radiotherapy, who wanted to store their tissue for future fertility. So this is a summary of semen cryopreservation. It's easy to cryopreserve. You can use any technique, the slow, rapid, ultra rapid, vitrification, or uncontrolled freezing, and multiple aliquots freezing, especially in case of if the sperm quality is very poor or very few, very precious sperm, then freeze them in the multiple aliquots, because otherwise you refreeze them, the viability is lost. The risk of iatrogenic damage post-warming, again, this needs to be considered because they become very susceptible. They're just thought you have to handle them carefully when used for injection or ICSI or IVF. I'll take you through the oocyte cryopreservation. If you look back about 20 years ago, the oocyte cryopreservation was almost impossible because of the structure is well hydrated, too much of water in it, the meiotic spindle is open, and cell organelle. So it was almost difficult. Now the vitrification made this process easy. The vitrification is a well-established technique, as the previous speaker stated, and you can get about 99%. If you have a good technique and the handling is good quality oocyte, you can attain almost 99% survival. And this is a technique. I'm not going to take you through the technical aspect. Normally what we do here is that so there are different type of solutions to basically to equilibrate them, remove the water molecule and then bring them to ultra low temperature. But always there are concern about the cryopreservation because they are supraphysiological. The oocytes are exposed to supraphysiological condition. One of the conditions here is that osmolality. If you look at the osmolality, intracellular osmolality of the oocyte is about only 280 milliosmol. When you put them in the equilibration solution, it is 100 times higher, about 2,700. Again, when you put them in the vitrification solution, the osmolality is 5,600. There is an osmotic shock to the oocytes or the embryos. So the concern is that during the process of cryopreservation, whether it is oocytes or embryos, we expose them to supraphysiological condition. One is the temperature differential. Normally, oocytes or embryos are kept at 37 in the incubator, stable condition. During the process of cryopreservation, we bring them to room temperature, and within few minutes, we just dump them at minus 196. There's a temperature differential from plus 37 to minus 196, which happens in few minutes. The change in there's an osmotic shock from 280 milliosmol to 5,600 milliosmol, and we wanted to attain good survival. So we go for very high cooling rate, which is usually about 25,000 to 50,000 degrees centigrade per minute. So in fact, this is a review. In fact, we have done it in collaboration, which if you are interested, you can read this, where we have explained what are the possible mechanisms where the cryopreservation can have impact on the oocytes and embryos. But overall, if you look at the literature, the vitrification is a fantastic technique, the good survival. There are several meta-analyses has shown that the vitrification is much superior to the slow freezing in terms of whether it's the oocytes or the embryos. Now the question is when to freeze in a clinical situation. So ideally, the oocyte cryopreservation should be done as quick as possible. If it's a planned freezing, don't delay it. Because if you look at the picture over there, the three images where it's non-frozen, the top one is non-frozen, which tells you the meiotic spindle assembly. The second one is vitrified after 4 hours. You can see a distortion of the meiotic spindle. The third one, the vitrification was done 8 hours after pickup, where it's a complete distortion of the meiotic spindle. So what I want to tell you here is that if you have planned freezing, then do it as quick as possible, maybe within 1 hour after pickup, because if you want to use it later, after thawing, you have to wait for at least 2 to 3 hours. You cannot do ICSI immediately after warming because whole process has to be regained. So this can prevent the in vitro aging of the oocytes. In case of embryos, everything is same, but there is a difference in the susceptibility of the embryos to cryopreservation warming. The early, compared to advanced stage, the post-compaction embryos, the early embryos are more susceptible. When the differentiation happens, the compaction and blastocyst, the embryo becomes more resistant to any kind of freeze-thaw process. They can sustain better than early embryos. Next slide. Something I want to tell about the morula vitrification. Normally, morula happens in human on day 4. The morula is the most sensitive stage of human development because that is the time the differentiation starts in embryos. The cell-to-cell connection and the formation of differentiation of 2-cell population, that is the most important and sensitive phase. That's the reason normally we don't transfer embryos on day 4 or we don't freeze them on day 4. Okay. But you may ask me a question, what will happen? I have done it and I have seen. Yes, you can definitely get a good survival. You may get pregnancy, but we don't know the long-term health of the progeny born through this day 4 manipulation. How the embryos are evaluated? Embryos are evaluated post-warming, basically for the morphological integrity. And it is believed that if you have less than 50% cells degeneration, still they're okay. But ideally, there should not be any blastomere degeneration. And the assessment should be done at two different time points, soon after warming the embryo and also prior to transfer. Sometimes the embryo quality may deteriorate after some time. So it is important to check before you transfer the embryo. Ideally, keep 2 to 3 hours of interval after thawing before you transfer. The transfer and thawing and transfer interval should be at least 2 to 3 hours. So these are some of the key factors which can affect your vitrification program: the patient-related factor, the age, the pathology and gamete source, in vitro aging, and oocyte-related factor, the maturity of the oocyte, the quality of the oocyte, whether it's a fresh or the in vitro mature. The in vitro mature oocytes are more susceptible to freeze-thaw-induced changes. The process of vitrification, the process of warming, and post-warming factors. So what is important in cryopreservation is the consistency. You have to have good SOP. You should be consistent in all your manipulation. The temperature stability at various phases. The manipulating using large volume reduces the error. What I want to tell you here is that the manipulation, during equilibration, should be done at room temperature. I've seen some people that do at 37 degrees centigrade, which is not good. The membrane permeabilization is more optimum at 37 degrees centigrade, but the rapid equilibration, it can be detrimental. And importantly, the cryoprotectant, the DMSO, is toxic at high temperature. It protects the cell at low temperature, but it is toxic at higher temperature. So all manipulation should be done at room temperature or low temperature. Small volume, there is a high risk of evaporation. Some people, they use a very low volume for equilibration and freezing. That reduces the cost, definitely. But if it is a small volume, that can lead to evaporation. Any evaporation can change the osmolality within no time, and it can be detrimental to the oocytes or the embryos. And most of the centers who have consistently good results, they use large volume for during cryopreservation or during warming process. So how to start vitrification successfully? Select only top quality oocytes or the embryos. Effective control of time, temperature, and osmolality, as I stated earlier. The pipetting skill of the embryologist matters a lot. You should be very precise in manipulation. And minimum volume loading. Keep minimum amount of medium when you load the embryos in a device, because when you have large volume, that will compromise your cooling rate. You cannot attain very high cooling rate because of the large volume. Keep minimum volume around 1 to 1.5 or 2 microliters per device. And of course, the handling, transport, and storage can also have significant impact on the outcome. The warming is a most crucial step in vitrification program. Like cooling, you have to have a very high warming rate. When you have a good warming rate, the survival is better. Always start at 37 degrees centigrade. Your warming process should be started at 37 degrees centigrade with a large volume of thawing solution. When you have a large volume of thawing solution at 37 degrees centigrade, you can attain very high thawing rate because you bring them from minus 196 to plus 37 degrees centigrade. You can attain very high thawing rate. And importantly, the embryologist should be able to move the device, the embryos or the oocyte holding devices quickly from liquid nitrogen to 37 degrees centigrade in a fraction of a second is the most crucial factor for better success in your vitrification program. Now people talk about the universal vitrification warming protocol because some people have vitrified some decades ago, but the kit is not available. Now you have a concern. I have used a different kit. The kit is not available in the market. Can I use the other kit? Yes, there is a possibility. Now people are going with a universal warming solution. You can use them so that you must have used any kit for freezing. You can use with the universal warming kit for warming process. Recently, few weeks ago, there is a technology has emerged. It's ultra rapid thawing. Normally, the process of warming takes about 15 to 20 minutes. But now the technology or the new method which says that you can thaw them in less than 2 minutes. But I have my own concern with this technique because whether in 1 or 2 minutes, whether you'll be able to take out those cryoprotectants outside effectively before you transfer those embryos to the patient. And we don't know the long-term impact of this. And we need more data about the safety of this technique. So these are the factors which can affect the freeze-thaw outcome of the embryos. There are factors which can have negative impact, like the developmental stage, the vitrification of the embryo from vitrified oocyte. That means you have used vitrified oocytes, you fertilize them, you got the embryos, you refreeze them. It may not have any impact. You can still go ahead with that. Vitrification of the blastocyst from vitrified warm day 3. That means you have warmed day 3 embryos, and then you have frozen, you refreeze them on day 5. It can be still done without compromising the outcome. Biopsy embryo vitrification, still possible. Whereas there are certain factors like the immediate revitrification. You have thawed the embryos on day 3 or day 5. There is a problem in the embryo transfer. The decision is to abandon. Can we refreeze immediately? If you refreeze immediately, that can compromise. You have to wait for some more time. If it is a day 3, then try to see whether you can take it to day 5 and then refreeze the embryo. The poor quality embryos, the modular stage vitrification, as said earlier, avoid manipulating the embryos, the freezing or transfer on day 4. Revitrification of the biopsied embryos, sometimes you may have to, there could be a patient request, whether I have frozen embryos, can you do biopsy? Yes, you can do it, but again, you have to refreeze and can compromise the outcome, survival of those embryos.
So last 5 minutes, please.
Yeah, I'll finish in 2 minutes. Thank you. And this is a KPI, the key performance indicator, which basically tells you what should be the KPI for your freezing program. Ideally, the survival should be same as fresh embryos. Same as fresh, the benchmark, the rate of embryo development should be the same as fresh embryo at the clinic. And implantation rate can be around less than 10 to 30% compared to fresh embryo, but she should not be lower than that. So finally, there are 4 key points for the successful vitrification or cryopreservation program: the efficient dehydration and rehydration, the effective cryoprotection, the high cooling warming rate, and the stable temperature at sub-zero. That means you have frozen the embryo and maintain the sub-zero temperature stable until you use those embryos or gametes in future. Thank you very much. I think I'm done with my slide. Okay. In summary, the same thing, vitrification is highly efficient method. The pre-freeze quality determines the post outcome. Universal warming, irrespective of freezing method, is possible. Cooling warming rate, most determinant factor, and KPI is the best way to monitor the lab performance or individual performance. Thank you very much.
Thank you, Professor Satish, for another mind-blowing presentation. I would like to call upon Dr. Vipin again from Indira IVF. The topic is empty follicle syndrome, a true ART disaster. Over to you, Professor.
Thank you, Dr. Shadab. This is very small topic and against the previous one. So I'll try to finish up as early as possible. So definition wise, I think all of you must have come across this nightmare where empty follicles must have stimulated and you were happy until unless you find that on each and every aspiration you're not finding any oocytes. It's a nightmare for you as well as a clinician, as well as for the patient. It's difficult to counsel them that we have telling them each every day, follicle are growing very nicely, very good FOD, good FOI, and you are we expect a good outcome, and then the day nothing. So definition wise, very simple: failure to retrieve even after adequate ovarian response. Now this has got us some incidence ratio. Incidence is a lot of variation is there. In a standardized structure, clinics which operate in a very standardized manner, there this incidence rate is very high. But at a standalone center where defined SOPs are not there, very high rate even up to 7-8% of in empty follicle syndrome can happen. Now,
there are a lot of literature available, and each have quoted variation, a lot of variation in incidence rate. Now, I'll give you two case scenarios to understand what can be done in cases where you come across empty follicle syndrome. Now, this is a case where 30-year-old female with a bilateral tubal pathology with a BMI 29, AMH 2.2 underwent controlled ovarian hyperstimulation with a long agonist cycle, receive a agonist trigger 0.2 on the day of pickup, but on the day of pickup, no oocyte retrieved. What is the possible cause? What can be the diagnostic tool to identify this is an empty follicle syndrome? Method to rescue this cycle, if any possible. What are the future precaution you want to observe in this patient? Scenario number 2. 39-year-old woman with BMI 30, AMH low, 0.7, underwent stimulation with the agonist cycle and received a recombinant HCG of 250 microgram as a trigger. On the day of pickup, no oocyte were retrieved. Again, what can be the possible cause? What should be the diagnostic tool to make out it's an EF, empty follicle syndrome? What should be the method to rescue it, and what should be the future precautions? We'll discuss these two cases. Once we'll go through the scenario, means the pathophysiology, then how to manage, and then we'll come back on these cases again at the end of the topic. So there are two type of empty follicle syndrome. There can be a genuine one and another can be false. As a genuine, as a definition wise, it means a failure to retrieve oocyte from mature ovarian follicle after ovulation induction for IVF, after apparently normal follicular development and steroidogenesis in presence of optimal beta HCG level on the day of ovum pickup. False when there is a suboptimal LH circulating level less than 15 IU per liter as a cutoff on the day of retrieval. So false is, again, genuine and false can be based on the trigger agent. So if HCG is a trigger, the serum level of HCG should be the cutoff marker for differentiating between genuine and the false. HCG level 10 IU per ml. If there is an agonist trigger, LH can be measured, and 15 IU per ml can be the cutoff for to differentiate between both of them. Now, function of trigger, as Dr. Satish has already described very well, a lot of things happens, but at most important thing, impact which trigger brings is it brings the maturation of follicle and separate the COC from the follicle into the follicular fluid, and then we show that which can be aspirated at the time of pickup. Now, how to diagnose? To do the diagnosis, the error in the trigger can be because of the efficacy of in the procedures and in the drugs administered, and then can be error on the administration part also. So on the efficacy front, there can be a subideal temperature, and the storage is not optimum for the trigger agents. The cold chain transports are not very proper and ineffective, and there can be you may have used a agent which is have a low bioavailability. Now, on the side of administration, the wrong dose may have administered lesser dose, or a higher dose may have administered wrong agent, wrong trigger agent may have used, and the wrong timing of the agent of the trigger as well, and in comparison to pickup may be the reason for empty follicle syndrome. Now, what should be the way to manage these cases? Now, on the day of pickup, when you are aspirating the follicles, take out 4 or 5 optimal size follicles, and if you don't find to, or it help to unable to retrieve any oocytes, ask. After, I have a habit of asking my embryologist after each tube how much you got. 1, 2, because you know how much you have aspirated, how many follicles you have aspirated. So it don't be in hurry intermittently, even after each and every tube. Ask your lab scientist people to help you out in giving you numbers, how many follicles are there in the follicular fluid which we have aspirated. don't go beyond 4-5. If you're seeing any good follicles, good oocytes in the first few or 4-5 follicles, then you can proceed further. If there is no follicle in the best of the 4-5 and no mature oocyte has been found, you can stop there. You can rethink. You can discuss. You can do the sum analysis over there, run the analysis, and can decide whether to re-trigger or not, and can do the management over there. So what should be the workup for cases of genuine and the false empty follicle syndrome? So we have to keep certain things into consideration. We have to, before while deciding on and diagnosing the cause of empty follicle syndrome, as well as to manage it further. So what we should be aware of what protocol has been used for stimulation, what the trigger agent is used, and reconfirming the trigger from the staff as well as from the attendant. Now, this should be the algorithm for you to manage your empty follicle syndromes. So if it is an agonist protocol and HCG has been given, then do the test, run the test for HCG level in the follicular fluid, urine, blood, and pregnancy or via pregnancy kit. If it is the values as we have discussed, 10 IU per liter, then definitely hello. Yeah. So, but if it is agonist trigger, then this is a wrong trigger, because in agonist, if agonist protocol, you cannot give agonist as a trigger. In agonist cycles, agonist protocol, HCG can only be the one trigger possible. But in case of an agonist protocol, if the trigger is HCG, you can manage, you can check out on the HCG levels. And if it is an agonist trigger, you can check on the LH levels using LH kit, ovulation kit, and the serum LH levels. Here the serum values for the use to be used as a cutoff is 15 IU. So in case of a false empty follicle syndrome, there can be many reasons. Biologically, there can be reasons. But what more biological reason, along with the biological also, more of the false one is related. I'm unable to. It's going haywire. It's going haywire. It's going forward. Yes, go back once. Yes, fine. So in case of a false one, best check whether it's in a self-administered one. In case of most of the time, the false one, because of the patient who have self-administered the trigger may have not done properly. Nurse may be with the incomplete expertise, wrong time of administration. There may be a defect in the still production of the HCG and reduce in the viability of the certain batches of the commercially available HCGs. While in case of a genuine case, there can be early oocyte atresia. The cases of genuine are more oftenly seen in ovarian aging, where day 3 FSH values are very high and peak estradiol and a high exogenous gonadotropin is used, and in against a lesser number of follicles. So these are the cases where again a longer exposure of stimulation can again be the cause, and then genetical causes are also there, where a mutation in the LH and gonadotropic receptors, LHCH, genes is possible, as well as also the mutation in the zona pallida genes are there, GP genes in case. So what should be the management? Again, false, we have to start, train our staff. We have to put up a standard policies of check and make for so that we can avoid such situations, and no patient should go for a false empty follicle syndromes. But for the genuine one, we can discuss about the retrigger with a different agent and do a pickup after 36 hours. But there is still a chance of a recurrence if there is a mutations is there in such cases. In antagonist protocol, we as a policy at Indra, we use dual trigger, where both agonist and HCG has been shown have better retrieval rate than this isolated HCG or antagonist. Prevention in successive cycle can be done by serial monitoring of LH from the trigger level and do the pickup only if LH is more than 15 IU at least a few hours before the pickup. Use of double barrel pickup needle to prevent any loss of separation of the follicles. Okay. Another way to is to prolong by increasing the time to pick up. Instead of 35.5, you can do it at near around 36 hours. Then again, such cases can have some better retrieval rates. So common marker for the poor ovarian outcome are poor of empty follicle syndrome, are poor ovarian reserve, advanced age, elevated day 3 FSH, low peak estradiol level, those patients who are requiring high dose of organotropins and and low number of follicles which are more than 14 mm. These are the patients. In such cases, empty follicle syndrome, genuine empty follicle syndrome can be on a higher side. Again, for such going for the next kind of a protocol, subsequent cycles, what should be the protocol? We can, if it is an antagonist protocol which you have done, you can go again with the antagonist protocol, but what change you have to make sure that you have to change the trigger agent. If it is HCG you have to use, you have to do with the agonist trigger. But in my practices, we do with the dual trigger instead of a mono agent trigger. Now, one more thing which we do separately for such cases is to look for the LH and FSH receptors assay while deciding on the doses and all, because LH again will help in maturation and towards the follicles, towards the last time of the stimulation. Those with the LH receptor polymorphism will also have a high rate of recurrences. So these three minor changes, if you can bring in practice, you can reduce your empty follicle syndrome. Also, you can achieve good success after even a case of subsequent cycles of the patients. Second, as I said in my previous lecture also, now gone are the days where we do the hard stimulation. As you can see over here also, longer duration of stimulation, harder the stimulation, again will end up in an empty follicle syndrome, because over maturation is not so good for the follicles to mature and we get in a good mature follicle, mature oocytes. So again, coming back to the those two case scenario. So case number one, it was, let's go back. It was a false empty follicle syndrome. So there what we have to do, we have to standardize our institutional SOP. We have to put check and balances, and a checklist should be there at the time of trigger. If the patient is, if the nursing staff is doing the putting up the trigger, administering the trigger, if you are giving the allowing the self-administration also, proper education for this patients has to be done for that, how to administer, how to maintain the cold chain and all those stuffs. In the case number two, which is a genuine one, and in such cases, we have to decide of the retrigger, and we usually do with the dual agents and with 36 hours. Thank you. Thank you, Sada, for such a short topic for the next.
Thank you so much.
Thank
Dr.
you, Dr. Vipin, for the nice presentation. So now I would like to invite my friend, Dr. Shadab, to moderate the panel session. Over to you, Dr. Shadab.
Thank you so much, Dr. Gilbert. And thank you so much, Dr. Vipin. All right. So moving on to the first panel discussion for the day. After some enlightening lectures, we would now like to move on to our first panel discussion for the day and hear some inspiring alumni success stories from Merck Foundation. To share their valuable experiences with us today, we have in sequence Dr. Gilbert Nibitanga. He is the president of the Burundian Association of Fertility and Assisted Reproduction Specialist. Polyclinic Women is a fertility service and Merck Foundation alumni from Burundi. Welcome.
Thank you, Dr. Shadab, for the nice presentation. So today I want to talk about the beginning of IVF in my country, Burundi. The idea of starting IVF in Burundi started in 2019 when Merck Foundation started Merck More Than in my country. And for that, we should salute the support from Merck Foundation and the First Lady of Burundi. So I believe that Merck Foundation contribution was mostly based on the scholarship provided by Merck to some Burundian doctors, and me also, I was among those doctors. And that time, we came to know how to handle, how to use assisted reproduction technology. And it was the opportunity for me to understand how to manage some infertility cases. So that time during my training, I was sent to India, especially to Miran Fertility Center. And after that training, thanks also to Merck Foundation scholarship, I got a chance to be trained to a UK university online, where I came to strengthen my knowledge, my skills about endocrinology skills. So during that time, I came to understand how to control endocrine system of the women and the men, how to handle menstruation cycle, and how to treat sperm during infertility treatment. And after that, I went back to Burundi, and my dream and the vision in my heart was to start IVF, but it was not easy because that time there was many barriers, social barriers, and many church, they were against the program. They said, what are you coming to do here in Burundi? Because we already have many people in this country, and you come to create another problem. But to overcome that, we try to use social media to make people understand what is going on in the country. And after that, many people came to know what is going on in that country. And thanks also to the First Lady, who is brave on that aspect. He supported me financially. He gave a financial support. He built an IVF center in that country. And I was one of the doctor who was trained in India, who was called to be the head of that project. But the beginning also was not easy, because as the first person who started to do the IVF in that country, no drug in Burundi, there is no culture media, what to do? It was very hard for us. But after that, after building the IVF center, we tried our first IVF batch, which was having 23 patients. But as you know, in Africa, many people don't have money. Only old people, more than 40 years old, who can afford, who can pay IVF. And on the population eyes, they want to see if I can start and get pregnant. If not, they can say other things which are not good for my field, for my career. But in my heart, I was saying, God first, maybe I can succeed. We started the first batch with 23 patients. And in those 23 patients, 80 patients was having more than 40 years old. And only 6 patients was having lower than 35. We start because those one who can pay money, I can't refuse them to treat them, to get the money to start that program. After doing that, I started to do fresh transfer. And all of you know how fresh transfer is. I don't know more about that one, but we had to do the fresh transfer. And after doing that fresh transfer, at the beginning, we get around 6 pregnancy positive, chemical pregnancy. That is God.
Thank you.
But after a few time, 4 patients get miscarriage. Another disaster for me. And the people start to say, this guy, this doctor is doing wrong things. Even the pregnancy, the pregnant women are getting miscarriage. IVF is fake techniques. In my heart, I say, anyhow they say, I can move forward. And at the end, we get 2 pregnancies who reach the term. 1 twin pregnancy and 1 singleton pregnancy. And from that time, the good news started to happen in my country, Burundi. And I decided to move on for the second batch. The second batch, I went for freeze-all, maybe to maximize the chance. But in my country, many people don't believe in freezing. You are freezing our baby. This is the question. This is the big challenge I got. But as a doctor, I know what is going on. I move forward. And then after doing the transfer, by using those frozen embryo, we got 40% of success rate. And that was also a good achievement for me. And for all of those, I would like to express my tribute to Merck Foundation, to the government of Burundi, to the First Lady of Burundi for everything they did to get where we are now. Thank you very much.
Thank you so much, Dr. Gilbert, for sharing your experience with us. Next we have with us is Dr. Sri Prasad Adhikari from Nepal. He is the hospital director and head of infertility unit at Paropkar Maternity and Women's Hospital and Merck Foundation alumni from Nepal. Welcome. And please, 5 minutes only.
Thank you, sir. Good afternoon, all the delegates and my colleagues and friends. I am Dr. Sri Prasad Adhikari. I'm a gynecologist and obstetrician and gynecologist working in one of the largest maternity center in Nepal, where 20 to 24,000 deliveries occurs in a year. But that is the only the maternity center in Nepal, and which is located in Kathmandu. But there is no IVF center in the government institution. All the IVF centers are only private. So in Kathmandu, my capital is the Kathmandu, where there are more than 20 IVF centers only in Kathmandu, but there is no IVF center outside the Kathmandu, even in the government center. That's why I like to thank Merck Foundation, who provided me training in this infertility postgraduate diploma in sexual and reproductive medicine and MSc course, which was started in 2022. After that, the course, I started the fellowship program in our country. There is a posting of the students to the AIMS in India for a few months. And after that, I was the one who graduated in first in the fellowship program and started IVF in my center. Like Dr. Gilbert said, it was a struggle to me. Nobody is supporting, even the private centers. They are looking after me. Could he able to get pregnancy or not? So in the first year, 2022, we were able to do 22 cases, and there were only 4 cases, I guess, were positive that time, and we were very much struggling. After that, I found one lady who is doing fellowship in PGI Chandigarh in India. So I requested her, and another lady who was doing embryology course in India. So after the help of those 2 ladies and management team and the government help, and thank you Merck Foundation for your initiation to make me that knowledgeable in the infertility. And then after that, we are able to do 50 cases in the second year, and then our success rate is good. We are having 20% success rate. Thank you very much for the Merck Foundation, which has helped me a lot in this training. And beside that, the government has planning to establish at least in the provinces, IVF center in all provinces, but there is no training center in Nepal. So we are planning to develop a training center in my center so that all the doctors and embryologists, they can be trained in this in my center, and so that they can provide the services in the government centers in a low cost and cheap price. Like my center is we are giving subsidized rate, and we are giving deliveries. All the neonatal services are free. So we want to provide services in very low cost, and that's why I want to request Merck Foundation to support in future also for the embryology and other part. Thank you very much. Thank you. Thank you.
Thank you so much, Dr. Adhikari. We are very proud of the wonderful work that you are doing. Next, we have with us Dr. Mugove Gerald Madziire, consultant obstetrician, gynecologist, program coordinator for OBGY, Faculty of Medicine and Health Sciences, University of Zimbabwe, and Merck Foundation alumni. Welcome.
Thank you very much, Dr. Shadam. Good afternoon, everyone. Thank you very much. I would like to thank Merck Foundation for the opportunity to train us, but I would also want to acknowledge Dr. Vipin Chandra. I've got 2 other colleagues who were together at Indra in Udaipur, and they gave us lots of hands-on experience when we really didn't know much, and they took us through everything, firstly in their simulator lab and then the transvaginal scans. He did promise us that eventually would be able to see the uterus and identify it. And I'm sure now I can tell you I've become an expert in transvaginal scanning and picking up lots of pathologies. So it has really been a very useful exposure. But moving on, like my colleagues, we've all benefited from this initial training, and then later on, we got theoretical trainings as we did the diplomas and the masters and from other areas as well. The process which I've gone through in my country, firstly, we have got very limited diagnostic capability in the public sector. So we have to rely mainly on the private labs, even for the government patients. So we've been advocating to get good diagnostic capability in the form of fluoroscopy and being able to do the hormonal assays. So being the chair of obstetrics and gynecology, I've also tried to champion that we teach as much as possible in the fertility arena. We are fortunate that we've got other colleagues who have been trained in endocrinology and in fertility endocrinology. So that has made it very useful. So my first big challenge was to champion for coming up with a public IVF center. So it was lots of lobbying, and I'm able to say we eventually had a breakthrough. As I speak, we've now got a complete unit. I tried to send some pictures to show that might be a bit late. We've got now an IVF center where everything is, all the superstructure and all the finishing side are done. And we've been promised that now money, we've done the budgets, we've actually done all the quotations for everything. So we've been promised the money. Of course, we know if you are promised money by the government or university, it doesn't come as quickly as you would wish, but we are in the process of lobbying out for their money. So I think the biggest advantage which I got from this training was to make me a better teacher because I teach postgraduates. So it means it's actually helping creating a critical mass of specialists who can who can teach fertility and even teaching other skills like transvaginal scanning, and even the undergraduates who quickly expose them to the knowledge which I have. So I've been fortunate to be able to run cycles in private. We now have got 3 IVF centers in Zimbabwe. 2 of them are in Harare, the capital city. So I've been able to ever since I came from Indra. I think by the end of the year, I managed to get access into one of the private centers where I can take my private patients. But of course, my focus is really to try and have it going on in the public sector. And again, I've done a systemic review and meta-analysis looking at methods of making IVF cheaper, and we've run that analysis and looked at the issues of low-cost stimulation and other various ways, which I think is the challenge which we have, that the cost is a lot, even within the public sector. We don't think government will be able to fund it, so we still have to rely on patients coming up and making some payments, but we have to find the ways of making it cheaper so that the majority of our patients can still be able to access within the public sector. So in fact, we also be lobbying that the other part of the country get also a public IVF center, and maybe just relying on existing infrastructure and then modify it so that it can be used as an IVF center. So once again, I thank Merck and I thank Intra IVF and Dr. Vipin here present. Thank you very much.
Thank you so much, Dr. Madziire. Those were some really kind, nice words. Next, we have with us Dr. Mackenzie Musebo Bright. He's a consultant obstetrician, gynecologist, fertility specialist from the Levi Vanawasa University Teaching Hospital, Lusaka, and Merck Foundation alumni, Zambia. Please.
Good afternoon, everyone. I've already been introduced. I'm Mackenzie Bright. That's my name. Success stories are better said in seconds and not even in minutes. So I would love to thank Merck that as the Zambian team, we do not have a public IVF center, but luckily, after getting the training, we had to put our heads together, especially those of us that are in the capital city, Lusaka, to see how best we can help with the people that are fighting these infertility cases. We have 2 big IVF centers in the city that are all private, but we've had proper negotiation with the teams that are offering IVF. such those patients that are referred from us to them are charged very minimal. Because what happens, they just go there for IVF and then we do the follow-up ourselves in our own public hospitals and we deliver them ourselves. So that's what has brought them to be paying very much minimal fees. And I must mention that for this particular year, we've had about 98 patients that we've been following up. And out of those, through investigation 31, we managed to do complete investigations. And out of those 31, 19 successfully conceived. And we've delivered, in the last quarter, we've delivered at least 5 successful pregnancies. And I was led to post something that's very interesting story. Like last week, we managed to deliver our 59-year-old that was undergoing IVF with a very good bouncing baby boy that we did. Yeah. And on top of that, we started for the past 2 years, we've been fighting to come up with a constitution for the Zambia Fertility Society, because we had issues in trying to open up one. Most people were saying, no, but you already have the Association of Gynecologists in the Zambia. Why do you want this fertility to stand on its own? We said, no, this is a policy. And I must thank Professor Shirwasi. He helped us with the steps. He sent us the constitution and we got some other constitution to come up with our constitution, which we finalized and we submitted to Registry of Society and it has been approved. And very soon we'll be able to announce and register with the IFFS. Thank you so much.
Thank you, Dr. Mackenzie, and congratulations on that. Next, we have with us Dr. Mahamadou Lawali. He is an obstetrician, gynecologist from the Nigero-Turkish Friendship Hospital and Merck Foundation alumni from the Republic of Niger.
Merci, Dr. Shadab. Chers maîtres, chers collègues, je vais parler en français comme c'est un pays francophone. Donc, bonsoir à tous. Je me nomme Dr. Mahamadou Lawali. Donc, je suis gynécologue obstétricien pour ne pas trop retarder les choses. Et je suis au niveau de l'hôpital. D'accord. Il m'a dit de parler en anglais. Bon, je vais essayer. Good afternoon. Okay, I benefit from a fertility training scholarship in India, in Bangalore. And thanks for the cooperation between Merck Foundation and my country, Niger. During the training, I was introduced to modern assisted reproductive technology. Okay. And then we have a lot of medicine doctors who have benefited of formation at on oncology and on fertility and diabetes. My internship was highly beneficial for my community as it enabled to the opening of a public fertility center at the National Reference Hospital and another center at the Niger-Turkey Friendship Hospital, where I work. Offer fertility service to support couples struggling with infertilité. Donc, on offre des services de fertilité à des personnes qui sont démunies, notamment à travers le traitement de certaines affections, telles que l'infection, et à travers certaines interventions sur les tubes, donc sur la trompe, et à travers certaines interventions sur l'utérus, notamment donc, les différentes myomectomies. Et on a commencé aussi à faire l'hystéroscopie diagnostication. Donc, to implemented intrauterine insemination procedure and other assisted reproductive technology, enhances spermatogram analysis according to international standards. Currently, the establishment of this service is delayed due to the absence of regulatory frameworks governing assisted reproductive technology in Niger. I would like to express my sincere appreciation to Merck Foundation, to Senator Dr. Rasha Kalej for the unwavering committed to Africa's advancement, to Milan Center team for their dedication and support. Thank you all.
That was wonderful. Thank you. And last but not the least, we have with us Dr. Vakil Kumar Lilodhari. He's a specialist senior obstetrician, gynecologist, fertility specialist at SSRN Hospital and a Merck Foundation alumni from Mauritius. Welcome, sir.
Thank you, Dr. Shadab. Good afternoon, distinguished professors, fellow colleagues, doctors. Okay. Good afternoon, distinguished professors and fellow colleagues. I am Dr. Vakil from Mauritius, a small island in the Indian Ocean. So with a population of 1.3 million only. However, with a growing economy and hence a population with delayed childbearing age. So based on recent demographic parameters, the fertility rate is on a declining trend with only 1 child per 100 couples in Mauritius. So however, fertility services are quite expensive and mainly privileged for patients attending the private health institutions. So hence the government of Mauritius has decided to explore and address the problem and initiated the project of establishing a fertility clinic in the public sector. Following that, so a fertility clinic was launched in 2022 to address the healthcare needs of couples facing fertility issues. And so far, we have had 1,000 attendances. Furthermore, we do have 4 regional hospitals where gynecologists are providing basic infertility care. We don't have an IVF center in, we don't have IVF centers in the public sector. So currently what we do in the public sector, we provide basic fertility services, workup, endoscopic surgeries, medical management, and since the beginning of this year, intrauterine insemination. So the Ministry of Health and Wellness has approached the Merck Foundation to facilitate training of gynecologists and laboratory technicians. I was one of the gynecologists trained at Indira IVF in Udaipur, which has been a wonderful journey rich in knowledge. So, and this facilitated by the Merck Foundation. So, however, we do face many challenges when we set up a fertility clinic in the public sector. The first one is the cost implications and legislation regarding gamete donation. So we don't have proper legislation yet. And all these are currently being addressed by the Ministry of Health and Wellness. And to enhance the quality of care and make it sustainable, the following developments have taken place. So acquisition of new equipment, introduction of intrauterine insemination, as I mentioned. This has been a stepping stone in fertility care in the public sector, as and patients are being offered free cycles. So the same in private in Mauritius costs about $2,500 for free treatment cycles. In addition, for provision of care, there is also capacity building with the Merck Foundation. So we are also training midwives to provide counseling from pre-conception care to address risk factors for infertility and to work in the fertility clinic. So we are also dealing with a legislation, like I mentioned, like egg donation. So we are, with the help of both local and international reproductive medicine experts. And lastly, we also would like to explore the possibility of public-private partnership. So I would like to thank the Merck Foundation and Indira Fertility Academy for providing this excellent training platform to doctors around the world, mostly in Africa and Asia. And I strongly believe that the training provided will definitely help doctors of this part of the world to become better ambassadors for many infertile couples who live with a hope and despair trying to become parents. Thank you very much.
I'm Dr. Noah Dennis. I'm from Nigeria. I would like to call upon our next speaker, Dr. Bernard Kweku Okai from Ghana. He is a teaching faculty for Women's Health Program, University of Buckingham in UK, fellow in reproductive endocrinology and infertility at Kung Fu Anokia University Teaching Hospital, that should be in Ghana, and a Merck Foundation and Luminary from Ghana. He'll be talking today to us on the topic hypertensive diseases and emergencies in pregnancy. Dr. Bernard, the floor is all yours. Please welcome you with a very big.
Good afternoon, everybody. Good afternoon, House.
Good afternoon.
Yes, my name is, as has been introduced by Dr. Novia Bernard Kweku and a Merck Foundation alumni from Ghana. I'm sure the topic has thrown everybody by surprise. I mean, we've been talking about IVF, fertility, and then all of a sudden we've thrown in hypertensive emergencies in pregnancy. I think the purpose of this particular presentation is so that as practitioners, we'll be mindful of the fact that some of our practices and even some of our patients are prone to some of these diseases. And so I'm sure subsequently, if we see some of these things coming up, we shouldn't be so thrown off, and then realize where, as ART practitioners, we come in and what we can do to modify our practices to be able to reduce and minimize these particular conditions. So let's go on. As an objective, we want to understand the epidemiology of hypertensive diseases, particularly in Africa or sub-Saharan Africa. We will look at the classifications of hypertensive disease in pregnancy. We will highlight some of the risk factors and then the underlying pathophysiology. We would review some of the effective and possibly effective preventive strategies. And then we'll provide management protocol for specifically preeclampsia. And then we'll discuss the management of severe complications such as eclampsia. So the global picture of hypertensive disease in pregnancy is as follows. It's actually one of the leading causes of maternal morbidity and then perinatal morbidity globally. And then we know for a fact that, and from studies, that up to about 10% of pregnancies are complicated globally by all the spectrum of the hypertensive diseases in pregnancy. Specifically, in when it comes to death, about 50,000 and then 60,000 that are related to preeclampsia, to be specific. And then what we found out about these sorts of deaths is that they contribute to roughly up to 25% of all maternal deaths globally. And then the sad incidence is that almost all these cases typically occur in developing countries, which most sub-Saharan Africa are part. How do you classify hypertensive disease in pregnancy? This is just one classification system. There are varied classification systems, but in my country, Ghana, and then in other African countries, what we commonly adhere to is the National High Blood Pressure Education Program classification. There are various ways other people classify hypertensive disease in pregnancy. This particular classification adopts these four main subclassifications, where we have chronic hypertension, we have gestational hypertension, preeclampsia and its related diseases, and then chronic hypertension with superimposed preeclampsia. As a way of definition, gestational hypertension is when there is a new onset of systemic blood pressure of 140 millimeters of mercury and or a diastolic blood pressure of more than 90 on at least 2 occasions 4 hours apart when the pregnant woman, when it's noticed in the pregnant woman after 20 weeks of gestation. The caveat is that usually for this kind of classification, there is no proteinuria, there is no sign or symptoms, but that doesn't mean that you don't look out for these things. Later on, these things can progress on to more severe forms of hypertensive disease of pregnancy. We also have chronic hypertension, which is diagnosed as, or which is defined as present before or on at least 2 occasions before pregnancy, which is 20 weeks of gestation. And there are times where in Africa, you realize that most of the women will not come to the hospital very, very early. So you are not sure whether you are dealing with a gestational hypertension or you are dealing with a chronic hypertension. And so it goes on to say that if you notice that after 12 weeks of delivery, the hypertension is persistent, then it is most likely to have been a chronic hypertension. And then we have preeclampsia. We will delve deeply into preeclampsia, so I wouldn't want to waste so much time on it. But then typically the main difference between that and the gestational hypertension is that with that one, there is proteinuria, which can be measured objectively or qualitatively using the dipstick, which is commonly available in sub-Saharan Africa. And then in higher resource centers or teaching facilities where we can actually measure the protein in urine, you go on, and then when you get any figure more than 300 milligrams per 24-hour urine collection, or a protein creatine ratio of more than 0.3, you could say the person has preeclampsia. There are also instances where you may not be able to do the proteinuria because of probably an acute kidney shutdown. And so we would also learn of any other features That's what points to the fact that the patient may be having preeclampsia or the woman will be having preeclampsia. And so these are some of the things that would point to the fact that a woman is having preeclampsia if even you cannot get urine. When you realize that the systolic blood pressure is more than 160 in the presence of thrombocytopenia of less than 100,000, when you have impaired liver function, when the kidney functions are improving, specifically the creatinine is more than 1.1 milligram per deciliter, and then in the presence of persistent cerebral or visual disturbances, you can say that the person has preeclampsia with severe features. Later on, we'll talk about eclampsia, so I wouldn't waste much time on it. And then what we have to know is that for people that we even think that they may be having chronic hypertension, there is a risk that they may be a superimposed preeclampsia on it, which may either be a normal preeclampsia or preeclampsia with severe features. And so we'll delve into the main topic of today, which is preeclampsia. Preeclampsia is a systemic disease, like we all know, with various manifestations and a lot of system or organ involvement. We classify the risk factors looking at pregnancy peculiar issues, maternal specific factors, and then paternal factors. So when we take it from up there, we realize that some particular things like chromosomal abnormalities, molar pregnancies, multifetal pregnancies, which usually we get in ART, oocyte donation, donor insemination, and then even some infections can predispose people to preeclampsia. And then for the maternal specific factors, we have extremes of age. Unfortunately, being black itself has been identified as a risk factor for developing preeclampsia. And then the others has been listed. Very interestingly, for first-time fathers and then men who have fathered, women who have had preeclampsia before, they are at risk of subsequently letting their new wives also get preeclampsia. But I want us to look at the other end of the PowerPoint. That's actually where the meat is. Beyond these classifications, they've been able to stratify these classifications into those that are very high risk and then those that are sort of moderate risk. Now, you want to ask yourself, why this stratification? Essentially, it's for us to sort of interventions when you meet such cohorts of women so that you may at least prevent them from developing preeclampsia, or if not, maybe they getting it at a tail end of their pregnancy so that you could easily deliver them and then you get a healthy mother and baby home. And so for the high risk ones, they've been listed there. For lack of time, we'll give the slides out. And so for lack of time, they are on the board as you've seen. And so what causes preeclampsia? There's been lots of schools of thought, there's been lots of postulations, but at the heart of it all is that there's abnormal placentation. And eventually what that does is that it leads to impaired trophoblastic invasion into the spiral arteries, which ultimately leads to a decreased uteroplacental perfusion. This would ultimately lead to placental hypoxia. And then this would release into the system a lot of inflammatory markers. And then the sequel is that it affects almost every organ in the body. So we see that the uterus itself is affected, the baby in there is affected, the liver, the kidneys, the blood vessels, the heart, and even the brain. And when these organs are affected, these are how they usually manifest. And so for the CNS manifestation, usually we have women complaining of very severe headache, frontal headache. There are some who may be complaining of visual disturbance or visual changes. And in its extreme forces, these women may fit what we call eclampsia. We'll get to it. Or in some cases, they may even get retinal detachment, which will lead to blindness, or in severe cases, even stroke with long-term deformities. When they affect the heart, they may lead to chest pain. They may also complain of difficulty in breathing. And then in severe cases, these people may develop an MI. And then for the kidneys, we've talked about the fact that elevated creatinine is a severe feature of preeclampsia in its worst state, it will lead to an acute kidney injury, and then the patient may even need a dialysis even during pregnancy or just after delivery. And then the other manifestations as have been listed on the slide. When we talked about the risk factors, I made mention of the fact that the reason why we try to identify risk factors is so that we would stratify our women such that we know those who require some sort of preventive interventions and those who may not need. Currently, the only proven form of intervention for preventing preeclampsia is the administration of low-dose aspirin. Low-dose aspirin has a number of good effects. It results in reduction of proteinuria preeclampsia. It leads to reduction in composite serious adverse maternal and neonatal outcome. It reduces small for gestational age newborns. It leads to reduction in overall preterm death. And basically how it goes about it is that when you administer low-dose aspirin, when we're talking about the pathophysiology, we realize that there were a lot of inflammatory products that were produced when there is uteroplacental placental hypoxia. And so there is decreased platelet thromboxane synthesis. And then there is increased prostaglandin synthesis in the vascular wall. And ultimately, what it does is that it tries to maintain the perfusion of blood through the placental or the spiral, the placental bed. That's what it does. There have also been some preventive measures that have been possibly proposed that could help, but there are always there are some bone of contentions around some of them, but we would list those that currently have evidence. People believe that for areas where women usually don't take a lot of calcium, when you supplement their diet with about 2 grams of calcium in a day, it sort of helps in delaying preeclampsia or even preventing preeclampsia. And then for women who are able to optimize their pre-pregnancy weight, and then also ensure that during pregnancy they don't eat a lot of weight, they are also able to possibly delay preeclampsia. And then particularly what applies to us is modified assisted reproductive technology, particularly to reduce multi-fetal gestation, which is a high risk for developing preeclampsia. So how do you manage someone with preeclampsia? We'll first look at the non-severe form. With the non-severe form, the catchword is always close monitoring of the woman. And so with close monitoring, essentially what you are doing is that you are monitoring the maternal symptoms. Is she complaining of any of the symptoms? Is she complaining of any of the symptoms that we highlighted earlier? And then if she's experiencing those symptoms, you quickly intervene. The mother, what the mother can do is also to be monitoring the baby's movements. And then as clinicians, we should usually keep an eye on the blood pressure. Recommendations say that you can do it twice weekly, but when possible, you can do it more frequently, depending on the values that you are getting. And then you don't forget to also do your labs. Ultimately, if it remains severe preeclampsia without severe features, you can deliver at 37 weeks. And you may not need to give any form of magnesium sulfate. However, when there are signs of severe features, which we have listed already, you don't want to extend the pregnancy beyond 34 weeks. And so usually once the pregnancy is at 34 weeks, what you want to do is you want to stabilize your patient quickly and then ultimately find a way of delivering the baby, particularly at a place where there's a need so that the baby's care will be taken from there. The goals of treatment is essentially to prevent seizures, control BP, and then deliver the placenta. To prevent seizures, we all know about the importance of Merck sulfate. For Merck sulfate administration, I would not want to dwell so much on it. What I would always say is that follow the local guidelines, but know that there are variations. There are those who want to give the continuous IV infusions, and then there's also the intermittent intramuscular injections. Both have its pros and cons, and so for effective management, follow your local guidelines. You also want to control your BP. Now, the aim of controlling the BP is generally when the BPs are more than 160, 170, 100, you would want to quickly reduce it so that there is a decreased risk of decreased risk of cerebral or cardiovascular complications. Now, your aim is so that you hit BPs of about 130, 50, 130, 59, or on 91, 50 per the Canadian guidelines. 9 as a recommendation where you list more than 150 or on systolic and then 80 to 100 on diastolic. But then here again, to the local guidelines is what you need to follow. Ultimately, what you have to understand is that you shouldn't also crash the BP so much so that it would affect placental perfusion. You have a choice of using parenteral medications. We will not go into the specifics of it, but we are at liberty to use any of the parenteral medications that are available to you locally. And these are some common ones that in my country we use and how we use about it. And then given them, we should be mindful of the complications that are associated with them. When you're able to break them down into safe areas, you could also put them on common oral medications to maintain the BP. And then in my country, these are again what we have available for us. And then as always, you stick to your local recommended medication for that. And then finally, when you've been able to do all that, you aim at delivery. You give this information to everyone. So let's move to eclampsia here. So what's eclampsia? Eclampsia refers to the occurrence of new onset generalized tonic-clonic seizure or coma in a patient with preeclampsia or gestational hypertension. What we have to know is that it's one of the several clinical manifestations at the severe end of the preeclampsia spectrum, and it's an obstetric emergency. What we typically do at our end is that we don't manage it alone. And so when you get an eclampsia, you quickly call for all the help that you need, the supporting staff, not only doctors, anesthetists should be around, pediatricians, midwives, and then all auxiliary staff that may be involved. You have to have a fair idea of what you are dealing with and then be calm and purposeful. The goal of management is always to ensure that there is always a maintenance of the airway oxygenation and then the circulation. And so you want to clear the airway, suction, saliva, and then if possible and available, you insert an airway after the patient has finished fitting. You don't extend the neck, and then you make sure that you prevent further convulsions with Merck sulfate. If there is a presence of high BP, which is not always the case, you may want to control it. And then when you are done with that, you come and do your secondary survey where you do a complete physical examination, including abdominal and vaginal examination. Decide on the mode of delivery, and then you deliver as soon as practically possible. This is just an algorithm that we use at our end, which I'll leave on for those who are interested about this. Okay. We should also realize that Merck sulfate doesn't come without complications, and so we should, when administering it, we should know where the therapeutic range is, and then the effect of increasing Merck sulfate doses and how they manifest clinically. And so these ones have also been listed on this particular slide. And then the intervention we put in when you have too much Merck sulfate, which is the calcium gluconate. So what if the person is still having recurrent seizures in eclampsia after you've instituted all your management? Usually what we do at our end is that we repeat an IV dose only once. And then if the patient is still recovering, still fitting, we move on to other anti-epileptic drug. Usually when the fit becomes very refractory or the person is not responding to the treatment, and we have a whole choice that we use. Here again, I would also insist that try and stick to what you do locally. We have a choice of using phenytoin. Some people would want to still repeat the Merck sulfate, but stick to what your local protocol advises. And so these are what we give and then how we administer it. And then you should also be mindful of the complications associated with it. Once, like I said, eclampsia is considered an absolute contraindication to expectant management. Once you stabilize, you should think of delivery. Once you deliver the woman, that is not the end of it. The patient is at risk of still fits in or developing further complications. And so post delivery, you make sure that you keep an eye on such. So what's our take-home message today? We are saying that hypertensive diseases in pregnancy is a significant cause of maternal and neonatal morbidities and mortalities. For us in the ART, there are some things that we would have to understand that most of the patients sometimes coming to us are at risk or they have some risk factors, and they should be informed how we go about their stimulation and even go about selecting embryos for such cohorts of women. And then for severe manifestation or when the condition sets in, it can only be manifestations and complications can only be reduced when there is early detection, close surveillance during antenatal, and then timely intervention. These are some of my references. Thank you very much.
Thank you so much, Dr. Okai. That was a very, well, thank you for making that simple. So we'll move on now to our next presentation. We'd like to invite Professor Jolene Simpson. He will discuss mosaic embryos detected at PGTA, okay, can be transferred. Thank you so much, and over to you, Professor Simpson. Please welcome him with a warm
I talked about a controversial area in the morning, and I hope we followed that. And most of you look like we're the same people here, and I'm happy to see that. And so that one, you remember, was the issue of what happens when those of us our age, or at least your age, not so much my age, you know, realize that you are at risk for a autosomal dominant adult onset disorder. And it could be cancer, it could be cardiac arrhythmias and the likes of that. Of course, everybody knows about Huntington's disease. So that's controversial enough, you know, and it's been able to be detected based upon the sequencing of availability that we had and accuracy. I'm going to talk to you about really a similar topic, and that's mosaic embryos. And this is very important because it explains some people's failure to show the benefit of PGTA or failure to show the benefit of a number of conditions. And it's really because that there's about 10 to 15% of embryos that, despite a very accurate analysis of measuring aneuploidy versus euploidy, we have not taken this into account. So very important. Is this okay?
Yes, yes. Just hold it a bit closer to your.
Closer to me?
Much clearer.
Again, as I said this morning, usually I get complaints for talking too much, you know, or too loud, but now it's great to be here. Okay, so let's start right now. And so, again, this morning, my colleague here was Svetlana Brzezinski, who's head of reproductive genetic innovation, and has been responsible for the huge numbers that I showed you this morning, which is 34,000 PGT cases over the last 30 years or so. So we have these conflicts that I have alluded to before. And the learning objectives that I have in mind here is to tell you what is the laboratory methodology that should be used and the method that should be used to determine whether in fact the PGTA is accurate in predictive value of what's going to happen here. And that's going to lead also to the concept that we have mosaic embryos in about 10 to 15% of PGTA analyses, and that needs to be taken into account. And if we don't, we're not transferring all of the embryos that could be transferred effectively, and the accuracy of the test is going to be arguably so. So the key thing I would like to get across here is that the methodology is not a standard randomized clinical trial because there's bias, because you've got the embryo in front of you, you've got a patient in front of you, there's some inherent bias as to say, well, she's not going to get pregnant anyway, so why damage that? So it's a different issue. So the value of what really should be done here is called predictive value. And when you first have this concept, you wonder about whether or not anybody can get away with having a predictive value study, because it doesn't seem as if it should be approved by an educational board or anything like that in the hospital. So what you do is, number two, you biopsy the embryo, hold it, don't analyze it until later in pregnancy, and transfer it and see what's going on. So there's no bias there. It's just that it looks like it should be illegal to get away with doing that. But that's because I've always believed in PGTA. And for those people that don't believe in it, this is what you need to hear. So we then have a retroactive comparison of pregnancy outcomes after the transfer, usually about 11 weeks. So at that time, you open up the envelope and see what happens. And that's what would be the key things right there. So this was first done by Richard Scott, who's in New Jersey, still active. And this was his result in 2012. Keep that in mind, because there's going to be a better mousetrap in a few years later. And we're going to reanalyze the same thing. So you can see that if in retrospect it turned out that you had a euploid embryo, you had 42% deliverance. And if you had an aneuploid embryo, it's 4%. Now, we now think that the 4% is due to mosaic embryos. Hasn't been proved per se in this issue, but just bear that in mind. And even with this right here, we had situations that that were valued using this 2012 array CGH test. For those of you who are keeping up with this, you could prove, or at least show in this case using RCT, and all of these are RCTs in a single unit. So it's not a randomized thing that accumulates data from 15, 20 different cases. That's variable, and it's not as robust as what you have here. But each of these, you look at the controls, you look at the PGTA, and you have 20% success rate. So in this particular case, you know, it improves the take-home baby rate by 20%. Can't avoid that. Now, as I mentioned before, we need better mousetraps anyway than what the rate of the CGH, and we have that. So just to go back in 2000 to 2010, for example, we had a very poor ability to assess aneuploidy. And that poor ability was based upon the fact that we had fluorescent in situ hybridization. Those are dyes in. You can only get about 9 dyes in at the same time. So you started out with not having the ability to have a complex and a complete analysis. 2010 is array CGH. I'm not going to go into that, but it's still useful in other circumstances, not necessarily here. And now we have next generation sequencing. So thank God, one of the things that's very important about next generation sequencing is it's really simple. You count DNA. That's all you do. You count it. Really not complicated. Could be complicated. And so using that same next generation sequencing, let's look at what that looks like. So look to the left over here. This is 46XX normal. So if it's normal and it doesn't have aneuploidy or either trisomy or monosomy right here, in that particular situation, there should be the same amount of DNA in a sample and then a reference that you looked up. And that's what you got. Right in the middle of that, 2.0, for those of you up close who can read, you can see it's the same as the thing. So there's nothing missing and nothing excess. If you move over to the middle, you see that the same thing occurs for first 15 chromosomes, and you get to number 16, and it drops down. So there's only 1X as opposed to 2X counts for DNA. So that's monosomy. And this happens to be a boy. And so since the standard is meant for XX as opposed to XY, once you get to the other X, it drops down. And that's the reflection of the male in that case. Then you move over to the third box here, and you see 46XY, XX now again, and now +2. So now we have trisomy 2. It's very simple. And this is a slight modification of that, shows you how we're going to detect mosaic embryos. Now, so if you do that sort of thing compared to what we did before, this is what Dr. Scott and his team did in 2021. So euploid embryos, in retrospect, 82% were implanted, very good rate, 73 clinical pregnancies and 64% deliveries. So, you know, success has arrived here. If you look at the aneuploid, you get 0 deliveries, no take-home babies, but it's worth noting that you have 23% clinical pregnancy rate. So you transfer an abnormal embryo and it implants. It just doesn't last. It's not sustained in that particular area. So let's move over to the next things in terms of assessing what to do. And a very exciting study, I think, and Chandra, I just put this here directly for you. This is for you. We could comment in the questions and answer sessions. So here is, again, that same group, Scott, and you can look down here, Fertility 2021 is a reference if you want to look at that. They said, well, let's take women, and if they don't, we transfer a euploid embryo, and we don't get a pregnancy rate, we don't stop and assume it's another mutation or it's an RIF. Instead, we repeat it again. So the first transfer, you got 69% sustained implantation, 64% take-home babies, and then we repeat it again. In that situation, at the end of the day there, we have 54%. So we transferred a euploid, it didn't work, and then came back and we repeated it again, and we've got 54%. Same thing the third time, another 54%. At the end of the day, you got 92% take-home baby rates for these women, you know, but you have to repeat it. So I wished you had shown me a little bit this morning, Dr. Chandra, but in particular, I love the slide that had the soil in which the you dropped in the seed, it didn't work. So I think that's what's going on here. Or you could say it's a stochastic change, it's just bad luck. You know, if you transfer the embryo to a different part of the uterine, you know, the endometrium, you know, you don't have to invoke a lot. So that's something maybe we could talk about there. Now let me jump ahead to where we are in the United States. Let's go past this. I think we can do that. So here's really what happens in multiple pregnancies that in which you have transferred a euploid embryo and a aneuploid embryo. So the top line euploid, of course, you know, midway through pregnancy is 71% pregnancy rate, but it doesn't last at 64%. So you have miscarriages and stillborns at the end. Aneuploidy, 25% positive pregnancy test, but at the end of the day, you got nothing. That's what's going on. So that's a take-home message. Don't believe that just because you have an aneuploid embryo that you're going to have a miscarriage, something of that sort. Now, something else that's very important I want to let you know about. Hold on, let me see. I don't have an order here. So I want to tell you why in the United States we're very proud of the fact that single embryo transfer is taken off. It's taken a long time. The British in particular criticized us enormously for a lot of time since the 1990s. You've got zillions of multiple embryos coming through. It's stupid. So here's the 202 data. So 2.5% of all births in the United States are from IVF. That's a number from American Society of Reproductive Medicine. The singleton concept is 96%. We have very few multiple embryos, and we're very proud of that. The single embryo transfer rate was 74%, which is why there's only 96%, very few are not. And for those of you interested, egg freezing is about 30,000. So that's moving up quickly in that situation. Now, embryo transfer is preferred in these situations, you know, and it's preferred for the reasons that we've seen. In addition, there's one additional information that I want to show you. This is a randomized clinical trial, old-fashioned randomized clinical trial by, again, Scott's group. This was led by, Foreman. So to the left, you see the study design. There was an IVF pregnancy rate of a single PGTA embryo, and the other side was 2 non-tested embryos. And so the red represents the pregnancy rate after the single PGTA. The yellow represents after 2. So first of all, they both worked. 65% pregnancy rate. It's a good lab. On the other hand, you then flip to the other side over there and you say, well, how many twins were there? So the twins for the PGTA group were 0, and the twins for the untested embryos was about 50%. So if you put the bottom line together, most of the babies that were born by transferring 2 embryos, really were multiple gestation, which is not what we want. So let's go back and now talk about mosaics. I've told you that. We can pass on that. So the mosaic embryos, we've always known that there's mosaic embryos.
So last 5 minutes, please.
Okay. We've all known there's mosaic embryos, but we didn't know what to do with it. So beginning around 2015, Greco, who's a very good Italian group of geneticists in PGTA, said, look, why don't we just transfer it anyway? Italians, I guess, would have that thing. So it worked there. So Greco published this in a letter to the editor to the New England Journal, and you can read, perhaps not in the back of the room. So 18 mosaic blastocysts were transferred, implantation rate 44%, miscarriage rate 11%, and the pregnancy rate was 33%. So remember now that the contrast is 32% take-home baby rate, 1/3 versus 0 if you didn't try. And so that's the message. And so the other stuff, we don't need to go over the numbers right there. Now, where do these mosaic embryos come from? Here's a nice paper that was published by Vero Rodriguez and Carmen Rubio, and this shows you what happens. So this is a blastocyst. You can't see this when you're doing a biopsy. All you know is you've got a blastocyst, and you're closing your eyes, you don't know what you're going to get. So at the top, you've got a mosaic embryo that's got a circle of circles. Some of these circles are red, meaning that it's aneuploid. Some are not red, and they are euploid. You've also got in the middle, I'm not sure it's safe to try to point because we may not get it back. This is the intercell mass right here. So that's going to be the organ systems in the embryo. And then around here is going to be the placenta. So you can see there are some of these that you could have biopsied, and you could have been having a completely euploid embryo. That would be here. If the only red dots are in the middle, you're not going to get the red dots. And the converse here. So this is what's happening. Now you could say, well, this means the whole thing is very inaccurate in the situation. But fortunately, there have been concordant studies, and they show about 90 to 95% concordance. In other words, there needs to be a match for the organ system, the intercell mass, versus the trophectoderm. We really don't care too much about what happens to the trophectoderm. We care a lot about the embryo. So where did these mosaics come from? That's an obvious question to ask. Well, so let's go back to what we had before. What we had before was straight lines here. And this time, this line and that line represent something that's neither fish nor fowl. It's not 2x, it's not the expected number of DNA counts, but on the other hand, it doesn't reach down here, where this would be a monosomic embryo. So it's more sensitive. That's the possibility of next generation sequencing. That's what it's all about. That's why you do the best in terms of doing that. So you can flip down and you can see the second one You can also get an aneuploid embryo. This one is monosomic, this cell, and this one is trying to be trisomic, or the other one, and it doesn't make it, meaning it doesn't have the same count for that particular chromosome, but it's abnormal nonetheless. Now, on the other hand, so let's see how frequent this is. So this is what happens in our own unit. This is 14,000 cases that were looked at. So aneuploid, euploid is 44%, monosomy is 13%, trisomy is 11%. All this is kind of unexpected. The top three, yellow, purple, and green, are a little different. Complex means you've got multiple chromosome counts that are abnormal. You need to throw it out because it's not going to lead to anywhere.
So last 2 minutes, please.
Pardon?
Last 2 minutes.
I don't know about that, but I'll try. So, so mosaic embryos, 8%, and segmented are 14%. So here are the types of mosaic embryos. Number one, if you have chromosome mosaicism for two different types, that's what we're used to, but that's what we learned in junior high school, something. So that's, this is probably, this is associated with the maternal age fact, and it's probably not, it's a different issue. And then segmental mosaicism is the ones in which you're most likely to be able to transfer. So let's see what that's meant. The mosaic embryos that are segmental, this is not related to maternal age effects, so you're not worried about trisomies. It's usually got a lot of microdeletions and microduplications. And the third bullet explains it. This is, we had discussions this morning about the fact that you haven't given the self-DNA replication enough time to properly do that and kick out the cells that are not going normal. So this is the key thing right there. So if we look at all of these chromosomes here, the reds are duplications and the blues are deletions. And you see the big chromosomes are the ones that have the largest number. That makes sense. They're big, it takes longest to finish the sample size. And therefore, this is a artificial problem. It's not something to really worry about. So the final few minutes, it's going to be a long 5 minutes, but it'll be fairly quick pause. So the bottom line here is the key statement that I want you to take home is that there's no such thing as an embryo that is 100% euploid or 100% aneuploid. It doesn't happen. And so instead, what you've got is a gradation from completely green, at least in theory, to the left side to completely red in the right side. And the ones on the right are not going to make it. You don't want them to make it. The ones on the left, you hope that they do. But it's not perfect in that situation, and it doesn't need to be perfect. Look at these numbers. Euploid transfer, 57% implantation rate, ongoing pregnancy sustained, 52, 8% miscarriages. Move down to mosaics of all types, 46% implantation, 37% ongoing, 20% miscarriage. So if you transfer a mosaic embryo, you are more likely to get a miscarriage and more likely to fail to implant than if you have a euploid embryo with less than 20% aneuploid. And of course, you get greater than 80% aneuploid. You have no business unless you like to be in court in America or Europe. Not a wise move right there. Okay, so the final few seconds here. What do you do? This is what Feature GIS, Pre-Implantation Genetic Diagnosis International Society will recommend it. You transfer the euploid embryo if it's available. Common sense. If you don't have a euploid embryo, you discuss it with the patient and you transfer it if you have at least 20% euploid embryos and preferably up to about 50. But if it's higher than that, then you probably don't do that. And this is a discussion with the patient, a lot of argument between Dr. Chancellor and myself and all of our colleagues when we were over wine somewhere. But anyway, that's the bottom line. If you transfer the mosaic embryos, counsel miscarriage rate higher and implantation rates lower compared to usual, there's no particular threshold that you can depend on. Because if you repeat the test, it's the same, it's not the same each time. So you can't look for 43 versus 38 because one is 43, the other is 38. The transfer of the embryo doesn't need to take into account the chromosomal disorders that are on the embryo that is transferred. First of all, we don't know that much about it. Okay, this truly is the last couple of slides here. So what happens if you have a large scale study? So this is such a study, and this is up to 4,000 to 5,000 cases now. It hasn't been updated. So here is a 1,000 consecutive mosaic embryos. At the top, 20% of these don't make it. So you can drop your numbers down by 20% over 455 if you really like that. What happens ongoing? There's 80% that make it. So you want to get a figure 80% success rate if you transfer mosaic embryo. Then what happens? Number one, the mosaicism is rarely preserved throughout pregnancy. There are a few cases like that. So don't say they're none, don't say it's zero, but it's not a lot. And these are the numbers. I hope they can get the slides in here, look for themselves. So the final study right here, this is what we believe in the Pre-Implantation Genetic Diagnosis International Society. Here we are. If available, euploid embryos should be given priority. Higher levels of mosaicism greater than 50% versus less than 50% are going to be associated with decreased implantation rate and increased miscarriage. I've said that again, but I wanted to come home. The patient should be informed. This is a key thing. Don't say you got a good embryo. Consent form should be modified and the patient should be counseled. That common sense and good medicine. There are data from other organizations. ESRI has said low mosaic embryos are suitable for transfer. ESRM, the same things. Do not consider mosaic embryos as abnormal. They may be, but do not just consider that automatic. So the summary then, I think we've gone over that. Next generation sequencing is really important to understand the definition of a euploid embryo is no more than 20% aneuploid, and the converse for an aneuploid, and 10 to 15% of embryos are mosaic. So apologize for going over. I owe you a glass of wine after this is all over, and I will be happy to be taken up on that. Thank you very much.
Thank you so much.
Was Dr. Panayota Zamakupis. She's the Medical Director, Center for Fertility and Reproductive Endocrinology, and Assistant Professor at the University of Pittsburgh in USA. So her topic was quality management in IVF.
I'll start by the definition of management, which is people together to accomplish using available resources efficiently and effectively. It does include planning, organizing, staffing. In particular, when it comes to healthcare, the characteristics of practice management, product is specialized health services, staff, very educational experience background, nurses, sonographers, laboratories, or a major corporation or hospital. Quality is defined by WHO as the process of meeting the needs.
We do have to focus both on patients. Forget that. In the American Medical Association, quality is the degree to which care services influence the probability outcome. Total quality management is comprised of three components. We have performance management and risk management. Performance management encompasses all activities that ensure goals are consistently being met in an effective and efficient manner. It does focus on the performance of the organization. It includes programs for training and education of its employees and staff. and it sets quality goals and policies. It allocates resources to achieve those goals, and it also involves continuous monitoring of results. Quality management is customer-oriented approach. So in regards to patients, we need to continuously meet their needs and ensuring their satisfaction. Leadership and personnel should both be involved. It is a process approach, and all decisions should be made based on evidence. There should be attempts to continuously improve in response to feedback from clients, i.e. our patients. And ultimately, we need to satisfy patients' needs in a cost-effective manner. Risk management involves the strategies to face possible damages, limiting their consequences as much as possible. There is no organization that is devoid of crisis and risk, and the organization needs to be ready and prepare for such crisis, because we also know that failure to manage crisis can result in serious harm and losses for the organization. So how do we implement total quality management? We need to remember of 4 letters: PDCA: plan, do, check, and act. So we plan by defining a problem and collecting data. Then we developed and implemented solutions, so we do. After we've implemented a solution, we check to confirm our results, and we do a before and after data comparison, make sure that we've improved. And then we act by documenting, informing others about our changes, recommending specific ways to improve and solve problems. And then, of course, the cycle can be repeated in the next with the next assignment. We would like to implement total quality management because within healthcare specifically, that will help us provide high quality patient care. It helps improve efficiency with decreasing costs. And ultimately, it's part of the practice's competitive strategy, because it will ensure that you will be able to have your market share and improve that as you build your practice and expand your services. The total quality management has 2 important aspects. The one that we all know and we focus on is really the technicalities, which is a tool. This is the standard operating procedures, documentation, traceability, be ready for a crisis, and how do you approach audits, internal, external, etc. But the most important aspect of total quality management is really the culture. This is part of the group identity, and it's something that needs to be fostered within the organization itself. Building a quality culture is a way of thinking, and it involves literally a cultural shift. It starts from top to bottom, from the management of an organization all the way down to the lower level staff, and it involves everyone. The culture needs to be that everyone is important. We listen to everybody. We show that we listen attentively, and ultimately we act accordingly. So why is building a quality culture is important? How do we persuade people that need to buy into quality? I'm gonna tell you a little funny story here, and then you can understand what I'm trying to convey. So this is a story about 4 people named everybody, somebody, anybody, and nobody. And there was an important job that had to be done, and everybody was sure that somebody would do it. Now, anybody could have done it, but ultimately nobody did it. So somebody got angry about that because it was everybody's job. And everybody thought that anybody could do it, but nobody realized that everybody would not do it. So it ended up that everybody blamed somebody when nobody did what anybody could have done. What does this say? That if you're in a big organization and you see something that is wrong, but you don't say anything or you don't act on it, you expect somebody else to do it, and that's somebody else didn't do it. Ultimately, things will fall through the cracks. Mistakes could be made, errors that can translate in major losses can eventually happen. And it takes everybody to try and avoid something like this. So everybody needs to be sensitive and not expect somebody else to do something that they can do themselves. So it is a funny story, but it just summarizes, I think, the culture that needs to be built in an organization in regards to quality and management. So total quality management in healthcare is a rigorous set of processes and techniques to measure, improve, and control the quality of care and service based on what is important to the patient. Again, the central focus point is the patient's needs and what is perceived to be important from the patient's point of view. Because ultimately, the quality of the organization equals the quality of care. And that is both outcome, but also patient satisfaction. So let's just talk specifically about a fertility practice and how we can integrate quality management. So as you all know, working in the IVF world, IVF practices are very unique, and the specific unique characteristics are our patient population is very knowledgeable about the treatments. They have high expectations, especially because they cover usually most of the expenses out of pocket. So the population is highly motivated, and the success rates are very important, leading or guiding, I should say, the choice of practice and clinician that the patient will trust their care in. So the purpose of a quality management system is, simply put, say what you do and do what you say. So it does provide the tools to clearly delineate what everybody's responsibility is within the organization. So you have to be very clear about what are you about, why you do what you do, how you do it, and how can you do it better. So you need strategy, you need policy, planning, objective setting, you need control and assurance records, you need audits, evaluation, and ultimately improvement. Quality management systems are derived within the organization itself. It is not something that's going to be imposed from the outside, and the documentation is the cornerstone of any quality management system, and it does ensure that the quality of services is met. It is important, especially in IVF centers, because IVF organizations are very complex. They're literally mini hospitals, if you think about it. And every aspect of the organization is intertwined with the other. A change in one area can quickly affect others. If one area fails, the organization might fall apart. Failure of one discipline to function properly results in potential serious errors. And the infrastructure for all players is to communicate and achieve the common goals of the organization. And here you can see how the IVF center mimics a little mini hospital in a way. You have doctors, you have nurses and phlebotomists, you have admin, CEO, you have andrology, embryology, endocrine lab, you have ultrasound technicians, you have secretaries and receptionists, and then you have the billing and financial personnel. So the quality management system is comprised of the following aspects. There is documentation, a process approach, setting expectations for staff. You need to understand that you should never be happy with the status quo. Leadership takes a huge role. Communication is paramount, and ultimately everyone should focus on the customer, which is the patient. So I'll start breaking it down one by one. Documentation, as we all know, it involves any record that should be clearly identified. All the documents need to be organized and maintained appropriately. There has to be someone assigned in the organization that is in control of all documents. All the revisions need to be authorized and recorded. Each employee should know where they can find the latest version of every document, and every process that goes on in the organization should be written down. As we said, it's all about say what you do, and then of course, do what you say. So standard operating procedures, basically for everything that goes on in the IVF center. So the document control process, you start by creating your document, then it has to be approved, released and distributed, and then it is put in use. If at some point changes need to be made or it needs to be reviewed, an update is created, and then again, it has to go through approval, release, distribution, and use, and you loop around the whole cycle again. So documents is everything. Documents could be SOPs, patient information, letters, clinical records, procedures, date timing, any communication that is part of the record, whether it's the nurse's note or it is the clinician note. It has to do with any consumable information that comes into the lab. And all of these records need to be kept in order and readily available. Next is a process approach to problem solving. So any problem has to be analyzed based on facts. You're going to try and come up with a solution. The corporate decisions require careful analysis and process, and everything has to be in a methodological way. So everybody's suggestion and input needs to be heard and analyzed. Ultimately, decisions or practice should be evidence-based. You need to approach non-conforming products or services. For example, you have two aspects, as I said, to everything. There is the operational aspect, where you're going to identify errors or flaws or mistakes, or you can see after putting an SOP in effect they were suboptimal, and then try and revise it and correct it. But ultimately, the most important thing is the culture within the organization, that every employee is focused on quality and every employee knows that can contribute actively towards better quality care for the patient. So building a quality culture starts with the idea that if a mistake is made and it's recognized, and we know that always there's going to be a mistake or an error that will happen, that will prompt a non-judgmental approach to analyzing the facts to lead to corrective action. And from there to go into preventive action by changing the SOPs or the routines or the way we operate to prevent future mistakes and errors. It has to be to the point where, for example, a lab employee or a lab staff can make a recommendation to the chief medical officer. The chief medical officer needs to be open to hear such a recommendation, even if it is from, let's say, a junior embryologist or a junior andrologist. You need to have this culture of accepting feedback without being judgmental towards getting your process better for quality care. Internal audits need to be made in regular intervals, as should be external audits, for example, for your embryology lab. Anything needs to be documented. Dates, signatures need to be in every document. For example, you have, specimens that are frozen. When you do an audit, you need to see, okay, in this door that we have non-infectious, let's say, semen samples, has all of the serology been documented for every single patient? You need to document equipment variables. Are the decisions that were made at any given point of patient care according to the SOPs? For example, you have a patient undergoing IVF, she has a hydrosalpinx. Was the hydrosalpinx removed or clipped before the patient underwent an IVF cycle? The next point that is very important about quality management systems is setting expectations for the staff. There has to be clear job descriptions and expectations for every employee. And also the training and the competency has to be clearly identified on how we're going to manage. When a new employee comes in, undergoes standardized training program, there is a training log that needs to be kept for everybody. The new employees need to read all the SOPs, sign that they've read them and they're aware of them and where to find them. And there has to be a continuous education program involving everybody. Very important aspect of quality management system is that you should never be happy with status quo. You have to foster this approach of continuous improvement, and every employee should be encouraged to share their ideas for improvement. Nobody knows best how one person can do their job but themselves. A receptionist knows how best to control the flow of the practice, for example. The CEO doesn't know that, or the physician doesn't know that, or the physician knows how to better control their schedule, not necessarily the embryologist. So everybody knows best what they can do themselves. So the culture needs to be that we hear from the people that do the work how we can improve the organization. Leadership is the ones that take over developing the mission and then ensuring that everybody follows the mission of the organization. They have to establish unity of purpose and direction for the employees and create an environment where people are fully involved in achieving the organization's objective, which would be best quality care you can offer to the patient. And communication, as we all know, is of paramount importance. Miscommunication can result in significant medical errors, but also it's very important how the patient can communicate with the practice. It would be a very disappointing element of the practice if, let's say, a patient calls, leaves a voicemail to the nurse, inbox is full, nurse is overwhelmed, the nurse doesn't get back to the patient but 3-4 days later. That would be unacceptable. That even if the patient gets pregnant, ultimately, that would not be a good comment from the patient, that the communication was not effective within the practice. And finally, we need to focus on the patient. We need to focus on improving quality, and the quality needs to be measured. It's not like, oh, we feel we're doing good because our success rate is good. That's not good enough. Customer satisfaction is the tool that determines the ultimate success of the IVF center. The patients need to be given questionnaires or surveys that they can give us feedback, so we know that we indeed are providing good service. We need to focus on the fact that we're providing service. We're not providing end product. We're not providing babies. We provide good quality care, and we need to remember that. There are a few slides here about the embryology specifically, just to know how things have developed over the years. Originally, the lab manager was based on experience, apprentice system of learning was not specialized or structured. We had no specialized equipment. We prepared media in-house, and we made shift equipment, and there was little monitoring of conditions within the lab. And fast forward to the present day, we have highly qualified embryologists, structural learning, strict regulation. We have quality management systems, quality control, quality assurance, risk management, audits, document controls, etc. And this is everyday embryology practice. We have so many regulations and guidelines. We have peer-led guidelines we need to follow. We have regulations and legal framework based on the country we practice in. We have international standards. We have consensus meetings and KPIs. The quality control in the lab consists of constant monitoring of the products, constant monitoring of the laboratory conditions, benchmarking, evaluation of the performance, troubleshooting, dealing with problems, validation of equipment, planned preventive maintenance, manual of all equipment, log faults, service dates, everything has to be recorded, calibration of external measuring equipment. Now, obviously, performance and monitoring performance at the embryology lab is of paramount importance. We all know of KPIs, key performance indicators, which are a universal tool to help manage the laboratory in our particular case. An example would be blastocyst utilization rate, for example, the percentage of 2PN embryos that are either transferred or cryostored on day 5. And here from Reproductive Biomedicine Online, you can see key performance indicators on the left, and then you have competence value and benchmark value. For example, ICSI fertilization rates for competence value would be okay if you're above 65%, but for benchmark value, you want more than 80%. Blastulation rate would be benchmark above 60%, competency above 40%. So in summary, we need to remember plan, do, check, act are the 4 ways of going into quality care. We need to understand that quality management ensures reproducibility, consistency, and cost efficiency. We need to be able to pick up problems before they affect our program. We have to be proactive in prevention, so we identify the nature and causes of potential problems and develop a strong safety culture. We need to always remember that quality is more than just safety. We need to learn from events and make improvement. We need to understand that this quality culture benefits the entire team, but also involves the entire team. And ultimately, the satisfaction of our patients, partners, and collaboration should be the goal of the organization. So quality in IVF can and must be managed. Quality is every employee's responsibility. Quality must be measurable. Quality improvements must be continuous. Quality is a long-term investment, and quality is an ongoing integral part of daily IVF practice. Thank you very much for your attention, and I hope that next year we'll be able to be in person and join in the next Africa-Asia Luminary.
Thank you so much, and we have received wonderful feedback from our on-site and online attendees for your lecture. Thank you.
Thank you so much for the
Like to join in
opportunity.
and say
Thank you.
So thank you finally to our final speaker, again online, it's Prof. Taya. He's from the United Kingdom. He's a consultant psychiatrist at the University Hospital of Wales in Cardiff, UK. He will be discussing the topic integrating lesion psychiatry, bridging the gap between mental health and maternity services. We now turn the floor over to Professor Taya.
Thank you very much. Can I have my first slide, please, Dr. Shadam? And I would like to thank the organizers for inviting me. I wish it was more in person in Tanzania rather than online. As psychiatrists, we like to be more face-to-face rather than at a distance. So this is the beautiful city of Cardiff, my home, where I live and work. And I'm a liaison psychiatrist. I'll explain a little bit about liaison psychiatry. Can I just declare my conflicts of interest? I do not have any conflicts of interest for this conference or the contents of this conference. I'm a liaison psychiatrist. I do not have any specific expertise in fertility or infertility related matters, but as a liaison psychiatrist, I deal with wide range of problems that mental health problems that people might experience in general hospital setting. So what I'm going to do is I'm going to talk about a little bit about liaison psychiatry. I'm going to talk about perinatal psychiatry, some bits about fertility and mental health, and tips for general hospital colleagues when they encounter people who have mental health concerns. I don't like calling problems because these are concerns people come with and we need to address them. Last few speakers I have listened to, and I'm trying to make link with my talk. Previous speaker made a few very important points, and I would perhaps refer to those in a little while. Can I have my, please, Dr. Shadab? Thank you. So people who do not know when the World Mental Health Day was, it was 10th of October. So it's not very far, and this year's agenda for World Mental Health Day was dealing with stigma. And as a liaison psychiatrist, we deal with stigma day in and day out. But it's also important to create healthy environments for people who have got mental health concerns. And hence, it's important to promote mental wellness globally. And that can only be achieved by recognizing concerns. Please, thank you. So this is an editorial, 2001, and I was a trainee when I read this editorial, and it struck lots of chords. And what it says is, not only is the distinction between mental and physical illnesses ill-founded and incompatible with contemporary understanding of disease, it is also damaging. And Professor Kendall ends this by saying, if we do continue to refer to mental and physical illnesses, we should preface both with so-called. And then he says that these are archaic terms. And in my view, after an experience of almost 3.5 decades as a psychiatrist, I totally agree with this, that if you start talking about mental and physical illnesses as two separate entities, then we are not doing justice to our patients, please. This is a paper, No Health Without Mental Health, written, it's a document written in 2009, Royal College of Psychiatrists, Faculty of Liaison Psychiatry, which I'm also a member of. It talks about awareness of the links between physical and mental health, and also how to develop liaisons. And I think, having listened to the previous speaker and some of the other speakers, it is really important to have liaison psychiatry services at the doorstep of infertility or fertility services, as you wish to call them. And it's important, previous speaker mentioned about engaging patients and stakeholders, and it's really important to do that. And this paper talks training and education. Please, thank you. So what do we deal with? We deal with loads of problems, loads of concerns. So it's important for liaison psychiatry service to be present in general hospital setting. Why is that? Because lots of people end up in emergency unit, in general hospital setting, as the first step of seeking help for their mental health concerns. Hence, what we can do is give an easy early access, and consequently, we reduce the morbidity associated with the comorbidity with physical illnesses. We reduce mortality associated with comorbidities, and also reduce the risk of self-harm and risk of harm overall. Sometimes it's iatrogenic harm also. And there are a number of papers which suggest that liaison psychiatry services actually result in saving a lot of money and reduce stigma, please. What do we deal with? We deal with a wide range of problems, psychological reactions to physical illnesses. If I was in the room, I would have made you think about what sort of psychological reactions to physical illnesses. And perhaps in future, I might be able to come and do this sort of talk in person. And part of my talk is going to be informative. For example, this slide, but hopefully what I've said before and what I'm going to say next would be transformative towards developing services and developing approaches and making personal differences to our lives, our approach to make a difference to people who present with psychological problems related to physical illnesses. And those reactions are, for example, depression in long-term conditions, organic causes of some common psychiatric symptoms. We know very well that endocrinology illnesses, they have an impact on people's mental health. Think of delirium. Delirium is an important part. A number of people I have seen in maternity services with delirium postpartum. I think it's an important area to think of. And then medically unexplained symptoms. Not every medically unexplained symptom means that this person has a psychological underpinning. We as doctors know a lot, but we do not know enough for many medically unexplained symptoms. And hence, putting a psychiatric label inappropriately can be stigmatizing. And hence, it's important to work with these patients who have concerns which are medically unexplained. Mental capacity assessment is a part of our work, but it's part of everybody's work. And when it's complex, then it becomes part of liaison psychiatry rather than every mental capacity assessment. And if I had time, I could talk all day about deliberate self-harm and suicide associated with our work, please. So what is liaison psychiatry? What is consultation psychiatry? There are two bits to it. Consultation psychiatrists are when we give an opinion and disappear. We work with medical and surgical wards. And if I was in the room, I would have asked, give me an example. Example could be someone presents once, we go give an opinion and then leave it with the medical and surgical team to deal with them, or signpost them appropriately. As liaison psychiatrists, we become part and parcel of that medical or surgical team, and we continue to advise on management. Please, thank you. Functions, we have wide range of roles that we deal with. We advise, we train, we coach, we assess. Biopsychosocial formulation is something which is very close to my heart. And I really think that all doctors, all health professionals should be thinking about biopsychosocial formulation, irrespective of where they work, irrespective of their specialties. And it's very, very important to know about biopsychosocial formulation because it engages the patient. We talk about management, we help manage patients. Mental Health Act, MHA, or Mental Capacity Act is a very UK term, but you might have to think of local legal provisions to help these patients. My view is that we should be helping patients in the least restrictive manner without bringing in the Mental Health Act or Mental Capacity Act. And I've written as a consultant psychiatrist of almost 2 decades, I've written number of service development plans, and it's important to keep engaging with services, please. Thank you. Now, this is very important in context of Tanzania, but more so in context of other small income, low income, or developing countries, because health is not equally distributed in population, and it is affected by a number of things, power, resources. But let's think of disadvantaged groups, women, children, and in some cases, men. But it's also important to think in terms of how this shift can be made, please. Inequalities really have an impact on mental illnesses. For example, unemployment, social benefits, social isolation, housing, and I can go on and on about a number of other social inequalities that we need to think of. I will refer to this inequality, so please remember this, and I'll talk about it towards the end of my talk, please. Okay, so sometimes I feel like this little red car. This is a picture I took a few years ago, and the other cars could be barriers or spectators watching a poor, lonely psychiatrist going in the wrong direction or perceived to go in the wrong direction. But actually, I face in my patients in general hospital setting can face a lot of barriers, and hence it's important for me to try and break those barriers and help patients. And these could be because patients themselves, they don't want to talk about their mental health problems because they feel that doctors don't understand the psychological illnesses or the psychosocial issues. And above all, they think, if I'm going to talk about my psychosocial issues, I'm going to be ignored. The doctors will not help me and blame everything on my mental health. And hence, at times, and there's plenty of research around it, patients with mental health concerns think, I can't trust the doctors with my mental health or emotional problems and managing them. Therefore, mental health concerns are everybody's business, please. And this is proven by research that there's plenty of research that people who have mental health concerns, when they present to the GPs, they're general practitioners, non-psychiatrists, they're only picked up if they have been crying or expressed suicidal thoughts. And hence, it's important to train mental health related subjects and put them in the curriculum of all health professionals. So this is a part of work done in Wales by the faculty of Welsh Division. And this relates with the previous speaker's talk. And this is such an important piece of work because it talks about person-centered biopsychosocial approach, and it is underpinned by apologies, it should be trust. T has gone a little bit haywire. It's underpinned by trust, communication, empathy, respect, and dignity. And each of those areas, working as a doctor or a health professional, there are certain responsibilities. And when you're working as a doctor or a health professional, you have a leadership role. You're working in a team and how you take the team along. It's important to develop services with people who have got lived experiences. And at the times I have been an advocate of patients rather than a psychiatrist is phenomenal. And it's important for us to be accountable and transparent. So we can talk about this slide almost all day, and we will be able to make a big difference to the subject of this conference. Please, thank you. This slide relates with the previous speakers' PDCA or PDSA cycle as well. Okay, again, I'm going to say what I've said before. If I was in the room, I would have asked you these to talk about these 3 areas: everyday experiences, illness beliefs, concerns, and expectations. Please. I'm going to ask you 3 questions and make a note of those 3 questions that I'm going to ask, please. Thank you. So question number 1, how frequently do you explore your patient's everyday experience of mental health concerns? So I asked a colleague of mine, how often do you do that? He said, never. And he said, I don't have time for it. But think of this question number one, always, option number one, always, two, not as often, three, as often as I could, four, almost never. So how often do you explore patients' everyday experience of mental health concerns, please? Question number two. And these questions are very, very important for patients with fertility issues, not just women, but also their families and partners. How frequently do you explore your patients' illness beliefs? 1, 2, 3, 4. Next question, please. Question 3. I really hope that you're more towards 1 and 2 rather than 3s and 4s. How frequently do you explore patients' ideas, concerns, and expectations about treatment? Again, whatever specialty we are in, these are very, very important and strong questions to engage patients in a biopsychosocial assessment, please. So I'm going to go into the next phase of the talk about perinatal psychiatry. Perinatal psychiatry is that branch of psychiatry that links very closely with liaison psychiatry. It is to do with women's mental and well-being during their pregnancy and in the first year after birth. And it has a wide range of psychiatric diagnoses to consider, for example, ranging from postpartum blues, dealing with their pre-existing mental health concerns, or diagnoses that they might have, for example, bipolar affective disorders, schizophrenia, eating disorders, substance misuse, and then disorders that might develop during their pregnancy and postpartum. For example, I mentioned postpartum blues, but postpartum depression, but also psychotic disorders postpartum. Mental well-being is very important for the well-being of the fetus and overall outcomes, please. So apologies for 1 or 2 typos in this slide, which I picked up after I had sent this slide, but there's a 13% increased risk of anxiety disorders in antenatal periods for those who did not have any previous psychiatric disorder. And there's a 12% experience, women who experience depression in antenatal period, and 20% up to 1 year postpartum, which is more than the general population rates of depression. And then there's a small risk of increased binge eating disorders, and maternal and fetal complications with increased risks of substance use is very well known and very well researched. Suicide is well known, and I'll talk a little bit about that in a minute. And it's important to think of exposure to antenatal depression that can also have an impact on the babies. ADHD as they develop, autism are well-known entities. Okay, please. So is going to talk mainly about the mental health disorders that can result as a complication of pregnancy that affects the entire family and the system and contributes to the mother's mortality and unfavorable outcomes, and mainly focusing on maternal suicide, because in first postnatal year, suicide is a leading cause of direct deaths, and within 42 days of the end of pregnancy, second largest cause of direct maternal deaths, and it's the 5th most common cause of deaths during pregnancy. So it's a huge thing to be thought through. And this evidence is from mothers and babies reducing risk through audits and confidential inquiry, which was done in 2019 in UK. Okay, please. That would talk about the history of mental as risk factors, history of mental disorders, family history of mental disorders, being a single or unmarried mother, poor family support. And remember, I showed you the inequalities slide earlier on, and this sort of links in with that slide very well. Please. That would be about depression, and depression is a common presentation. It's important to think about it because 1/3 of cases occur before giving birth, and women with mood and anxiety symptoms and baby blues or postpartum blues have a high risk of depression. Next, it's also linked with the abortion and low birth weight and preterm delivery. And there's some paper about maternal depression. In fact, it's very old paper, 1991. Lots of work was done by one of my friends way back and published in Lancet, which clearly showed this link with depression, mothers' maternal health, mental health, and its association with babies' health, please. It's going to talk about management of depression. Now, this is very important because it's important to talk to people. It's important to take a thorough history, identify the risk factors. And I'm going to talk a little bit about biopsychosocial formulation in a couple of minutes. It's important to assess risks, not just for the mother, but also for the baby. And it's important to engage in a multidisciplinary manner. One thing I've noted in the previous slide, and it's no criticism at all, please do not think of it as a criticism. There was no mention of mental health colleagues to be involved in that system. It's essential. You cannot leave mental health outside the whole system. For mild to moderate depressive symptoms, first-line treatment would be psychological interventions, and there are interventions that can be thought through. And that's why it's important to have mental health professionals available to give advice. And if it's moderate to severe end of the spectrum of a disorder, then you should consider SSRIs, which are the selective serotonin reuptake inhibitors. There are different groups of antidepressants. It's important to think through which would be the most suitable for that particular woman. But it's important to weigh and balance pros and cons of prescribing an antidepressant or not. Please, then should talk about psychosis during pregnancy and postpartum period. It's a psychiatric emergency. And I would not say more than that because there's a risk to the mother, there's risk to the baby because women could be hearing voices, they could be paranoid, they could be talking about things which would not be based on reality, they would be irritable, they would be angry, not looking after the baby. And the treatment needs to be initiated as soon as the symptoms are identified. And that is a very important psychiatric emergency which should be dealt straight away. In my view, the best treatment for that is ECT because it gets mum well very quickly and starts looking after the baby as soon as possible. ECT gets a lot of press, which is bad press, but it's a very effective treatment and it should not be put under the carpets and folded away and thrown into the river because ECT is a very effective treatment. It's so effective. If I had severe depression, I would want ECT. And there are some other new treatments, and it's a very safe treatment these days. Antipsychotics, antidepressants. So I'll move on, please. Bipolar illnesses are very important, and so are the pre-existing psychotic illnesses like schizophrenia or pre-existing depression, because pre-conception, when someone is trying fertility pathway, then they need to have this discussion early on, whether they should remain on medication or not. What are the pros and cons of being on mood stabilizers, in particular the anti-epileptics, which are given as mood stabilizers. And it's a very important factor to consider because the pros and cons of remaining on medication, stopping medication, risk to the mother, but more importantly, the teratogenic effects, they need to be considered very, very strongly. And this is a conversation which needs to be had pre-conception, pre-planning, and it's a very important point to take forward, please. It should be about the psychological effects of infertility. Now, the key point here is it's the whole system. It's not just a woman, but it's the partner, the family. And there are high rates of anxiety at baseline. There are high rates of anxiety both in men and women as you follow them through in the fertility clinic. Similarly, depression is common both in men and women, and it's important to engage both men and women as a couple in the fertility clinics. Like I said earlier on, I'm not specifically a psychiatrist who would deal with fertility issues, but we deal with a wide range of issues. And these are common things that we always need to think of, please. So we talked about the fertility, anxiety and depression. It's also important to think in terms of repercussions of infertility, and they're very, very clear, as you can see: feeling of grief, loss, guilt, shame, self-blame. And in some cultures, women get stigmatized, and some treatments are taken on which are not evidence-based, which are not medically underpinned, but people would be taken to non-mental health professionals, non-medical professionals. They would be doing different types of things like witchcraft, spells, possession, and so many different things. I've just written an editorial, and it gets published soon, about the wider impact of delay in untreated mental health symptoms and taking the wrong pathway, and hence there's a need to bridge that gap, please. So I'm going to talk about biopsychosocial model. I've mentioned it a few times, and it's important. When someone presents with symptoms, you start to investigate in a more detail about predisposing factors, precipitating factors, protective factors, and perpetuating factors. But it's very important to also think of iatrogenic factors, and it would be very pertinent in case of infertility and trying fertility treatments, the iatrogenic factors. It's not just about the effect of medication or the side effects of medication. It is also how we communicate with women and their system. And that is also an iatrogenic effect that we need to think of. So these 4 Ps can be put in a biopsychosocial grid, please. And I can spend half a day doing a workshop on biopsychosocial approach, predisposing factors, precipitating factors. So this grid is deeply ingrained in my mind and my trainee. When we talk about a patient, we talk about these points quite regularly. It's in my office on a whiteboard, and if we are talking about a patient, we will literally go through each and every box of this grid. It should be biopsychosocial, or biopsychological, and social should be the 3rd column. There's a 4th column which is important to consider, which is spiritual. And I take social and spiritual together, but that can be an important factor to consider: biopsychosocial and spiritual model, please. Why this is important is because we need to think in terms of treatment goals. And the way I think is, first of all, we need to increase the remission rates, prevent relapses, restore physical functioning, and finally restore social functioning, please. And remember the grid I showed you. Now that particular grid goes into the previous slide, please. That particular grid goes into the short-term, medium-term, and long-term mental health symptoms. And short-term management could be biological. We might think of a medication, we might not think of a medication, but psychosocial interventions would need to be considered. And I like to think of where I want to see my patient in 2 months' time, where do I want to see my patient in 6 months' time, where I want to see in a year's time. And hence it's important to think in terms of how I can increase improve the social functioning and restore social functioning, please. And it's also important that we need to work collaboratively with patients. So psychological therapies could be at the heart of fertility services. It's also important to think of comorbidities, drug-drug interactions, impact on mother, impact on baby, and impact on the whole system post-pregnancy. The level of stress in infertility patients tends to increase as treatment intensifies, and there's evidence around that. Sorry, it should be 2014. I picked it up after I had sent this slide to you, Dr. Shadab, but it should be 2014. And medications that are used to treat infertility may contribute to depressive symptoms. There are mixed reports on the impact of stress on IVF outcome, but this is something which needs to be researched further. Please, now, this is very, very important. I think it's important to summarize that we are not just dealing with the patient and the family, we are also advising staff from mental health services. We are also thinking to the infertility treatments. And if we took each one of those separately, it's important to screen for psychological distress. There are a number of questionnaires like PHQ-9, hospital anxiety depression scale. There are some very specific scales for women as well. And it's important to offer a very tailored rather than a general advice, because every individual is different and one size does not fit all. And hence talking to patients and getting their information and talking to them on a biopsychosocial model is very important. Services dealing with infertility should provide referral information, and you should know services in your area. Mental health services facilitate an early entry into mental health services to seek help, and hence the duration of untreated illness is reduced. It's important to incorporate psychological support. I'm saying support, not therapies, as part of the fertility cycle, and also ensure that the family and in particular the partner is involved. Now, clearly, when I've listened to others today, there is an important issue of workload of staff, and it's a common thing across all specialities, and hence training staff to deal with their own stress is very important. And also it is very important that they learn good communication skills. And as far as infertility treatment protocols is concerned, I'm the wrong person to advise on. I've read the literature. For me, it seems that it's very important to simplify treatment protocols. Focus on infertility prevention and public health messages are very important. And lifestyle changes support patients and their families who do not successfully conceive with intervention or without intervention. Please, thank you. So just as a summary for management, it has to be an integrated approach to emotional health, not just physical or fertility health. It has to be no health without mental health approach. Focus to reduce the burden of treatment for whatever physical illnesses there are there. Screen patients for psychological distress, and also consider psychological interventions or psychological support. And if you're thinking of psychotherapy, then cognitive behavior therapy, progressive muscle relaxation exercises, mindfulness. There was a time when I started psychiatry training, mindfulness and progressive muscle relaxation exercises. We used to teach patients, but there are lots of YouTube videos there which you can think of and share with your clients and patients. And it's important to think of psychotropic medication when they are needed. And that's where you need a psychiatrist's help, because we look at a much wider perspective and try and make sure that risks of psychotropic medications are discussed with patients so that they are aware of what to expect if they take medication, please. I talked about inequalities, please, because there's some commonality between this slide and I think it's important to improve access to mental health care, irrespective of the disadvantaged groups, whichever the group they come from, women, children, people with socioeconomic inequalities, because in some countries, if you have money, you get access easily. If you don't, then you are stuck and you continue to suffer. For general hospital policies and protocols, it's important to review those and see whether mental health services and in particular liaison services are involved or not. And if not, you can't get away with it. It's time that these services should be at the heart of any service. And investment really pays off. I'm going to say that as a psychiatrist, but there's plenty of evidence actually. And it also improves the experiences of patients who engage with these services. And hence, dealing with inequalities and dealing with stigma is really important, please. So 10 things that all general hospital staff or maternity staff should think of in no particular order, but these are the things that everyone should be aware of, not just psychiatrists, not just mental health professionals, dealing with agitation and restlessness, dealing with suicide risk, dealing with medically unexplained symptoms, history of substance misuse, psychotropic, basic knowledge of psychotropic medication, or seeking advice and help And delirium is particularly something really, really, really close to my heart. And I've done almost 2 decades of work on delirium, and it's really important that that should not be ignored. Please. So I asked you 3 questions. I'm going to ask those 3 questions with a different slant now. That after listening to this talk, hopefully I've transformed you to think of ones and twos when you explore their everyday experiences. Please. You would ask about their about their illness beliefs, please, and you would talk to them about their ideas, concerns, and expectations about treatment on a more regular basis. The answer that I don't have enough time is not the right answer, in my view. I'm sorry if I upset someone's practice, but really we need to talk. How are you feeling? What do you want from me today? What's your expectation from the treatment today, please? In summary, this has been a very quick tour of liaison psychiatry, and mental health is everybody's business, and we should not ignore it. And no health without mental health, whether it's with fertility-related matters or otherwise. I'm going to stop here now, and I would like to thank my hosts for inviting me, and hopefully one day we could do it in person and you could come to Cardiff, the home where I live and work. It's been a pleasure talking to you all. If you have any questions, happy to answer.
Thank you so much, Professor Taya. Moving on, now that we are done with all our speaker presentations for the day, we are here to continue with our second panel discussion, which is the final activity for the day. Let us now welcome our guests for the second panel discussion to discuss the topic, Merck Foundation More Than a Mother Movement's Impact on Training the First Fertility and Embryology Specialists in Africa and Asia. For this discussion, we have today with us our first panelist, unfortunately couldn't join us on site. She is Dr. Maela Figya. She is a consultant obstetrician gynecologist, infertility and fetal medicine specialist at Shifa Hospital, Maputo, Mozambique. She'll be joining us online. Our second panelist for the day is none other than Dr. Novia Dennis herself. She is a fertility specialist and medical director at Kenedja Health Center. She is also the director for the Family Health Program, Ministry of Health and Merck Foundation alumni from Liberia. Please give her a big hand. Next we have with us is Dr. Nicholas Mazuguni, consultant gynecologist, fertility specialist, and Merck Foundation alumni from Tanzania. Big hand for him, please. We have with us Dr. Vubetu Alebachiu, assistant professor of OBGY, reproductive endocrinology and infertility specialist, subspecialist, SPH-MMC, and Merck Foundation alumni from Ethiopia. I'd like to call upon Dr. David Mvesigye, consultant OBGY, fertility care specialist, managing director at Women Health and Fertility Specialized Clinic, and Merck Foundation alumni, Rwanda. Please welcome Dr. Meseret Ansa Giveta, obstetrician and gynecologist, REI subspecialist, CEO of Center for Fertility and Reproductive Medicine, St. Paul's Hospital, Millennium Medical College, Addis Ababa, Ethiopia. And lastly, we have Dr. Mustafa Thiam, consultant obstetrician, gynecologist, and president of the Senegalese Fertility Society, Senegal. We welcome all our panelists and would like to inform that we will be asking only one simple question to each panelist, and they will be given 5 minutes to respond to it. Okay. Dr. Maela, can you please tell us about the status of fertility services available in the public sector hospitals of your country, and what are the main challenges in terms of training and expertise with regards to procedures like IVF?
Okay, thank you. First of all, I would like to say thanks for the opportunity. It's really truly honor and pleasure to be part of this expert meeting. I'm from Mozambique, a country in sub-Saharan Africa, and unfortunately, the treatment of infertility is still a big challenge here. In the public health sector, there are many limitations to treating the infertility related to the shortage of technical personnel with skills in this area, and also to the lack of material resources. For example, I'm not able to do a good spermogram with high quality in all the public hospitals. And hysterossalpingography, it's done by a radiology technician in the public sector. There is no an OB-GYN selected to do this exam. So these are examples that we are not able yet to, like we would like to be. And I think there is a need for some organizational change in this area, and also in terms of staff training. Related to the private sector, there are obviously more material resources, but there's still a shortage of trained personnel in this area. Regarding IVF procedures in Mozambique, unfortunately, it's not yet down. We are able to carry out intrauterine insemination, scheduled coitus, but not highly complex procedures. There is no specific center for this area, and the Mozambican women has to search it outside the country. They need to travel to South Africa, India, Brazil, sometimes to Portugal, to search for this kind of treatments. And infertility problems, it's a very common problem with the women of Mozambique. And we receive a lot of women in the consulta for gynecology visits with this problem. And it's not good. We have some limitations to manage these cases. There is no program for gamete donation and preservation of these gametes service. And we have to refer these patients for another outside centers. But on the other hand, there's a lot of motivation of the gynecologists, because we would like to accompany this woman to the goal of the get pregnancy. And I think this would be very rewarding for all of us to achieve this dream for every woman. Thank you.
Thank you, Dr. Maila. Thank you so much for your response. My next question is for Dr. Novea. Dr. Novea, you are now the Director for Family Health Program under the Ministry of Health in Liberia. Can you please elaborate your journey and how, according to you, can fertility services be made more accessible and cost-effective, especially for the underserved communities?
Thank you. Yeah. So the Family Health Division, it's okay? The Family Health Division at the Ministry of Health is the largest because we deal with reproductive, maternal, newborn, child, adolescent health, all in one. So my journey started from, as I said, Merck Foundation offered us a scholarship, went to India, IVF, Indra, had a training, came back. The first thing we were faced with was how to get fertility drugs. That was the first thing, because in Liberia, we were one of the first. The minister, Dr. Poto, went first, and since I was pregnant, I went after her. So when we came back, we didn't know what to do. Then I said, look, I think I need to establish a pharmacy only for reproductive health drugs. And that's how I established the Godwin Reproductive Health Pharmacy, where we supply medication for, infertility treatment. So we started off low key, and we had some few like highly complicated cases that we were able to successfully treat. And one case came from England. She had a blocked tube, multiple fibroid, but one of the tubes were patent. So we did 2 cycles of IUI, and it was unsuccessful. And then we decided, we did a rescan, the ovarian reserve was low. So what we did was we did a low grade treatment with estrogen, the priming, and then after we gave her the stimulants again, FSH, and then the beta HCG. Blessing it for us, she got pregnant. And we managed to treat her. She went back England. She had cesarean section because she had multiple fibroids. And then she delivered a baby. After 6 months, she got pregnant spontaneously, just by herself, and now she has 2 boys. So, you know, there are a lot of other cases that we treated just like that in the absence of IVF, but just using some of the things, you know, the scientific stuff behind, you know, low ovarian reserve, how to treat those people. And so that's how we've been. Even right now, we have 1 cycle that we just completed. We are waiting for the result. Again, hopefully we're keeping our finger crossed. That's IUI we did. So as the director now of the Family Health Division, what we want to work on is prevention, because infertility treatment everywhere is very expensive. We're just discussing how maybe if we define a package of care for infertility in Liberia, then we'll introduce the insurance where people will pay into the insurance, and then later on they can access almost like a social security scheme where you pay when you are working, because you don't know, you might end up infertile. So if you contribute to that scheme and later on you discover you have some issue, you can also go and then reap what you sow. The next thing we are currently working on, we have a consultant. We want to do infertility guidelines, prevention, treatment for the country, so that we can start setting guidelines, you know, in terms of prevention, in terms of treatment and everything for Liberia. Hopefully we can get somewhere with that. Thank you.
Thank you so much, Dr. Novea. Thank you. Our next question is for Dr. Nicholas Mzuguni. Sir, what has been the role of Merck Foundation in helping you start an IVF center in your country? And what has been the secret behind its major success?
Yeah, thank you so much. And thank you for the wonderful opportunity of me being here and at least share my experience ever after I finished my training. So I was very fortunate to be one of the very first people to be trained by Merck Foundation. And I would say in one or another, it was the beginning of the very beautiful journey when it comes to fertility care in this country. So the first thing that we did immediately after training was not to start IVF. The first thing was to put up a structure to be able to offer services that will increase the chances of couples conceiving, but at the same time having a live birth. So the first thing that we tried to do was to implement a structured clinic whereby we can attend patients properly, take good clinical history, investigate them properly, and then decide what would be the best option in terms of intervention for those patients. And I can tell, I think that was really important because just in the first year of doing that, we managed to get quite a good number of patients being able to conceive naturally. And this was as simple as them knowing when are they going to ovulate, for example, and some of them going through several kinds of treatments. It was really important. We started doing IVF, I think, on the 2nd year after I finished my training. And as of to date, I would say we have delivered more than 600 babies from IVF. That is purely from my center. So we are very happy because that has come in with at least doing more than 500 cycles every year. So we have seen the impact, but it didn't end up there. So we decided to help other people, other clinicians to be able to build up an interest on fertility medicine. We conducted our first training back in 2020, whereby we invited at least over 100 clinicians all over the country that they joined the training. And I think that was really a key thing that we have achieved to date, because having more than 100 clinicians joining for the training and building up an interest to look after these couples that have been suffering from infertility, that was a game changer, I would say. As you can all tell now, in this country, we have the first public IVF center that is with the Muhimbili National Hospital. And I can say we have worked with them hand to hand. Some of the clinicians are here from Muhimbili National Hospital. We managed to spend some time with them just to get them inspired, just to get them understand, to get the feel of how difficult it can be. Because when people hear IVF, especially clinicians, when they hear IVF, all they know is thousands of dollars that they should be able to earn if they're fertility clinicians. Like you have heard today, the mental health is one of the big problems. And don't forget, when you are a fertility clinician, you can also go through a mental health as well, because imagine you have a patient who has fed 2, 3, 4, 5 cycles, and all you know that they will have to pay again for them to come for their treatment. So we have managed to achieve that, and I would say we are so grateful to Merck Foundation. And it doesn't end there. We have this plan of try to encourage everyone who has gone through this training to make sure that at least they further more in terms of further training, maybe going for MSc, if you think that's something that you can think according to the pathway of your career. So in a nutshell, that's what we have been able to do so far.
Thank you. Thank you so much, Dr. Nicholas. Our next question is for Dr. Wubetu Alebachiu. What, according to you, is the role of infertility awareness among males and females, and how successful have the assisted reproduction services offered at your center been in terms of cycles or number of healthy conceptions?
Thank you. I have been practicing as a fertility specialist for the last 1 year, but I have been practicing at different setups in government setting initially, followed by a private center, initially with egg donor and self cycles, and the last 4 months with gamete and embryo donor cycles. So we had a good success, but I want to focus more on the last 4 months of my experience, because it was a new experience for the country, and I have been practicing in a setting where donor was not allowed in the country at large, but in a certain region of the country it was allowed. So it was a kind of a new experience with a new challenge. So because I was the first person to initiate this service, and there was no clear rule regulation. We used different countries' protocols, including India and others. We tried to contextualize to our society, and there was a lot of challenge because of getting a donor is one challenge, especially egg donors. The next, initially at the beginning, just when the service was started, within few days we get lots of people, male sperm donors. Couple flooded with the clinic was flooded with male donors, but it was very difficult to get oocyte donor. And who can donate? How many times? Can it be anonymous, or can it be both? These things were challenging. Then we formulated, with lots of reference, we formulated regulation, and we tried to manage who can donate with the good candidates, and the regulations were clearly set. And in 4 months of practice, we were able to record around a success rate of 76% in 50 patients. 28 of them were egg donors, 12 of them were sperm donors, and 10 were embryo donors. Then, because of some issues in the northern part of Ethiopia, there was also a peace security issue. Still, I am back to the capital city, and the service is not able to be continued. But that one created a good move to start the service in Addis, in the capital. So now Dr. Maseret, my senior, will help me in more elaborating. There is a good move to start now as donor IVF cycles in the country as a whole. That will be a good milestone also to assist this service in general. So I would like to thank Merck Foundation for helping me in this journey. Also, Indira IVF Center had helped me to record this high success rate, because I got a lot of hands-on skill trainings in addition to my training in my country. So now I can feel that I can work anywhere. I can have a good success rate, provided that with a teamwork and a good embryologist there. Thank you.
Thank you. Can we also have a very big hand for Indira IVF here, please, and Dr. Vipin Chandra especially? Seems they have a major contribution and many success stories here between us. Thank you, sir. Next, we move on to asking a question to Dr. David Mbisigie. Sir, please tell us about the new initiatives, facilities, services added to your practice as a gynecologist, infertility specialist after training with Merck Foundation, and how have your patients benefited from them?
Thank you so much. Good afternoon, good evening. Thank you, Merck Foundation. Thank you, our seniors. So way back after my training by Merck, I was working in the public hospital, Ranamit Hospital. We managed to, when I reached there, we managed to isolate the patients who were in publicly seen, mixed up. So we created a special consultation room for only fertility clinic. And we set up for the first time, we are the one who set up this clinic. So when we set up this clinic, we went public on media, we got huge number of patients. So when this patient came, there were many. We started giving them appointments. So time came, I said, I think from the inspiration I got from India, from this institution, from Kamini Rao, she taught us that everything's possible. So because I saw a number of patients were being given so many months to be seen, so I said, now, let me go extra mile. I created my clinic. It is called Women's Health and Fertility Clinic Rwanda. When you go to YouTube, Facebook, social media, it's there. So now, this clinic, I decided to step up, go aside, and now become a path of the patient that we were waiting for so long to be seen for IVF. Now, I'm like a channel for this patient. I see them while waiting for IVF. We do prevention, we do medical assisted, we do IUI. We have improved a lot in IUI. We counsel. You know, as you've seen, really, in Africa, IVF is very expensive. You know, there are simple things we do, and these women get pregnant. We go, we teach them about to improving style, prevention, and we've seen mothers, by the way, whom IVF have failed, and we do IUI, and they succeed. We do simple teaching, and we get good outcome. Really, we are doing a great job. We counsel them. Actually, it's women's other, you know, they tell us, when I was opening up this clinic, they were telling me, why don't you include men, get money, put children? But I said, please, because I knew the vision I had for these women, infertile couple, they need to come in a safe way, private. They cry from there. You know, they need privacy. So I was not after money, but I was after the passion that I was shown by Merck Foundation. That passion, I think, when you build on it, even God gives you money. There's a way you satisfy the couple's desperate depression, and usually after we shall generate money. So everything will come. Actually, I've learned from what is being done by my colleagues. Now, actually, when I set up this clinic, it's like these patients, they come to me, we counsel, and now we refer, I transfer them to this IVF clinic. When they go there with full confidence, you know, managing infertility, after all, in our community, they don't even understand. They need to understand what is IVF. These African couples, they need to understand why. They ask themselves, why not conceive myself? So they didn't understand. So they come to our clinic, we counsel them. You know, some women, they know, provided they are still bleeding at the age of 40, having menses at the age of 50, 45, they can conceive naturally. So this is a misconception that we teach our community, that really they need to understand what really they have to undergo. So really, there's much to do, which we are doing in our community. And we've seen that this one, you know, you can't convince a like African couple that you're going to have donor. You need to teach them. They have to get some time. Teach them how to accept donor. We've taught them how to accept donor eggs, donor sperm, and they're having families. Because when they find these doctors in IVF clinic, public hospital, sometimes they don't have their time. So we need to talk to them, counsel them, and they accept. Finally, they get more donor babies from donor egg, donor sperm. And really, we are seeing that our clinic is impacting, provided we don't have IVF, but we are doing great work. And thank you, Merck Foundation and our professors.
Thank you so much, Dr. David. Thank you. Those were some really nice words. My next question is for Dr. Messeret. Ma'am, what, according to you, are the key components in providing cost-effective IVF care to the general population in a country like Ethiopia?
Thank you. So good afternoon. It's an honor to be with all these experts. So regarding cost effectiveness, it's obviously issue, especially in Africa, particularly in Ethiopia. We know, let me tell you a figure, like we evaluate nearly 16,000 patients per year as outpatient, but we treat like 1,000 to 1,500 patients into IVF cycle, around 700 patients into IUI cycle. Few patients are not, so he was mentioning about donor egg IVF, which is at infancy state. I would rather not prefer not to talk about it because the regulation is not there. It's not officially allowed to do donor. So we have around 3,000 patients waiting for donor sperm or egg IVF. So you can understand, like, affordability is a big issue which hinders our patients from getting the proper care, even after proper evaluation. So we try to, so let me just tell you that, like, one patient, if we do have 2 modes of treatment in public IVF center. Our center is public IVF center. So there are patients who get the medication payment only, not for the service. There are other group of patients, there's minimal amount of money for the service, which helped us to support the center. So it's like $3,500 for one IVF cycle, which is a relatively small amount of money, but for a community like us with very low income, it's still a big deal. So we divided some methods like modified stimulation, minimal stimulation protocols, where we use oral agents followed by low dose gonadotropins. That was one of the methods which helped us to incorporate few patients into the IVF cycle with a good outcome, actually, especially with those with good ovarian reserve. But we are still behind. So luckily, we were able to establish one of the best embryology lab with the government support and with partner support. And thanks to Merck Foundation, we have good experts in embryology as well as RAI. And we have established a fellowship and we have produced 14 RAIs. 13 of them are working in the private and government center. One is from neighboring country, from Rwanda, who just graduated. So we have even contributed to neighboring countries because of Merck Foundation. And we have 5 embryologists who are good at skill. Also, we are planning to start master's program in embryology. So we believe that costs should be considered, but quality and success are also very important pillars of cost effectiveness. That's why we are working on establishing public-private partnership to support this financial issue. We are pushing the government to consider this infertility as one of the priority in the SRH as well as in policymaker level. And we are also working on advocacy education, which is very important, I think. If we get patients earlier with good ovarian reserve, the success would be high, which is success is obviously the thing which is behind cost effectiveness. So cost effectiveness should be considered, but the 2 pillars are success and quality, which should be supported by the government, private stakeholders, and also with foundations like Merck Foundation. Thank you.
Thank you so much. Thank you, Dr. Messeret. And my last question is for Dr. Mustafa Thiam. Sir, how important is the role of key opinion leaders and policymakers in helping specialized services like IVF care become available and affordable to all? What is the role of awareness in dissipating these services among the masses?
OK. Merci beaucoup. Je veux parler en français. OK.
Where is my friend, Dr. Gilbert? Dr. Gilbert, I need you. Come. He's my savior every year. Come. He will translate what Dr. Mustafa says for us in English, please.
Go ahead.
Alors, merci beaucoup. Alors,
thank you very much.
Nous avons les mêmes réalités en Afrique.
In Africa, we are having the same reality.
Pour gagner ce combat, il est important de travailler avec les leaders d'opinion, mais également les décideurs politiques.
to win that fight, it is important to work with policymakers and the others in the field.
Ils jouent un rôle crucial dans l'accès aux soins, dans la prise en charge de l'infertilité, notamment la fécondation in vitro.
Those people, the policymakers, they play an important role to make access to infertility care, especially by using IVF for the population.
Il faut savoir que leur rôle s'accentue en 5 points essentiellement.
There are many points which are very important to focus on.
La première, c'est d'abord la sensibilisation.
The first one is to make the population to be aware of the infertility issue.
En mettant en lumière les enjeux de l'infertilité, mais également le développement, les progrès de la médecine.
By clarifying everything related to infertility and the importance of treating infertility for the development.
Ce qui pourra permettre de démystifier le sujet, mais également de lutter contre la stigmatisation.
And also by fighting stigmatization of infertility.
Alors, pour ce qui est du Sénégal,
regarding Senegal case,
pour le deuxième point, nous nous sommes appuyés sur les lobbying politiques.
First, we use political lobbies.
En défendant les politiques favorables à l'accès aux soins de l'infertilité.
First, to push those politicians to defend the access to the fertility care.
En influençant les décisions législatives et budgétaires.
By influencing some decisions related to the budget and the politics.
Avec l'appui de la Fondation Merck, bien entendu.
Especially by using the Merck Foundation support.
Qui a permis aux dirigeants de prendre le taureau par le corne pour installer le premier centre de fertilité.
Merck Foundation helped us to push the policymakers for setting up the first fertility center in my country.
Parce qu'il mettait l'accent surtout pour la lutte contre les cancers, contre le paludisme, la tuberculose, en rendant gratuit le traitement.
Before mainly it was the most important policymaker was making importance on fighting cancers, malaria and other diseases.
Les parents pauvres dans le secteur de la santé étaient représentés par les femmes qui souffraient d'infertilité.
But these men of the population, we find that many of them are composed by these women who was having infertility.
Alors, le troisième point pour ces leaders d'opinion.
The third point regarding those policymakers
reposait sur le partenariat avec le personnel de santé.
Was related to the partnership with the medical staff.
Surtout les spécialistes de la fertilité.
Especially those one who are professional in infertility.
Qui pouvaient mieux comprendre les besoins.
Who can understand the need for the population.
Ensuite, le troisième point, c'était le soutien financier.
The next point was the financial support.
Nous nous sommes appuyés sur ces leaders d'opinion et ces décideurs politiques.
We use those policymakers to support us regarding the budget.
Pour qu'ils puissent allouer des fonds.
To get the fund needed for this project.
Dans la recherche et le traitement de l'infertilité.
Those funds was used for research and treatment of infertility.
Pour contribuer à réduire le coût.
In order to reduce the cost.
Parce que nous sommes dans un pays où nous n'avons pas cette couverture au niveau des mutuelles, mais également au niveau de la sécurité sociale.
Because in our country, these insurance are not covering those kind of management.
Et la particularité du Sénégal, c'est aussi le quatrième point qui nous a permis d'avancer.
Especially in the Senegal, the fourth point, which is very important.
Et c'était la création d'une réglementation claire.
It was to setting up the law related to that issue.
D'une loi cadre sur la procréation médicalement assistée.
That law was related to assisted reproduction technology.
Qui avait permis de garantir les soins.
That law allows to make sure to be sure about how to manage those cases related to infertility.
Des soins de qualité, mais également
quality, the good quality management and those one related to that technology.
Ensuite, le dernier point était de travailler sur l'équité territoriale avec l'appui des décideurs, mais également des leaders d'opinion.
The last point was related how to make sure the equity related to the treatment and how to push the whole people involved in that implementation.
Et là, la Fondation Merck également nous a appuyés.
For that, Merck Foundation supported us.
Par la formation des personnels qualifiés.
Merck helped us by training medical specialists.
Et qui ont accepté de travailler dans les zones déterminées.
And those specialists accept to work for the country.
Donc, ce qui fait que nous avons des unités de procréation médicalement assistée qui peuvent aller jusqu'à l'insémination.
So now we have special staff which can do IUI
Dans diverses régions du Sénégal,
in different parts of Senegal.
avec une forte collaboration avec les gynécologues et les urologues de ces régions.
And those medical staff are collaborating with the gynecologists in the country.
Avec ceux de la capitale.
They are collaborating with those one who are working in the cities.
Et comme je l'ai dit la dernière fois, l'exemple que nous avons ici, c'est le docteur Neha Dissen,
For example, here we have one doctor who is here,
qui est très engagé, qui est à 300 km de Dakar,
who is far away, the capital city, far away to 300 kilometers.
qui a des résultats excellents dans la prise en charge de l'infertilité jusqu'au niveau de l'insémination.
And he's getting good result in the management of IUI, especially in the management of fertility.
Voilà, merci beaucoup.
Thank you.
Thank you so much, Dr. Gilbert. And thank you so much, Dr. Mustafa, for your explanation. I'd now like to thank all our panelists for sharing their views and making this discussion worthwhile. You all may please take your seats back. Sorry? Yes.
I think I'm extremely impressed by what I've heard from these panelists. And all I can tell you is that maybe not too long ago, although it may be long for you, I was like this. I was just at the stage you are. Maybe yours, like what David was saying, just doing management of infertility and establishing that protocol, and also using some simple techniques from IUI. And gradually you evolve. And all I can tell you now is that you all have good stories. And they say that when you work together, you go places. So now we're together, and I like your stories to be heard. And I've mentioned this. If you have stories like this, you have my email, just bounce it to me. We are writing a compendium in the World Fertility Congress. And your name, your country will be acknowledged as contributors to this work. So that even we want to know, even if you are doing IUI, it's still part of assisting conception. And then if you're doing IVF, and also our center, we have an institute. We can send embryologists to, if you need, to just even see what you're doing or to initiate it and things like that. So feel free to, so that we can have a complete story for Africa. I think I'm quite impressed. Thank you all.
Thank you, Professor Ashiru. So,
Gonna leave.
you would like to take any questions?
Sure.
I'll just
yeah,
ask.
but, I have to have a pickup at 8:30, haven't even packed.
Just have a seat for 2 minutes. I'll ask for
Yeah,
questions.
sure,
for you
yeah.
first. All right, all right. So first things first, do we have any questions here for Professor Simpson? He's got to leave early. Excuse me, silence please. Do we have any questions for Professor Simpson? We are going to take only one question for Professor Simpson. Anybody? Because he'll be leaving us early. Oh, here there is a question. Please.
Professor, my regards, warm regards to you. You and me are not differing. We are on the same page. Just we needed to, I meant that we need to have an individualized approach. And we know that even the endometrium can fail the euploid embryos.
I missed the question. There's a good bit of noise in the room. So was that a question or a comment? Oh, it's a comment. Okay. You could, I think we got a question on the second row.
Yes, Prof. I've always wanted to ask, does pre-implantation genetic testing for aneuploidies have any role? Does it improve pregnancy outcomes?
Yeah, that's a
especially in the
misconception. It's not intended to improve the outcome because we can't, PGT test per se doesn't make for a better embryo. What it does is make for better selection. So if we know that a significant number of blastocysts, for example, or anything is not going to result in a sustained pregnancy and a take-home baby, then we would wish to avoid this. The PGT A and PGT M are no different than what we've been doing in genetics for 30 to 50 years. We're looking at those situations in which we cannot expect to have a normal outcome or sometimes any deliverable outcome for the couples in front of us. And we are suggesting let's move to something else. It's also the same thing that we have in medicine. You know, if we have treatment, if we have cardiac conditions or anything of that sort, you know, we can do nothing and hope for the best, or we can go to a physician that can provide care for us in a manageable situation or so. So this is different. There's nothing special about PGTA or PGTM. We are simply involved in selection. So that's the word to use. Oh, questions over here.
I already have the mic, sorry. Okay, yeah. No, just a, yes, no, just a comment, and also to go by his question earlier. I think the main role of PGTA is more of shortening the latency to pregnancy because we have good selection of the embryo, and also it gives us the confidence to do more single embryo transfers. I think that's the bottom line with the increasing use of PGTA.
Excuse me, I prefer to speak in French because my English is not very, very poor.
Well,
Somebody, can you help me now? Come on, yeah. Officiel traducteur. OK. Yeah. Permettez-moi de m'exprimer en français. Permettez-moi de m'exprimer en français.
I would like to use French now.
Parce que nous sommes de différents pays, aussi bien anglophones que francophones.
Because we are coming from different countries who are speaking French than English.
Et nous avons hérité des différentes orientations de la colonisation.
Because we have inherited different attitude from our colonization.
Et notre formation, what do you say? Yeah, I tried to, let me finish this. Oh, have you any problem? OK, let's go. Donc, on a hérité des différentes situations de colonisation et notre approche anglophone, l'approche anglophone est différente de l'approche francophone.
Because we know French-speaking countries and English-speaking countries, the way they do things are different.
Yeah. Maintenant, qu'est-ce que, en dehors bien évidemment de professeur Achirou, que nous connaissons très bien, qu'est-ce que, en tant qu'Américain, qu'est-ce que vous pouviez faire pour nous aider dans les pays francophones en matière de prise en charge de l'infertilité?
So, as a USA citizen, what are you planning to do for French countries speaking to improve ART in those countries?
Well,
that is my question.
Go ahead. Okay.
Well, I think a translator needs to return to follow up here.
Translate the question in short.
Okay.
Can you please translate the question in short?
So first of all, think that people in America, especially physicians, especially many governmental individuals, are more cognizant of the differences in the countries than what you might imagine. I'll tell you a story, you know, and with the very famous French geneticist whom I spent time with in New York City when I was training. So I was a mentee among one of the best.
Donc, je vais vous parler une histoire qui a rapport avec ce qui se passe, a rapport avec les pays francophones.
So this individual is the discoverer. I won't mention his name, but you could probably deduce it. You know, he, in terms of explaining and doing the first to cytogenetically determine the phenotype of individuals with chromosomal abnormalities.
So, la personne en question a fait le tout pour trouver des anomalies génétiques à rapport à ce que nous faisons en matière de la science.
So I was a resident at the New York Hospital in New York City.
So, à cette époque, la personne en question était dans la ville de New York.
this very famous individual visited the lab of my mentor, who was just a few blocks away.
La personne en question a visité mon laboratoire là-bas.
So this was about the time that amniocentesis came around.
Sorry?
This is about the time that amniocentesis to detect chromosomal abnormalities in utero was feasible.
So, à cette époque-là, c'était pour changer à ce qui concerne comment analyser les chromosomes de l'autre côté.
So as a OBGYN physician, very excited about this area, I mentioned it to this very famous man.
So, l'homme en question était très intéressé parce que à cette époque-là, les gynécologues étaient intéressés par la spécialité.
And much to my surprise, his answer was amniocentesis is not necessary.
Mais j'ai été surpris par la réponse qu'il m'avait donnée en ce qu'on faisait.
I was bewildered. And then he saw the look on my face to that extent. And he said, we will treat this and it will not be necessary to do amniocentesis, and that in similar situations.
C'est-à-dire que ce que je faisais la miniosynthèse et puis il était étonné de me voir faire ça. Donc, il me voyait comme si je faisais des choses étranges.
He was quite brilliant. He knew exactly what was going to happen in the rest of the world, because he had been in the rest of the world, but he had to have a defense because it would not have been acceptable in Paris in 1975 when this occurred. It was 1965 when this occurred.
Ce qu'il voyait là-bas, il était excité de voir ça, mais il se demandait comment est-ce qu'il va pratiquer ça de retour dans son pays parce qu'il fait la synthèse, probablement que ce n'est pas acceptable en France.
Now, of course, the world has changed quite a bit since 1965 until right now. But at the bottom line, we all deal with patients.
Mais le monde a changé beaucoup ces derniers temps avec la patience.
Patients are not homogeneous anywhere. I have been in medical schools in 5 different places in America. I've mentioned, at the panel that Oladapa ran the other day, that I have a lot of experience in philanthropic organizations. None of them are homogeneous. And I think at the bottom of the line, we deal with patients. We need to, they need to understand what the options are. And we don't dictate procedures of the type that we've alluded to. We don't dictate that you have to have in vitro fertilization, even if you're fertile, to transfer an embryo. We simply need to present the options that exist and support to the extent possible within the law and the legality in the population, whether this is consistent.
Donc, on ne dicte pas ce qu'on doit faire en matière d'assistance médicale à la procréation. L'essentiel est de parler, puis choisir ce qui est meilleur pour la population conformément à la loi.
I wish I were able to elaborate in French, but I don't.
Je souhaiterais vous expliquer ça en français, mais je ne pouvais pas. Merci.
Nous allons en parler après. Thank you.
We will try to exchange later after this meeting. Thank you.
Thank you so much. With full energy, he delivered 2 wonderful presentations today. All right. So do we have any other questions for any other speakers of ours, please? Yes. And your question is for Dr. Okai. Okay. Where's Dr. Bernard? Dr. Bernard? Yeah, please come.
Good afternoon, colleagues. My name is Dr. Mvola. I'm from Namibia. I'm just asking about the talk that you gave us.
Yes.
Regarding hypertension. Is something that is also, my interest is in reproductive medicine, but hypertension in pregnancy is also something close to my heart. I have a few comments and I just want you to comment on this. One is, we know that in literature, the incidence and the prevalence rate of hypertensive disorders in pregnancy is quoted to be around 10%. However, from our data that we did within our unit, it is way more than that.
Thank you, Professor Ashiru.
That's one.
Thank you.
And it will be very interesting to hear from the rest of the team here, whether they also share the same sentiments. I'm of the opinion that this data is European based, where we also know that it's not a problem in those countries. If you look at the Embrace report in the UK, preeclampsia is almost non-existent as part of their problem. And I think it's something that perhaps we really need to do more, and we really need to put out and really get there. I just want your comment on that. The second one is with regards to the timing of pregnancy. Yes, it would be interesting if you can just highlight which country is those recommendations that you quoted where it says that if you make a diagnosis of preeclampsia, you can manage expectantly up to 37 weeks. Because I just wanted to highlight a few issues, and that is also the guidelines that we use mostly in the Southern Africa, specifically talking about Namibia where we practice, and also in South Africa. If you look at the data regarding the timing of pregnancy, and there is a Merck trial which told us that if you do expectant versus immediate delivery, expectant, there is no difference. However, we prevent outcomes, especially with maternal morbidity from acute severe hypertension and also perinatal. I just want your comment on that, whether as a result for us, based on that data, if a woman comes with with preeclampsia with severe features, we do immediate delivery at least within 48 hours after we gave steroids. And that is our standard of practice both in Namibia and also the South African guidelines. I just want your comment on that. And then the other one is now the patients.
So let me answer them. Otherwise,
okay, all right. Then there's just a follow-up, last one. Okay.
Can we pull up my slides, or it will be very difficult?
Yeah.
Slides? Yes. It will be very difficult. So with the very first question, I think the challenge is really just as Prof was mentioning, Africa doesn't add its data to the global population one. Yes. So there have been meta-analysis, a lot of things. We understand that outside, it's a big problem. But in our side of Africa, even though we are recording more, in my unit, for instance, Pomfanoche, it's actually the leading cause of admission. But when we put all those things together, the contribution from Africa is low, and you can only report what is known, statistically known. So even on my notes, under the sub-note, I had made mention of how high it is in my country. But then do we report to the international bodies? So that's actually the challenge we face. So we should be writing more, we should be putting our cases out there so that when people sit down and are doing meta-analysis, thematic reviews, they can pull these things and then maybe the figures would change. But as it is now, most of these things are quoting up to 10%, which with little or no contribution from probably sub-Saharan Africa. Okay. Then your second question was on the timing of delivery.
Yes.
So there was a particular difference between with severe features and without severe features. So we're talking with regards to the 37 weeks, it was more without severe features.
And I was coming to that. That was the second part of my question.
I'm coming. And with those that are delivered at 34 weeks, we even stratified those that would need immediate delivery. And so obviously, if you're having an abruptio placentae, you're having an acute AI, you are having somebody who has fitted, you are not going to do expectant conservative management for the patient. This is what we do in Ghana. Yes. So what we do in Ghana is that barring any end organ damage, if you just diagnose what we previously called mild preeclampsia, which now has been changed to preeclampsia without severe features, we believe that for a countrywide population, I mean, when you find yourself in a teaching hospital, delivery may be immediate, but then we have a lot of places where we are also balancing managing the baby in utero where they lack NICU services and all those things and problem with referrals. So barring no end organ damage, you can push it as far as 37. Afterwards, we don't think there's any benefits from our end. But if you're also going through, I always kept insisting that the guiding principle should always be your local protocol. And so these are just something for the general audience. But when it comes to preeclampsia management, these peculiarities stick to your local protocol.
Okay, no, then I think if you stick to that, that is fair enough. Okay, say local.
Thank you so much for your response, Dr. Bernard. Thank you. we have time only for one last small question. Do we have any questions? Any more? You? Anyone, please. We are taking this. Okay.
Thank you,
Your
Chair.
question is for?
My question is for Dr. Chandra.
Dr. Chandra. I'm sorry, Dr. Vipin Chandra is not around in the hall. I'm so sorry. Maybe I can help you connect with him in the networking session after this. I will take up your question with him personally. Yes, please. Pass the mic to him. Your question is for?
I think he's also left, Dr. Phineas.
Dr. Phineas, are you here in the hall? No.
He's there.
No, you will have to connect with him one-on-one. Thank you so much. So with that, we close the Q&A session. And now on behalf of Merck Foundation, I would like to conclude this wonderful session with a vote of thanks to all our speakers, panelists, and attendees for joining us today and making this knowledgeable session a huge success. We look forward to meeting you all again for more knowledge sharing and great learning opportunities in the future. Please be reminded once again to visit our website, merck-foundation.com, and download the Merck Foundation application from the Play Store or the App Store to stay updated about the various courses available and path-breaking initiatives undertaken by Merck Foundation. Last but not the least, two important announcements that I want to make for you. First is about your certificates. Your certificates are right here on the table. For the speakers, we will self-distribute them, speakers and panelists. And for the attendees, we request you, we will call out your names and you can come in alphabetical order of your first names to collect your certificates in an organized manner. Okay. And the last announcement is that after you collect your certificates and gradually leave the hall, you are requested to go and assemble near the pool side on the ground floor for a group photo and networking session if you like. Okay. Thank you.
Yeah, thank you to Professor Chandra. I'm Dr. Hilary Aheisibwe. I work with the NeoCare Specialized Hospital and Fertility Center in Uganda. It's the first center in Uganda outside the capital, Kampala. So my question specifically is in your daily practice for patients who have had recurrent implantation failure, whom you have done hysteroscopy, assessed and found that the uterus is favorable, the ultrasound scan during the monitoring process is normal. What you hinted on various treatments, including steroids, progestins, low molecular weight heparins, that one can use. I just wanted to know, in your practice, in your daily practice, what are you doing post-embryo transfer for these patients to increase their chances of a positive pregnancy test? Thank you.
Yeah, we whatever morning I told you guys, same thing we are performing, and it's very standard process and laid down by us. There isn't a proper SOP for us. What we have to do if one cycle is failed, what we have to do if two cycle failed, what we have to do if three cycle fail, and so and so. So it's not so that whatever in the morning I told, we are practicing almost everything. We are practicing that there should be a laser assisted hatching, there should be blast culture, there should be freezing, there should be down regulation in adenomyosis cases, there should be testing for immunological test if one failed. Hysteroscopy, laparoscopy, definitely yes. Once, if after minimum hysteroscopy, if one failed, if two failed, many laparoscopy has to be done to assess and evaluate the the environment around peritoneal causes and all. So everything has to be done. Now, coming to the luteal phase support, when I say when somebody has done and somebody has put in so much of money, why not give extra support over there? So still I believe, though there are Cochrane says not much in the direct evidences in the support of LMWH and steroids, but I still believe we have seen results and with the support of LMWH, prophylactic 40 milligram per day subcutaneously, steroids, methylprednisolone, 10 milligram TDS starting from the day of transfer, going up to the, and then tapering off and stopping by 12 week. And we also use HCQ 400 milligram once daily to give passive immunomodulations. Along with the steroids, IVIG and intralipid also we give, but only once the patient has been failed minimum 2 times. So these are the minimum requirements we do. We have a set of protocols for each and every patient. It's not like me, I can do different from the my counterpart. We have almost 300 plus doctors serving to at around 150 plus clinics. So I set the protocols for them. They have to abide with that, and we have seen a good results. So it's not so that result cannot be good outcome cannot be given to such kind of a patient. As in the morning, I said the maximum number of failure patient which I have treated is a 23 IVF failure. So we have a lot of such good stories where patient have failed more than 10 times, and so came to us because Indra IVF is considered as a referral center in India. So they most of the patient who come to us, they already have 1 or 2 failures. So we are kind of seeing such a kind of a patient a lot, and we have set protocols. Yeah.
Thank you.
Thank you so much, sir. I hope that closes the Q&A session for us. And,
Dr. Shabad, one
yes. Sure, sir,
comment I
yes.
want to make.
Yes, please.
Since morning, I heard a lot of dreams, a lot of good stories. But one point is, though we are jointly you with us, giving a lot of training, and people are coming out and staying with us 3 months out of their country, out of their family man. But when they come back, I still feel lot many people are struggling to give up that kind of utilizing that much training proficiently. So I think we should again build up a one common group, focus group, which I discussed yesterday also. One focus group should be there who can handle these guys and take them to a next level so that they can feel confident. They can reach out to the experts whenever feel like that this is a difficult case. I'm facing difficulty in diagnosing this case. What next to be done? What management should be planned for these? So that hand-holding group can be beneficial to them, so that gradually they will start taking their own independent decisions. That's what my
Absolutely. That's a wonderful suggestion. We appreciate it. And we can definitely work towards this idea of mentorship program for them. Definitely, we will bring that up. Thank you so much for your suggestion, sir.